Please do start, sir.
A very good morning to you all, my respected teachers, as my seniors, dear colleague, and moderators. And thanks, Footballer, and giving me the opportunity actually. I don't know, it's most probably I value for this forum. So that I have asked me that is what talk you are going to give. So I propose from my side that let's have a kind of instructional course so that we'll cover the whole program. And initially I was about to give a solo kind of presentation, but then I thought that let's have a two guys with me because they need more nowadays. They're doing a good work and they are the future of for the knowledge. And they are really good work, and particularly the authority. So that's why I pick up Abhinav. I love his hand, seriously. And also the Rohan is also very much interested to go through the subject, to read, allow the busy all of his management also. So let's make a kind of interactive session. And we have scheduled that I have given us allowed 1 hour moderators. I don't know, 1 hour mostly. I'll try to finish in the 45 minutes. So let's start. So why city temporal bone? And these are mostly we are going to next cover the next 45 minutes. Why city temporal bone? Number one, to identify anatomy, operative planning, risk management, and most importantly nowadays the informed consent. So most probably, how many of we will advise city temporal bone in the first section? There is no active research. The past AOSOM case, so most people will not know other complications, then will not go for any kind of city temporal bone. But what about this? What about this? How many of we prescribe for city temporal bone? This case, suppose 52 years lady. There's no active research, but with a hard of hearing. So I think in that scenario, audiometry may have a upfront rule that if you have this much of loss, basically the AB gap, then definitely will go for CT, because it is not for the what the finding we are getting also important for the counseling the patient, that this amount of tympanosclerosis and there may be chances of ossicular erosion or more tympanosclerosis involving, then he may lose more hearing after the surgery also. That's very important. So I can
yes, I want to interrupt you. So you are saying that you will advise CT in this tympanostetic patch. So how much the CT is going to help you? Yeah. How much your radiologist or you yourself will be able to read the CT as far as ossicular the continuity or whatever is concerned?
That's why I come later on. So that's why you prescribe the CT like non-obvious finding like cholestoma, non-granulomatous disease. That's what you're going to expect. So in that case, if you have a suppose AB gap of more than 16, forget about the tympanosclerosis or ossicular finding. Then that needs helps basically the ossicular status mostly. So if there's that's why we go when we read the normal CTs and mostly incus is not the incus is eroded. It is not a one-point structure. It has a structure. It has the full structure. Similarly, Melias, it's not the only one bone, only one point. It's a whole bone. So that's why you know how much loss you have if you go for a very high resolution CT scan actually.
Your this first photograph, according to Scotland, is an inactive there. Inactive, but
COM.
Yes. Sure.
Nowadays they don't use the safe and unsafe. COM.
उसको आमा से लिखो है.
Yes, sir. Remote clinic or
No,
Mucoid and squamous. Exactly, sir. So most probably this will come, the second picture will come in a squamous variety, am I right, sir? This will come in a
This is
squamous.
one question, right?
So most probably we're not going to finish for you. Okay, this is good.
This picture shows a maringo sclerosis. So I think your CT will tell you about tympanosclerotic patch. I think the inguinal joint fixation, what you want to see, whether fixation in the inguinal joint.
CT can guide me tympanosclerosis, like sclerosis.
Whether you want to see that inguinal joint fixation by the tympanosclerotic
Dynamicity you can't appreciate. Dynamicity is very difficult to appreciate, like in the laryngeal CT, where you can appreciate the vocal cord pulsing. They have a few maneuver.
So what I understand
like in the
is
buccal mucosa growth also, they have a sick puff maneuver. It's very interesting.
So you want to see the
puff sick maneuver. But it's in aero also, you have a tracheomalacia, you have a dynamic CT evaluation. This is a very interesting point. I have learned it now only. So, but I don't think it's a very valid question from Hong. Can you do that physiological evaluation with the CT?
No, what are the points actually you want to see from the CT?
Basically, I want to look at ossicular status.
Ossicular status. Whether it
Whether
is
it goes on this discontinuity kind of thing.
But the biggest point is your CT is not going to pick up a lenticular process erosion. Suppose you have a very 1 millimeter gap between the stapes head, like I showed yesterday, and the incus down process. That is not going to be picked up by your HRCT.
Definitely, sir. But if you go for 4 mm, some information, at least like a incus.
I mean, if I were to argue with you, say instead of spending 5,000, why don't I do that? Raise the tympanomeatal flap, tell the patient that I'm going to do exploratory tympanotomy and then take a call. Because there might be inguinal joint fixation also because of tympanosclerosis.
But it is same how is it arguing the otosclerosis also. It is not the aberrant vessels. If you say, it is also they are doing it for otosclerotic foci also. It is not the persistent stable artery. Nowadays they are doing also.
So I think you will get from the CT is your condition of your meningeal mucosa. Polypoidal mucosa, any.
But you see, the endoscopic finding that is not as such mucosa, it's very dry, inactive air.
About the blockage of the editors also you will get.
Also, the other associated comorbid condition you can also know from.
Moreover, if there is low line dura forward the sign after everything will come.
I'm particularly, but nobody has argued regarding the acquisition of CT on this kind of scenario. Yes, everyone 100% they will question, but on the other hand, if we are doing it does not necessarily CT these cases also. Anyway, no argument. So let's be more CT. So, but how to prepare as it is? I'll touch few points. And very important for the children, basically we are prescribed for cochlear implant and kind of a conductive hearing loss in a pediatric age group for to rule out a congenital cholestoma and all these things. And don't see the education in adult. And the positioning in the CT is always a supine. And MRI is always the sequences.
How do you put the children in the MRI? With the mother?
Children definitely.
No, actually with mother. Half mother and
always,
children like this.
always. Yeah, nowadays, so this is called concept of modular city.
Yes.
Modular city means you have the music, you have the view of the sky and all these things. Now the concept is like that.
Yes.
It's not like a mother. Everyone can have a tea and cough and go for a city. So modular city, mostly Rohan is coming in that way. So radiation hazard is very important for the children. I'll not go that, and this is a very big sir during the preparation of this city that's how they can, they can preserve the retina. So this is called gantry tilt. But when I review all my city during the presentation, I have not found nobody is doing this tilt. Very interesting. So this is the fallacy of all these things. That the technician at 9 o'clock, we have an appointment of the CT of some patient at 9 o'clock. The technician they have no idea of what to teach all these things. Then the senior person comes for a review or online. They have all the knowledge of this, but they are not doing all these things. So it is very important to have a checklist. This is the position, should be the radiation hazards and all these things. If suppose any previous city also, you have to ask the children. If there was 3 cities already done in last 6 months, it is a criminal act by you to prescribe the 4th city. because that much you have the radiation hazard, because that formulas are there, how much radiation, these are very important along with within the city. So that's why I'm giving emphasis on all the radiation hazard. So few kilometers we know that how much slice of city nowadays in Guwahati also is more slice cities are coming. That means you have more cuts, more resolution. I'll not go for all these things, but for temporal bone it is a 14.6 mm of this slice thickness basically. And if you see the temporal CTPNS study by Satish, and in most of the workshop he has mostly 4.6. He always prescribed him temporal bone slices. So he will more, but that will be more radiation hazards also. So this is the, I'll go later on, but windows. Ranjan has submitted what the window you prefer for city temporal bone. So what is the window actually? It's a kind of a grayness. What is the unit of distance?
House feeling.
So house feeling unit that way. If you have a, I have not. So you have a, if you're born into, preferably to look at in the city, the bone structure, and that way you can delineate the bones. And next part is how to read city temporal bone. Either you can go with a film or either board software. These are the two software available, Radian or Swix. And please, the juniors, please, they are also freely available if you don't buy it also. But you have advantage of if you purchase it. So I invite Dr. Rohan to go for a normal city temporal bone, how we do study. So before Rohan, just I'll give a brief of the ICON software. You see, this is the software. This is not a folder. So you have a horizontal bar, and this is a template of the software. Then if you see, so for Mohammed presentation, I have a disk. So I am coming with this patient for this Mohammed. Any question may come, any folder may require, so I am coming prepared with it. And most important is that I have a note here. You can appreciate that for which city, what is there. Suppose here. This is very important. You can put a note. The cellular says limited cholesterol, LS fistula. So that way, if you go for presentation in outside, also that also help. It does not bring down all the things. So you can go it in that way. And you see, this is an import file. You can import any folder like this. You can import, and it will be online because it's very easy to carry out all this data. So you can export images. You can print here. You can do adjustment of the window, like just a minute. That's what the things. Suppose that's why it's city. So I can change the window here. I can change the window here, like just this window. I can change the window. Can you appreciate? Then I can say that. So these things, what the template thing you have to know. In that way you can play more with the doctor software. This is the horizontal and this is the profile of the picture, and then you can, and why the ICON is important. Can you appreciate how many CT scan is here? 231 slices available here. 231 slices available here from here to here. Can you imagine this patient is coming to review to me at 231 cuts? So if I have if there is a 15 CT in my this laptop and 15 into, you can imagine somewhere there is a 451. So he is coming with a they have to come with a track. So this is very important to every cut, every things you can go with. Now it is very beautiful as we have prepared this presentation now mobile. This ICON is also available. So it does not require laptop also to carry on this 400, 200 slice of CD. That's why how much we involved with the software. We are using for the last 5 years. So we are learning every day. Every talk I am going to present, I have learned a new thing. So I am giving to Rohan, and this is the one way of Hari. presentation. And another is suppose what Satish Sai is the editor, he doesn't go with a dead stack. He loves to prefer, suppose this is a apex cholestoma. So he has a CT folder, one surgery folder and everything here. So suppose he opened the he opened the distance, this folder. So when you open this folder, there is both CT and MRI. There is both CT and MRI. So in the same folder, he has a MRI. In the same folder, he has a CT. Suppose he wants to compare the both, then he takes. Suppose I'm just supposed to be CT. So I'm taking one cut. This is CT. This is CT. Next I want to see the same sequence the MRI. Suppose we have a T2 MRI, and T2. So you can appreciate there is a erosion of the sigmoid plate, but we don't know after that. We can only appreciate the erosion of the bony wall, but we can't enforce it as a soft tissue. So when you go for MRI, then you can know that this it may be cholestoma is something else beyond the bony erosion. That's how we can correlate all the sequences. In MRI also, you can suppose you want to MRI, you have a tree. The third sequence, suppose T1, where T1, suppose you want to T1. So in that way, you can have, and if you share these sequences, just say screenshot and share with a counselor. So he'll have all the sequences, or you export the image. That's how the beauty of the play with the software. It's a very beautiful thing. It's a very easy thing. Just invest hardly 1 month. Hardly 1 month. You have all these things, seriously speaking. Now, I'm giving the laptop to Rohan. Please, Rohan, start from the start. So here you go with the normal CT, how we did. Sorry, because time we are not going for entire yet. We will meditate the topic of cholesterol. Now he is doing a normal study and was long enough to take a case of cholesterol.
Good morning, everyone. Today I am going to demonstrate how to read a normal CT scan using a radiant dicom reader. So this is the axial cut of the normal extraCT temporal bone. So I am going to read the CT scan from inferior to superior. So if we go from inferiorly, so the first three structure we'll see is the ramus of the mandible, this is the styloid process, and this is the mastoid teeth. If we go up, you can see the pneumatization of the mastoid, which is not properly pneumatized. This is a sclerotic mastoid. You can see the styloid bone. This is the head of the mandible. If you go up, you can see the EAC. This is the continuous part and this is the bony part. And here you can see the jugular bulb, and here is the vertical part of the internal carotid artery. If you go up, you can see two foramen here. This is the foramen ovale and this is the foramen spinosum. This is the vertical portion of the internal carotid artery. If you go up, you can see the carotid artery is starting at its first end and is becoming the horizontal segment. And this is the eustachian tube. If you go up, you can see this is the promontory, and the first inner ear structure is the basal turn of cochlea. If you go up, you can see this is the tensor tympani muscle, and you can see the part of the middle turn of cochlea, and this is the cochlear aqueduct. this is the round window, and this is the round. If you go up, you can see two ossicles coming into the view. This is the long process of the malleus, and this is the long process of the incus. This is the mesotympanic part of the middle ear. If you go up, you can see the semicircular, posterior semicircular canal is coming into the view. You can see the tensor tympani tendon. It's at the processus cochlear starting to the to attach the handle of the malleus. If you go up, you can see in the posterior part of the middle ear, there is the lenticular process of the incus, and this is the stapes, and you can see the area of the oval window. And this W, it's the sinus tympani. This is the pyramidal eminence, and this is the facial recess. This is the sinus tympani, and this is the sinus tympani, pyramidal eminence, and this is the facial recess. This is the part of the epitympanum. Here we can see this is the cock. We can appreciate the vestibule here, and this is the cochlear aperture, and this is the inferior vestibular nerve, and here is the cochlear nerve coming to the EAC through the cochlear aperture. If you go up, we can see the ice cream cone appearance. This is the head of the malleus, and cone is formed by the body of the incus and short process of the incus. This is a corner septum here. We can appreciate the vestibule, and this is the typical signaling appearance of the lateral semicircular canal. Here we can appreciate the facial nerve. This is the labridal portion of the facial nerve. This is the bulbic appearance, turning into the genicular ganglion and becoming the horizontal part of the facial nerve. If we go up, we can superior semicircular canal. Now I am going to show the coronary section. If I am going from anterior to posterior, the first structure will see the TM joint. Then the next structure I have to see the EAC. Then this is the tympanic membrane. This is the sputum here. This is the anterior malleolar ligament, and this is the lateral malleolar ligament. I can see the cochlear turns here, and this is the facial nerve. This is the snake sign appearance. This is the tympanic segment, and this is the labyrinthine part of the facial nerve. If we go posteriorly, the internal ear is giving a marmot sign appearance. The tail is formed by the basal tongue of the cochlea. The body is formed by the vestibule, and this is the lateral semicircular canal, and this is superior semicircular canal. Now, if we go posteriorly, we can see the round window opening into the middle ear. This is the semicircular canal. If we go posteriorly, this is the posterior semicircular canal.
Thanks, Rohan. This is very beautifully how he has demonstrated how we did the normal CT. And thanks, Rohan, for inviting my proposal. But anyway, another way of Actually, I prefer to go just, I'll 2 minutes quickly. Yeah. Suppose, as Rohan says, I prefer to go not from down, I always come from above to below. And this is where you can magnify a little bit, this I am coming. And you can appreciate the skull bone, the temporal squamous junction, and then you can have a see the suture line. Then you can, the mastoid cells are appearing, pinna is appearing. Then the first thing is a 2 dots of the superior semicircular canal. Number 1. You see what the interesting question here. This city is not in a alignment. This is tilted. Number 2.
From your CI point of view, at this point you can also mention about the skull.
Exactly. Since I am not a CIT, that's why. Because once I say, hello, once I say that this skull thickness you can measure. This is a measurement tool. You can measure the skull thickness. Since the implant edge is coming down, so this very early children have a very thin skull bone. So you have to choose the implant. What implant? You need a thin implant. It's not a mutable implant. If you give a mutable implant, because the skull bone is very less, then there will be complication will arise. So the first thing what I should do, this is tilting. I don't know if you can't finish. I will give 10 minutes. This is tilting. So how it is possible? That's why the position tilting is very important. Can you align here this city? Is it possible? It's possible. Now, but look, whatever possible is original is always better. Again, I am going with this. I does not require this. I need this. But how can you can see the tilting like this way? Like you can align. You can see. You can. I am just with this axis. I am trying to align both the ISA, but still it is difficult. Can you appreciate? It's very difficult. This is how we can sometimes give a little tilt to the plate. And after that, we can appreciate it semicircular canal. Again, this becomes a 2 dot, then this is the ISC. Again, how you know how it is? This can still not a little bit of good tilt, normalized plane, because how will you know it's more normalized plane? Because you can appreciate the full circle of the semicircular plane in a one go. You can appreciate the full. That is the isotope pairs. So as these are already mentioned by Rohan, but Rohan has not mentioned here where is the facial now. So let's start study this diagram file as a dynamic study. It's a facial fallopian canal. It has a course. So you study the fallopian canal as a course. So either it come from below or either it come from above. So let's study the course. How? Where is the facial dot? Can anybody tell where is the facial? Which one? This dot, this dot, this dot, this dot, this dot. Which one? Which one is facial? Any idea how you know? Rohan, how you know? Which one is facial? On that you can tell most probably. Which one? You forget the beginning yesterday thing. You go to the other section. Just you go to the other section. That's the beauty of the software. Because suppose you don't know. But you can appreciate here. So this may be facial. This is sure facial, sir. Am I wrong? This is the course of the vertical portion of the facial. So you see the dot here. So this is the dot of the. So isko bhaga do. Let's take this in middle. So I know this dot is facial. This ko छोड़ना नहीं है आपको. So go up. You see the cursor is moving. It's going up or down. I'm going up. I'm not removing the cursor. So you see, then it becomes a horizontal. That is the second thing. That's why you can read the dynamic way. It is not a facial now. Then you know which portion the dehiscence. From how much it's dehiscence. So if you don't read this, this was no. So how much is dehiscence? So if you can take this, then it becomes horizontal, then it becomes the horizontal, and this becomes horizontal fallopian canal. Full course. Am I right, Mukherjee sir? So it's going beautifully. Then you see, this is the second bit, and this is the labial portion that's coming back. That's how we can give the dynamic, full dynamic course of the facial nerve. And I invite now, I think Mutamoti, the normal study, how will you read, and there's a two special class I'll come later on under the cholesterol. I invite Avinav, go for the cholesterol. How you read? Why? Depends on the nut. Please, Avinav.
Everything has already been mentioned by Rohan and Sri sir. So I'll just zoom in first. So let's just look at the CT and the problem on the right. The patient has I should remind you I'm a bit slow in this because Vijay sir has continuously forced me to read the CT scan again and again, so I have started reading. So just let's have a look. So this is the axial cut, and coming from above.
Can you reduce the magnification a little less? Because it is becoming a little large because it is highly magnified.
This also, sir.
Yeah, definitely. We have both the sides.
So here we are coming from above downwards. You can see that slight tilt is there when we are comparing both sides, and here we can see that the superior semicircular canal is there, and there we in CT when we are trying to read a CT of a temporal bone for cholesteatoma, we need to just follow a few steps. We know the normal CT normal anatomy, but we also need to, in a cholesteatoma, we need to see what are the points we need to see. First and foremost, any tissue, any soft tissue which is present in and around the mastoid. What is the extent of the soft tissue? So from here we can see that there is a soft tissue mass, there is no air in the mastoid air cells. And here we can see that if we compare to the other side, this is a highly pneumatized mastoid and this is a highly sclerosed mastoid. There are no air cells at all. So those air cells have been completely taken up by this soft tissue density. We don't know what this soft tissue is till now. So we can see that the whole of this area, the middle ear and the mastoid area is completely involved in this soft tissue. What we can also appreciate now is that we know all these, the normal anatomy of these structures has been showed by Rohan. What we will try to see is the extent. We will try to see the extent of the disease. So the first is the extent of the soft tissue. What we know now is the soft tissue is extending all over the mastoid, middle ear, whatever cells are there in the mastoid. Then second is what we want to see, what are the structures that it might have destroyed, or what are the structures usually a cholesteatoma destroys. So when we so here, if we see, we can see the eustachian tube. Now the thing is that maybe the eustachian, there is some cholesteatoma inside the eustachian tube, but there is a lesser chance of the cholesteatoma and higher chance of it being mucosal edema, because there is a small air pocket here. So we think that yes, so this is not cholesteatoma which has gone into the eustachian tube. This is just the mucosal edema of the eustachian tube. Second, we see the status of the ossicles. Till now, we have not seen a single ossicle because they have all been eroded. Again, we can see that the external auditory canal has started to appear now. Yes, and we can also see the jugular bulb. The jugular bulb is important here because we need to see if there is any erosion of the jugular bulb because we will be operating in the middle ear area. Another thing we can see is the status of the vestibule, whether any erosion or dehiscence has been there in the semicircular canals. So, if we see here, we can start to appreciate the signet ring kind of, which is supposed to be there in the normal CT scan, suggesting the lateral semicircular canal. But if we go slightly, yes, so here we can see there is a dehiscence. There is a dehiscence in the lateral semicircular canal. So in this case, we will see there will be dehiscence in the lateral semicircular canal. Another thing is the facial nerve. Now it is very difficult to analyze the facial nerve in this kind of cases because we hardly can differentiate it from the cholesteatoma. So let's just how do we zoom this in? Yes, only one. Yes, only this. Yes. So here we can see the facial nerve which is coming out of the stylomastoid foramen here, and we see that the facial canal is intact in the mastoid segment. Yes. So what else do we see? Any other positive findings that tympanic segment? We'll just try to find it in this. So the round window niche and
Can you stop there?
Just one now.
yes.
What is this structure?
This one. This one is the Vicentron of cochlea, and here
Can you go up a little bit or go down? Because there seems to be a body erosion between the structure and the mastoid. Can you go down this?
this is the round window niche, sir. So this one, yes.
Hey,
Oh.
stop there.
Just one now.
Stop there. What I want to this one. This one.
Yes, yes. So, exact thought point. How do you know this is the letters? As Abhinav was saying, you are not seeing the signature, number one, in Excel plan. Let's see what is happening in the other plan. So that's how we can know difference. It's the letter service applicant or not, because Mukhalisa is not happy. So where there's no, sir, this here, no? Here, no? You are not happy here? Yeah. So let's bring this cursor here. What I am doing? Let's bring this cursor here. Now you see. Now I does not require this thing. Let's go how. Let's increase it. Very gently. Now you examine. Just have a look. This letter some set like a zero there. So that's the beauty of going through the software. These are letters and set like it's eroded. So I'm happy that luckily yesterday because of Anjana visit, I retrieved this surgical part also. It is one. The same case, then same way we have appreciate. And now, sir, this is just now I am showing, and this is the fistula. This is the fistula. This is the fistula. This is the fistula. So, according to Vijay sir, you should do this every time fistula work last part. Take care, don't remove the cholesterol from that area. Everything, including temporalis, placement of the temporalis fossa also. Then, but that was not my planning day, because before that day, and most probably if I do now, I'll not do this thing now. Now you can see when I put a cartilage, there is a conduction out.
Why? Why should you do it in the last? The reason is, you keep the matrix, remove everything, because if you remove the matrix earlier, the membranous labyrinth is intact. It is only the bony labyrinth which has been eroded. You might accidentally put your suction or something and cause a fistula in that process.
Everybody is hard to affect in this case. In this case, everybody is hard to affect.
Yes.
No,
The patient is coming with that only. So sometimes I have a particular battle when I try to clean and try to.
hyperacousis.
Yeah, exactly, sir. Exactly. He is a known patient to us. But anyway, disease can be all these things that I come in different cuts. When you go back, the particular is junior, what a different cuts gives you, snapshot and you can take this, what a different structure you can see in a different cuts. This is the two special that I am going to mostly, Stenvers and fossils. These are more important in the particular perspective also, not only for cholesterol perspective, fossils and Stenvers. So just a minute. So basically, before that, I'm going to just perspective of cholesterol, what we can know about the etiology. We can know that it is extension, and also we know the complications, the things. So I think, oh, sorry, the last part we have now. So process view, basically, how do you do process view? First, if I allow me for the last part for 5 minutes only, because the new innovation by you, how we now the navigation. We are going to tell on navigation, no? But before that, I want to sort of for this one. Process view and Stenvers view. Why Stenvers view is important? Why is Stenvers? It is such a beautiful view. It is such a beautiful view where so when Stenvers view is basically there's a many prototype here. So I remove this and take this. So basically, its other name is big modular view also. So I am coming from above. So we have seen the two dots of the. superior semicircular canal. It's okay. These are two cuts. One is axial, one is a corneal cut. So these are two dots. Now I am going for transverse view. Always give a, if you don't read also the diagram, always give, sir, am I eligible for 5 minutes? Another 5 minutes. So how your spectrophotometry is made? You see that one is a red, one is a blue. So make this red axis in the alignment of ISC, or you can see the blue becomes a every align of the two dots. So this is the transverse view. Where is the transverse view? In the other cut. I am making the transverse view in the axial cut, but I am going to see the transverse view in a corneal cut. This is my manufacturing hub. This is a kitchen, axial cut. Though my table is in a corneal cut. So let's have a corneal cut. What is there? So I don't need a already. We have book. So you see what is the transverse view. It's a very beautiful view. So why is it a beautiful view? You can appreciate the round window. You can appreciate the oval window. You can appreciate the bezel turn, upper mid turn, all the turns of cochlea. You can appreciate the superior semicircular canal. You can appreciate the lateral semicircular canal. You can appreciate the mastoid teeth. Whole course of the dura from lateral to medial. Yes, sir. The lateral bone. So it's such a view. You can see the most of the course vertical and the horizontal course of the petus ICA, and you can see what is this? The face. This is above the cochlea. You can see this dot is also the facial. I can, and there's a break of time, I know how it is a facial. So it's such a beautiful cell, and it is very important from my personal experience from the cancer one case. If you see the colostoma may extend superior every time. How is superior every time? How is superior every time? Then you see there is a gap between this dura and this superior semicircular canal, and colostoma extending here. One of case of bicep. Very interesting. So that's why you know the superior levitan extension of the cell. So this is the view, standard view, that will give you the extension. What is process view? How do you make it break in the ISA? Now the process view. Again I have to go to kitchen. This is the kitchen is the axial, and I am coming up, up. Then I am making, last time for transverse view, I am making this blue line along the superior circular canal. I will make red line along the superior circular canal. This is a process view. This is possibly done.
What is the difference, red line, blue line?
This is the access side. Access. So now this is for particle person. Yes, you can appreciate the full course of the superior. So this is so that's why our anatomy is not a one point. It has a beginning and this is the end. So if you want to study from one point to the another, you need to maneuver, you have to cook your meal for the best flavor. So that's how you can appreciate the whole cost of superior canal. Yes, am I right? If any kind of dehiscence, if the dehiscence, because why the dehiscence is not what I am expecting. It's not one point. Dehiscence may be more posterior, dehiscence may be more anterior, dehiscence may be more lateral, dehiscence may be more medial. So it is not one point agenda. With that, most of the time, giving again for the last part of it, it's a great idea. When you're preparing it, this is the first time, because we know CTPNS, we always is a navigation tool for surgery, face surgery. But we have never imagined that CT temporal bone is a navigation tool for temporal bone. So he called me, this Dada, so can we have a scar in a patient position? What the patient is lying in the bed. Because corneal CTPNS is a cut for the surgeons, but can we have this cut? It's a great idea. I think we can carry forward from this day onward.
There is one question I am asking you. There is one case I got is superbone contraction and also the hyperacusis. I have asked for process view. They do not get it. Guwahati, who can do the process view and
So if you take a
to ask the city and give me. They can recommend to everyone. They will now give to everyone because this is very easy.
But they have told that there is no situation of the region. They have given the report.
Just last one.
But detail they do not give.
Social view is possible.
There I know, but therefore I am asking the particular direction.
So again, we'll just go through it very quickly. So what I thought was that what if we usually don't use the sagittal sections in our CT scans. So what if we just try to see the CT scan from a surgeon's point of view when the patient is lying on the bed. So what if we have the sagittal view and we rotate it? Yes. So right now the patient is lying down on the bed and we are looking at the pinna. So now when we have already taken up this patient for operation and now yes. So now if we go posteriorly, we go inside, we take off all the soft tissue and we are trying to open up the area which will give us the entry in, we can do the meatotomy. So we can see that this is the cartilaginous part and slowly the mastoid bone has started to appear. So once we see the zygomatic process, we know that this view is what we get when we have elevated the vulva flap and removed the subperiosteal layer and all. Again, so this is where we can see, can you appreciate this structure? This is most probably the spine of Henle. So from here, we enter into the ear. Okay, let's just leave the middle ear work for now. So we will start drilling from here. So once we drill, we go inside, we see the mastoid air cells and all these things. So we are drilling the cortical mastoid. We can see that slowly the tip cells have appeared and one more structure has appeared here. So this is the sinus, sigmoid sinus. We can also start to appreciate the dura here. So what I am trying to say here is we have seen all these things, same things in the coronal cuts and the axial cuts. So what I am trying to say here is if we measure, if we want to predict how far will the sigmoid sinus be or the dural plate be or the, because we have if we look here, we have this area and this is our triangle of attack, McEwen's triangle. We also, so we have started drilling from here. And as we go down, we have to, sometimes we feel that okay, the dura has come or the sigmoid sinus plate has come up. So if we know this, if we know the distance, then we can better predict this the appearance of a sinus plate or a dural plate in our cases. So this is the, we go further down, we are going towards the, we are trying to open up the antrum, we have almost reached the antrum, we have entered the antrum, this is the editus, this is the posterior wall of the in the external auditory canal.
Yes.
We can now start to appreciate some of the ossicle, this part of the ossicle, this is the incus. We can also see before that there is this is not the facial nerve. This is the chorda tympani. This is the chorda tympani. And just below it we will see the facial nerve. So and if you see this is our lateral semicircular canal. Completely we can correlate the findings which we read in our books that this is the marker for facial nerve. So the lateral semicircular canal has also appeared, and yes, we can even appreciate the whole of the chorda tympani. So the depth of the sinus, tympanic sinus, and all these things we can. I've just discovered it a few days back. Not discovered, many people are doing this, I know, but I'm just trying to find out some things. So regarding the measurements, how deep we will go, how can we measure the exact measurements so that we don't do any mistakes intraoperatively. That with practice and continuous pushing from Vishwajit sir, we'll just try to refine it better. And yeah, that's it. Thanks.
Thank you, and it's an excellent demonstration. This Abhinav Rohit. I think this city of the temporal bone is so necessary because we know what the anomalies are inside, what to expect inside. And I think it's no harm in doing a CT before doing any ear surgery because the surgeon actually knows what to expect when you open it. And I like your idea of excellent idea. And I think pretty sure what we are getting inside. How much we get to work between the posterior bony canal wall and the sinus. Most of the time in sclerotic mastoid we do not know where the sinus is, where the dura is, how deep will be the antrum. But this thing will clearly tell us like how much space we have to work in front of the sinus behind the posterior bony canal. It's an excellent idea. Any questions from the house?
If there are no more questions or comments, I think we'll close because we are already short of time. We are behind schedule. But let me appreciate these three musketeers. They have done a wonderful job of making all of us aware of the importance of revision. My earnest appeal, number one, when you get a CT of the temporal bone or of the PNS, don't read the report first. To the youngsters, maybe, don't read the report. Read the CT yourself. Read the CT yourself, then you see the report. Then you try to contradict or agree to what the radiologist has said. Right. Don't think the radiologist knows more than you. Number two, because he is not oriented as a surgeon. He is a radiologist who is only giving you the report whatever is in the plate. And most of us will not give him all the information that he needs. And then you communicate to him. Importance of the DICOM has been very nicely demonstrated today. Please, not only youngsters, all of us, even the elderly people can also play with the DICOM. It's like a video game. Once and you keep on asking the radiologist to supply you the CD every time. Because you can play with it and there are people to guide you if you are confused. Thank you. Thank you. I think in all our conferences, this CT reading should be a regular session. We should always have a regular session.
For your valuable insight on instructional course on CT temporal bone. Now, moving on to our felicitation part, I request Dr. Anjali Barua ma'am to please come forward to felicitate Dr. Vishwajit Gogoi with a memento and a certificate as a mark of our appreciation. Now I request Dr. Anjali Barua ma'am to felicitate our chairperson Dr. Kukut Gora ma'am with a certificate and a memento as a mark of our appreciation. Special thanks to Dr. Gautam Kam. Now I request Dr. Anjali Gora ma'am to felicitate Dr. Lohan Malla Borua, sir, with a memento and a certificate as a mark of our appreciation. Now I request Dr. Anjali Gora Dr. Abhinav Ghosh, sir, with a memento and a certificate as a mark of our appreciation. Now moving on to our next session, which is a panel discussion, which is on understanding allergy through analytical lens case-based. And for that, we have our moderator, Dr. S.B. Fukon, Senior ENT Specialist, Guwahati, and our chairperson, Dr. Thakeshwar Singh Paulsangwan, HOD of Jennings Hospital, Hall, Dr. Devolina Dev, Assistant Professor of Agartala Government Medical College.
Very good morning to all. Actually, I take the privilege to welcome you all. Actually, panel discussion yesterday, there is 4 panel discussion. Actually, I am being the moderator this session. And we have got a very efficient and panelist. The first, Dr. B.N. Sharma. I will make it very short because 45 minutes is there only. There is 1 hour behind schedule. Actually, very recently he became the allergist. In a very short time. I just gone to Mumbai also to examine and become the allergist. And actually he is the past president of Guwahati chapter also. And he is allergy by Shin Desai. So Shin Desai, all we know, is the son of the area Desai in Mumbai. They work with very good allergy clinic in Mumbai. Next year, she has got so much long biodatas, both vestibular and also allergy. And I don't get all this because she is doing in Dibrugarh. I don't know how many people are going there doing Dibrugarh in allergy, but I really appreciate her for her endeavor. Next, Nayanjali Sharma. Yesterday he came from doing allergy. I don't know for this panel he has again claimed. He was in Chandigarh doing a HCKS, under AIMS HCKS, and also under the PGI Chandigarh. Yesterday he came from there doing allergy course, fellowship. Vishni in Sagar Hospital, Sagadas. She actually really, I know that she is also doing the allergist. All training with Osim Desai. And Prasanna is all the son of the side from Manalay. He get finished a very experienced physician. He passed MD from Government Medical College. And in government jobs, he left the government job. And now he is a great practitioner in Manalay. He is included here as a physician. Because there is no pulmonologist here. In Guwahati, we do with the pulmonologist. And Gautam Kumar Boda actually is a very good pediatrician. I came here about 1 month back to give a lecture on allergy here. They say more. And today also I think you'll take nice part. Very active man. And with a now maroon color shirt also. Actually, before I always start, I tell this thing. There's a great saying of Elizabeth Barrett Browning. He lives most life whoever breathes most air. This is the main thing of allergy and asthma. History, actually not only that, it was first coined by a pediatrician. The Viennese Austrian pediatrician, the Clement one part in 1906, and all these things. But now today's present biology is a gene mostly at NPW having all the area guidelines and different guidelines under the gene mostly. These are the Jalen-Coombe classification of the hypersensitivity reaction, but today we are dealing with only the type 1 hypersensitivity IgE mediated antibody. And prevalence is the most important thing, of 55% burden in allergic rhinitis. But according to pediatrician, the ISAC, actually it is ISAC, the International Study of Allergy and Asthma Consensus, phase 3. But this shows that really interesting. See, 23.6% in 13 to 40 years age group. And in Indian scenario, it is 20 to 30%. And this is the burden of the whole, therefore you are here for the allergy, all the comorbidities. Last but not, this is also very important. I don't know how many people follow the guidelines. Actually, in ARIA guidelines, we should always follow. Because if you read the guidelines, you may not follow one by one, but you will give a very good rational treatment. Particularly Euphoria guideline, your EASI guideline, the European Association of Allergy and Immunology, and ARIA guideline. Started in 1999. One of our Indian fellow, there is Ruby Pamankar, he is from Mumbai, he stays in Japan now. She is the main promoter of this ARIA guideline. Now it is revised in 2022 also revised. Little modification. But the classification of allergic rhinitis changed to intermittent and persistent from the perennial to seasonal. But seasonal and perennial will never go. But for the treatment purpose, it is been classified. And this all you know. Last but not the least, this is the main allergic cascade. If you know this chart, you will know everything. Here even the prebiotic, probiotic role is mentioned here. Where the vitamin E, prebiotic, probiotic, everything. Now with this, I think I'll come to the first case first. But whereas time there is little strict because time is 30-45 minutes. All the panelists will be very precise and very clean and to the one or two sentences per month and no repetition this. But this discussion always promotion and argument always you should avoid it. This is case one. I will read it, but very nicely so then you can answer. A 58-year-old architect presented with severe rhinorrhea, blocked nose, irritation, nocturnal cough. You see nocturnal cough. For the last 6 months, he resides in dusty and polluted area. His comorbidities are hypertension, asthma, diabetes. Use inhaler. That is most important. On examination, expiratory wheeze. See, not inspiratory wheeze. Expiratory wheeze. I don't know how many people keep stethoscope in your table, ENT. I always keep stethoscope. I do all cases, blood pressure, and which I see. I have time. I am not a busy practitioner, but I give some evidence. I try to give evidence-based treatment. This wheeze you can pick up very nicely, expiratory wheeze. And history also, if you see, with a wheeze in the night, with allergy patient, is very important. Otherwise, the cough you cannot cure with different things by history. And left data is loaded eosinophil high, IgE high, skin prick test positive, see, gas positive and HDM. House dust mite, the commonest allergy. And PFT will not discuss much today because no pulmonary is here. They do. I don't think pediatricians here do this pulmonary function test, but they give nice information according to guideline also. In China guideline also, if you give treatment to asthma, we have to do this. Now, first case, I would request BN Sharma to take up this. This is an old case. See, repeated treatment given. What will you do? The case coming to you, what will you do?
First thing, we have to go for thorough history, and it shows that he is having hypertension, diabetes, and asthma, and on inhaler. So our endeavor is to find out the cause of the nocturnal cough as well as wheezing. So
He done this is skin prick test.
yeah, we have found that it is already grass pollen and the house dust mite is positive. is we should try to give the treatment for the allergic rhinitis, as well as we should advise him for allergic immunotherapy. For
But this is the last case, but the patient does not want immunotherapy. If you want to repeat the skin prick test, you have got any doubt of the skin prick test here?
yeah,
They said no, don't allow you to do it again.
it's not needed because it is already known that the grass pollen and ophthalmite is there. So we ask him to go for some preventive measures like changing and cleaning the pillows and bed cover and bed sheet every.
No, there is a protocol prevention, not easy. Actually, we have warm water, 55 to 60 degrees centigrade. The pillow, case, and the bed sheet should be washed. Twice a week, thrice a week. You tell the mother, particularly for children, to get them go. And what, no, he's an old man, but most important is that here we in Guwahati, we not get the allergic cloth. Previously it was available, but nowadays not available. I have charged many more also. In Korasman, Guwahati, some people told it is available, but it's not available.
Available in Amazon.
Amazon, but I told them, but no one can get this. But I asked them to do a plastic cover. But I covering the pillow and covering the clothes also. Because HCM is so much responsible, you can't imagine. Damage of fibers, verini, damage of fibers, serinious, and glomia. These are notorious, these things, because these are the most commonest thing. Do you want to repeat this skin prick test? No.
No, sir. From the very history, it is very much clear that this is a patient of persistent severe allergic rhinitis with asthma. So I will treat.
Why you tell the asthma?
Because the patient is having nocturnal cough for the last 6 months and the blood eosinophil and the total IgE is also raised that points towards asthma. Type 2 high asthma and there is expiratory wheeze on examination.
Yes,
expiratory wheeze. And also I will have to see the report plus pyrometry because the FEV1 FVC ratio should go down below 80%.
If you are taking spirometry, what is the FEV level to go for ICS?
So first, FEV lesson to diagnose obstruction. First of all, spirometry will not tell you whether it is asthma or other causes of obstruction. It will tell them is the patient of obstruction or not. So first thing that we see is
what is the definition of asthma?
It's a heterogeneous disease characterized by 4 cardinal symptoms of chest tightness, nocturnal cough, wheeze, and difficulty in breathing.
It is reversible. Unless your video shows you.
With variable intensity and
Kusam, you tell something about this. Whether you how do you take this case? Suppose this referred by ENT to you.
First you have to diagnose the case.
No, diagnosis is also diagnosis. Allergic rhinitis is asthma. Do you do any this test here, lung function test, spirometry?
It is needed, but
No, you don't. Normally you don't do.
but clinical assessment is very important.
Yes, very important. Correct.
And you are regular.
Then what inhaler you will do here?
Actually, now regular examination is a process and not. Sabai is not Sabai.
How why Sabai is not used nowadays? Lava. What lava you use? Long acting beta 2 agonist? Format. I personally use these things. Therefore, I am a surgeon, but the patients are so poor, no? You cannot refer to the pulmonologist. If you refer, they will do all the lung function tests. But past that trial, patients were okay, and then they come to me. Nothing harm to I am doing. But if it is status asthmaticus or very emergency for nebulation, then you refer the case. Why you should refer? Because pediatric cases are go down. You come to me. They will faith on me. I don't know. I mean, you will demonstrate half of what they do. If the patient, then actually, then what other oral steroid you use? Nebulation. What is the medicine you use in nebulation?
First thing, we cannot use a diabetes and hypertension. We cannot go for
oral steroid, but in inhalation, I think don't even do. And Krishni, we would do in this case, how to take up that? Suppose the case came to Sagat Hospital. Then how to take up the case? You have got pulmonary there. They do all the experimentary. As a more harder of this experimentary, anything is there? Do you know? No. There is another thing, one is oscillometry also. I think Noel knows more about these things. Oscillometry is the same thing. Oscillometry, more precisely you can do the lung function test. Yes, fractional lactose. Do we give some lava and medicine?
We don't give, but
The pulmonary refer, but I will need this. Yes, not. And again I go to physician. If you don't know GINA guideline, no? If you follow the GINA guideline of 2023, then exam stages are the first, second, third, fourth, fifth. And this what stage you will give for one is lama also there. What is lama? You know? Anti-muscarinic. Yes. Diatropium. Yes, diatropium. Yes, it was. In not looking for what will you do this case?
We have seen that all the interventions are done and
To be precise.
most important thing in such a case, I discuss about the technique history very carefully.
Knowledge is taken never discussed.
Because during this
One thing, why they not allergic? Why not non-allergic? He said in polluted area, very polluted area. He said, why not non-allergic? How to prove that they are allergic? It is mentioned here. Yes, you should have down.
That's why the is allergic and
Do you in Dr. Food, when you say air quality index is what on per day-to-day basis? In your mobile, it is written always. You see the weather report, air quality index. See in Guwahati, about 5 months back, I so much get respiratory infection cases and allergic. But now it is less because air quality index in normally is about 50 good. They have what about good, better, satisfactory, poor, very poor, like that. If you see the air quality index, you can very nicely tell. Now in Guwahati it is 50, 49, 50, yesterday also. But Nagaon little better. But Nagaon bad and Nalbari is better. Because if you see the air quality index, then you can, because pollution is a great thing in Delhi, suppose. And then in North Lakshmi, how is the pollution?
pollution is about, yesterday because it was full of...
No flyover construction, no?
Construction is going on. Pollution is much less, I should say. And it is mostly nowadays, it is declared. So we can be careful, sensitive, careful regarding this allergy.
So I just want to tell one thing. Can I see the case one? As the patient is having nocturnal cough, other than other things, it is specific for asthma. Still, we have to rule out other things of nocturnal cough, like GRD or LPR. We have to rule out. LPR. We have to rule out. It causes nocturnal cough. Yeah, maybe because of that. And another thing, sir, he or she, whatever, 58 years old. So in this case, we will not go for immunotherapy. Usually, immunotherapy is not effective above 57, 58 years of age.
Only 3 cases. There are no second case.
Okay, sir.
This is a case of children. Gautam will have first take up the case. A 10-year-old girl, she is very important. My daughter, same problem in a young age, I still remember. At that time, I don't know about allergy. I just give a Dextrona injection from Guwahati Medical College Pharmacy and I pushed her. She became okay. That's a very good method because she is gulping like this, long way. And 10-year-old girl presented in emergency room at 3 a.m. is very common. Restlessness, shortness of breath and a wheeze. pediatrician, not responding to antihistamine, incontinence and cough syrup, which responded previously. Past history of rhinitis for a long duration. She is breathless. Her mother is asthmatic, controlled by regular medicine. Physical exams respiratory rate high, heart rate high. Spirometry tried. In pediatrics, spirometry is not easy to do. Then what do you do? Big flow meter, FPFF. But I've asked Gautam only 2 days back, do you use big flow meter at Mogalde? But India, Guwahati pediatrician use. Then there is some red zone. Big flow meter has some zone. More red zone, yellow zone and green zone. In green zone it is 80 to 90. Yellow zone is a 50 to 80. And yes, around 50 or 50 and then it is below 50. And then what is the diagnosis? All diagnosis bronchial allergy with asthma. It is a common scenario. Why will you take up this case? Suppose the case come to you, you have got emergency in Mongol Civil Hospital, you are working there. This case, how will you tackle the case? Have you got nebulizer here? Yes. Oh, very good. Well.
First is angular guard. Presented emergency.
Please use the mic. Please use the mic. Put it closely on.
Presented at 3 a.m. with the restlessness, shortness of breath, and wheeze.
Yes.
Not responding to antihistamine, decongestant, and cough syrup. Past history of rhinitis for long duration, she is breathless. Mother is asthmatic and taking regular medicines.
Why this line has been put here?
Yes, sir, this is very important.
Why?
Because if one parent is asthmatic, sir,
yes.
then up to 60% child may develop bronchial
He is
asthma.
like diabetes
At some point of his or her life. So, parents' history is very important, sir.
Yes.
Second is, sir, this will be first, whenever the child will come to us, we have to confirm that she is suffering from acute exacerbation of bronchial asthma.
Yes.
Then you have to categorize which is a mild or moderate variant, then severe variant or light variant. And from history and findings, sir, this is be a case of severe variety.
Yes.
Because
when you suppose this came at 3 a.m. to your hospital,
yes, sir.
will you give the nebulizer?
No, sir. What happened? He reached the hospital. So immediately.
This is the guard.
No, sorry, sir. See, what is the facility we are there? We will use, sir.
Yes, that's correct.
If we are having meter dose inhaler, sir,
Yeah.
with spacer,
Spacer,
we
yes.
will go with that, sir.
First, yes, very good.
And every 20-minute interval, we will give 4 puffs, sir.
4 puffs. Very nice.
4 puffs, sir, to every 20-minute interval for 1 hour, sir.
Got it.
Along with that, we will give a single shot of prednisone, sir. That will be 1 to 2 milligram per teaspoon.
The syrup. So,
Short will go for, but I said what will the available medicine in our center. So this is the earliest we can do, sir. Now, we have to think about the child condition, because if the child is restless and red zone, so I don't think she can take the path.
Yes, yeah.
So in that case, nebulization is a must.
Yes, that is nebulization must.
Nebulations are same way. No, sir. What we will do in this case, considering need to put it side in the red zone, we will go for short-acting bronchodilator nebulization. That is, Estalin is there and Levolin is there. Plus, buprenorphine hormones.
Levolin, how much it is refined that your salbutamol? It is levosalbutamol. But it is salbutamol. How much refined it is levosalbutamol? Then your salbutamol?
Levolin, dextropan,
Sir, isomer
and this is not the levolin. So every 20-minute interval, we will go for. And sir, what we can do, considering how to be in the red zone, we will give a fast course of injectable steroid. That is usually prepare hydrocortisone. that is 10 milligram per kg body weight state dose.
State.
By the time on assessing, we will
You go
assess.
by intravenous.
I will say. This is on or whatever. Petition or 1
Petition
kg
or
or 5 kg body
the
weight.
pregnant syrup is there.
No.
Okay, then thank you. Then again,
Tablet versus
The
tablet.
resource available.
do you believe on hygiene hypothesis?
Yes, sir. Definitely, sir.
Yeah, what do you mean by hygiene hypothesis?
Sure.
Sir, as all of us knows, bronchial asthma is a heterogeneous disease.
No, that's okay. What do you believe? Hygiene hypothesis, suppose you are in children in the street, they never very less allergic rhinitis or diarrhea. They are exposed to more.
That is why, sir, patient and parent education
Yes.
and their lifestyle modification, avoidance of triggers. These are very important and we have to teach them, sir.
What is interesting with you listening? For the intestinal dysbiosis on this case, particularly for though he is not a pediatrician, but still, for the intestinal dysbiosis.
Basically, the gut flora is also very much
Yes,
important.
very important.
Good gut flora has a role in most of the diseases like
Yes, like allergy also.
allergy, inflammatory.
Therefore, there is one treatment also. But do you use it? Never. In allergic patient, probiotic, prebiotic. Bacillus fermentum and Bacillus paracassi. These two are the main thing, gut flora, that will be used nowadays. But it should be for 3 months. That is the main problem. And some analysis are there, but I don't know much about that. They say like that. But what is cyclodesma? What is the adult purpose that it is cycle? How to tell your mother that my child is not suffering from it? He will ask you. That question comes to me also. Whether my son or daughter is suffering from so much allergic rhinitis and is he going for asthma?
Yes, sir.
Then
Incidence is
now how do you tell counsel the mother that it is not asthma or asthma? What do you tell? If you tell it is asthma, other physician will it is not asthma. It is silent asthma. Then how to answer?
sir, we educate the mother. We will say,
Then we take the mic.
we will say that around 40 to up to 50% of the children with allergic rhinitis may progress to bronchial asthma in their lives.
Yes.
And simultaneously around 80% of the asthmatic side may have coexistent allergic rhinitis.
Correct. Then now Dibrugarh will come. Actually, for proper pediatric, this is a pediatric as a another pediatrician can answer. But you see, suppose milk, cow milk allergy in pediatric, how do you deal with that case? Very much allergy.
If milk allergy is there, we will tell them avoid it.
What milk you give? What milk you give?
Lactose milk.
Hydrolyzed milk. that is.
Hydrolyzed,
Yes. Is there anything mixed desensitization?
Yes.
They've got idea.
Yes, yes.
How will it done? There is not immunotherapy.
After controlling, we gradually start giving.
No, the immunotherapy principle is that generally
Same.
increase the dose of allergy.
Desensitization.
How do you desensitize in a pediatric to the
In
make
pediatric for
allergy?
food allergy also, it is almost same. We start the child with very minimum, sometimes. Occasionally we give little like milk or peanut or
There is a 6th grade, starting from biscuit to yogurt and ultimately to pasteurized milk also. There is 6th step to desensitize. Now you know. They say, how is step done?
I'm not quite sure about it. I'm not a treated patient as such, but whatever to the best of my knowledge is first give milk in the form of some other foodstuffs like biscuits.
Biscuits, yes.
Or whatever, cookies or whatever.
Then muffin.
Then muffin.
Like
Wait till
that
the milk is a little higher.
Like yogurt.
Yogurt.
Ultimately hydrolyzed milk. Then after to go to cow milk. The 6 steps are there.
Gradually.
Yes. Because allergen is a protein. Therefore.
by eating we can naturalize.
Yes.
Naturalize.
there you have told how Uncle Asma comes here. This I think you all know 40 actually. What is the three things? Evidence that United Airways is one area, one disease. How will you tell that this is that one? What are the evidences? Mr. You can tell.
It is nowadays saying that if you can stop the sneezing, you can stop the...
No, there is a dialogue. Stop people in breathing as well. But what are the evidences?
No, we have what the evidence that nowadays it is saying that almost 80% of the allergic cases, stomach cases and allergic rhinitis, and almost 30% of the allergic rhinitis may go for asthma. It's been recorded in Western tradition.
See, this is one picture. Actually, three evidences clear cut. One is epidemiological, one is clinical. Clinical means if you decrease the upper level disease with antihistaminic and montelukast, it gives a good relief, like the same thing. And thirdly, it is the same mucosal membrane. Pseudostratified columnar ciliated epithelium. Same epithelium. And same air cells. All allergic cascades are there. You see, in rheumatic fever, what happens? He strikes the joints and bites the heart. Strikes the joints and bites the kidney. But here he strikes the nose and bites the lung. The same mechanism, nasobronchial allergy. That is most important. I think we want to add something. Take the microphone. You take the microphone. Yes, TH2, yes.
TH2 reaction and the rheumatoid is that is TH1 autoimmune.
No, TH1 different.
TH1 is cell-mediated.
Yes, cell-mediated. That's what is computed as one area, one disease, or united area disease. Then always there is stop sneeze before it quiz. Therefore, you should give importance to the allergic rhinitis. So that the child or the boy never quizzes. This is the same thing, nasobronchial allergy, very important, one area, one disease. And how to tell that the child already told that he is not suffering from asthma. Is the family history is there, as you told, very correct. Family history, mother is just inhaler. You are almost sure that it is. But difficult to say, good counseling is necessary. You have to say like blood pressure, if both parents are suffering, then 70% chance, 40% chance, like that. Please take the microphone.
And sir, rough calculation pediatrician we used to do, sir. If the child is having bilateral polyphonic wheeze or breathlessness or difficulty in breathing or chest tightness or 3 attacks in a year, sir, then only we counsel the mother, your son most likely going to suffer from side effects.
I think we go to case 3. This is actually a little advanced, but we will not go for much advanced. Like, actually, the 30 years old housewife having one child of 5 years old, has long history of about 10 years having symptoms of sneezing, running nose and blocked nose. What are the symptoms, main symptoms? None you can tell of allergic rhinitis.
Sneezing, itching, allergic rhinitis, sneezing, itching, rhinorrhea, and congestion. These are the 4 cardinals.
What is the clinical definition of allergic rhinitis? Can you tell? Can you tell? Actually, IG mediated, okay, that's the definition. But actually, for 48 hours, more than 2.5 days, all these symptoms, two and more symptoms, and also for 1 hour, allergic rhinitis, then it's called clinical definition. No need actually, it's clinical. But symptoms of perennial pattern, see perennial pattern, here not that persistent, but the same thing actually. For treatment purpose, intermittent and persistent, but for clinical purpose, it is the seasonal and perennial. And more on morning. So more on morning means what signifies? Or whether you can tell, the more allergic rhinitis in the morning. Not like heart attack in the morning, getting up for bed, baby. That's it. Why in the morning, people come, I'm sneezing 20 times in the morning.
Because it is number one thing is the humidity, number
The
two
humidity is the whole thing.
it is high in the morning hours.
No, that pillow and that mattress. All house dust mites are there. Comes at night. Yes, comes at night. Yes, that's correct. Yes. Correct. Peppers are changed. Addition of pepper. Is a bigger pepper. Like pollution. They treated with antihistaminic, nasal drop, and CSA. Now little about antihistaminic. How does antihistaminic act? You can tell what antihistaminic you choose. First generation, second generation, third generation.
Use the mic properly.
Use the microphone. Don't jump and like this. Use the microphone like this.
Each one happens in the second generation and precursor because of the less sedating effect. So, preferably if...
Suppose this lady is pregnant, second semester, then you give what antihistaminic you give? No, fast you don't give antihistaminic. Because the obstetrician will see you if it is aborted. Therefore, you should be very careful giving medicines, particularly for pregnant women.
Sorry, sir. For pregnant women, if the symptoms are sneezing,
Why pregnant women? Why is this happening?
Sir, in pregnancy, they said that the symptoms of rhinitis is because of the hormonal change.
Yes, what was that? See, all the students, I level of the same thing.
All the symptoms are also beginning
First generation. Though they are sedated, but it is safe. Any INCS, what you will give?
First line, we will tell the patient to avoid mud triggers or syndrome. Number one. Number two, we can go for local decongestant, nasal drops or intranasal corticosteroid we can use.
Normal saline is
Normal saline also helps.
What internal INCS you use?
Fluticasone purine.
No, how many internal corticosteroids US FDA approved? Can you tell someone?
How many times, sir? How many times?
8 INCS are internationally approved by US.
200 milligram.
No. How many INCS are approved by US FDA? Number from beclomethasone to how much? How many? So 8, there is 8. Beclomethasone, triamcinolone, fluticasone fluoride, fluticasone propionate, budesonide, cyclosamide, prednisolone. Every 8 US FDA approved. You need to know. This is an oceanic guideline. But what will you use in pregnancy? That's most important. Pregnant women, sometimes you have to discuss with the obstetrician also. Can I give? Then you will say, the patient will hear, no, she is discussing with the obstetrician. But they will not pick up your phone. But very difficult to pick up. With some of them they pick up. If you counsel, no, then you can give something. And normal saline spray, everything. But that's why I am going out of the back. INCS, and I will ask her how it acts. The CS breathes off and on. But she is boring, but she is bored with this treatment, like a long thing. Then what is skin, ultimate skin quickness. Then we'll get there, how skin quickness, how will you do?
Pregnancy, we don't do.
Not for pregnancy, she is not pregnant. I make her pregnant. No, to discuss. No, actually, not to discuss because a short time, no, 45 minutes.
We go for skin quickness.
In children below 5, you know.
Below 5 we don't do, above 5 we do.
Then what do you do? In skin quickness?
Report is there. So we will go for
Don't report for the report. How do you do the skin quickness? This report is of non-external report.
persistent allergic rhinitis not recovered with conservative
But
treatment.
that your version, but patient will not be like that. But then the 1 point is there, the second?
Yeah. The conventional treatment is not working for her, and in those cases we are giving treatment for 6 months or so.
This patient is fed up. We go with the actually one, they will come, Dr. Shah, in Bihar.
We will counsel the patient for skin prick test.
Yes.
We counsel the patient
See,
and
procedure.
convince to do the skin prick test
Very
and
low pain.
immunotherapy and immunotherapy.
Yes. Then suppose the report came here. With TF, there is amyloid and bromia. See the bromia, how much percent is there? It controls histamine and saline. Suppose this report come, how would you do this? Immunotherapy?
So I will start immunotherapy against a house dust.
No. How to counsel the patient? Patient, you will immunotherapy 3 to 5 years.
Suppose if I get this report of a particular patient, so I will first go for the precautionary measures that a patient should take. I will give him a proper counseling before starting allergen immunotherapy. And I will ask the patient to dose precautionary measures for at least 2 to 3 months, along with the pharmacotherapy that the patient has been already taking since so long. I will tell him that only pharmacotherapy is not going to help him because we have been doing it for 5 years, 6 years, whatever. So today, whatever I tell you, whatever I precaution measures I tell you, have to follow very nicely for the next 2 to 3 months. If she doesn't, and also I will tell her about allergen immunotherapy, that you might require allergen immunotherapy if with alone precautionary measures you don't get well, if you don't get better.
But how to counsel? Not to be difficult to counsel the patient by skin prick test. How to counsel?
No, there is no difficulty in counseling.
The difficulty is not there, but how to convince the patient?
Because if the patient suffers a lot and our parents are really worried about it or our problem, then definitely.
No, you have to tell. This is the only the thing.
Yes.
Immunotherapy, skin prick test. Skin prick test have an advantage for avoidance. You diagnose that it is half the spine or anything, you can be avoided without doing immunotherapy also. But you have to counsel the patient that this is the only treatment that can modify the disease. Other everything is temporary. That's the most important.
Yeah, we can avoid this. Bring down the concentration of the bromia in this environment. It is true. Before going to AAD.
What is the two types of immunotherapy? What do you practice nowadays?
There's 2 types of immunotherapy available. One is subcutaneous immunotherapy and another is sublingual immunotherapy. SCIT and sleep. So,
what do you practice?
We are practicing sleep, sublingual
Everyone is
immunotherapy.
practicing sleep, no?
Yeah.
Because it's safe and no, you can ask the patient, no need to come here again and again.
They can take it at home.
Yes. What is the complication of this sleep?
Like if the patient is taking correctly,
Oh, that's correct.
that's one of the complication won't say, but one of the problems in my face.
No, sometimes feeling of the
It's a local reaction, yes.
Sometimes compliance should be there.
but it's safe. Like all of you who keep the emergency kit, like epinephrine
Yes, it
kit,
has to be there.
but always keep. If the reaction may be about different way.
Bring SPT also, it has to be there. And
Nowadays even epinephrine spray also there. One is the EpiPen means adrenaline injection, and another is the epinephrine spray also recently coming up. Adrenaline spray. Like this. I mean, medicine may not be there, but you should keep it.
immunotherapies are actually, there are several groups are there. In India it is not available, but subcutaneous, sublingual, epidermal, intradermal and intralymphatic ultrasound guided it is given.
Now, what we are finishing the 45 is only. Oh, then another time. Just. Hey, Hey, don't talk. Hey, what about biology? Last one, no.
Biologics can be.
Have you used biologics?
No, try to use biologics.
No, there is no one is using biologics, no? In pediatrician use, here you don't, In Guwahati, some pediatrician use Amalizumab and Dupilumab, 1 or 2 I think in Guwahati. But what are the biologics?
anti-IgG antibody, that is omalizumab.
Yes.
Dupilumab.
Yes. Dupilumab for what is it?
That is 4.
Interleukin 4 and 13.
4 and 13.
Then eosinophilic, IL-5, mepolizumab, respironumab, and what? Benralizumab. And another one, very important, TSLP. Tezepelumab. Those monoclonal antibody not only come in immunotherapy of cancer, but comes in allergy also. And last time I think question was asked to suppose there is polysensitization, not one allergen, multiple allergens are. How do you detect the allergen?
Sir, we coordinate the findings of the SPT with the patient's clinical history. Then we will determine what are the main causes of his or her allergic symptoms. In SPT, we will get lots of things positive.
Suppose SPT is negative,
Yeah.
IG also negative.
Yes.
What do you suspect? Basically, someone who allergic rhinitis.
Local
allergic rhinitis. How do you detect a diagnose the local allergic rhinitis?
There's a provocation test. Staff that is allergic to be suspect.
We can get IG in the nasal secretion and the biopsy also we can get IG, raised IG
Yes,
in local allergy.
Yes, the way you can detect. And what is the CRD? This is a little two-line CRD. CRD and basophil activation test. Component?
Result.
The diagnosis. What is the CRD?
Basically, it is the protein which is causing the problem. Identification of the particular protein which is causing the allergic problem.
No, that is correct. All allergens are protein.
Which is causing the allergic symptoms. Particular protein identification.
Have you sent blood to for CRD? No, no, it is
Nowadays it is not.
No, it is not available. But send the placenta laboratories of Chennai and Bombay. You also send them. You send.
The serum specific IG for that specific protein helps, specifically helps in certain polysensitization.
Polysensitization.
If you are confused, sir, then it helps in pinpointing the specific
Anything you want to tell? You take a take-home message. Only one line, all the analysis. One, please sit up.
Allergy treatment basically used to be multidisciplinary. Only ENT specialists should not continue. Pediatrician, medicine.
One line, take-home message.
Awareness needs to be there, and also about the patient, and also same thing like multidisciplinary approach, because it's not only the nasal, but also the lower airway.
One thing, allergy, vertigo, this thing are very common for ENT practitioner. If you don't know something, you cannot give evidence-based treatment.
In case of SPT, what I would like to say is that there is not a history, and if it is negative, then again we have to become because it will not be very bad. I mean, careful in taking a history in the patients of allergy. Because it is very important.
History is very important. In diagnosing and treating allergic diseases, simply giving anti-certain results may won't most of the patients.
What I have learned, sir, one year old when this so sir, never neglect allergic rhinitis when the child is suffering from asthma, and never neglect bronchial asthma when the child is suffering from allergic rhinitis.
Yes, we take treatment, otherwise it will There is an allergic march.
Yes.
Allergic march.
It has to be actually from atopic dermatitis. It should be identified.
Eczema from eczema.
From eczema to atopic dermatitis, asthma, and nowadays eosinophilic esophagitis is also taken in allergic conditions. Eosinophilic esophagitis. That is also has been included in the allergic march because it is from the food allergy.
You heard? Eosinophilic esophagitis.
I've studied a bit.
You have studied, I know, therefore I'm asking you. I don't think it is.
Eosinophils,
You should put it
I think 20 per high power field in the esophagus is diagnosed with eosinophilic esophagus.
No, that's correct. Whatever it is allergic march, they'll stress this. Whatever it is taken in allergic march.
Yes, sir, it is literature is there. I will share.
It's very recent stuff.
Wow, you are coming up very recent.
Recent stuff.
The question, sir. Anything last comment, one line, you're finishing up where? Yes, like that. Like that. Yes, sir.
LRT is a common disease and SPT is the gold standard of diagnosis and immunotherapy is the future.
Very good. Very good. That is the thing. Localization was biopsy, urine record. What is ART? You know? What is sample strength? Sample strength, sample strength. Therefore, decompetency. Now, in thyroid, decompetent cases is there. In carcinoma thyroid, stimulate for in 131 deletion. Now, even allergic decompetent allergic for immunotherapy. In the optical line of vision, nature of it is very recent. I think I got to like take it in 1 hour or what? There is a confusion. See, knowledge of action of diagnosis and management of allergy have been taught for several years. Genetic analysis must be known. It is manipulate the genes and immunology and allergy is a fascinating subject and a complex field. Unique complex field is necessary for better diagnosis. I think you agree, all of you agree. Because if you read allergy to the name, newer medium or newer molecule will come. Therefore, you have to be acquainted. Thank you very much for your all the. Yes, now I think doctors are also doing immunotherapy. Therefore, in the chairperson.
And
in Jennings.
I was exposed to immunotherapy
yes.
in Amsterdam when I was training.
Oh, yeah, Amsterdam.
And they had trial for sublingual and subcutaneous effectiveness.
Oh, yes.
And they studied about some 5 years study, and it was said that the sublingual is very effective and very acceptable to the patients. So basically now all the European countries, they are depending on the sublingual, and only American countries, this West, they do subcutaneous. Basically it depends upon how much you want to earn. You earn more when you do subcutaneous, but more patient problem. In my experience, I started doing it since 2018. I have done about more than 400 patients, and the dropout rate is very less if you influence them properly. Convincing is not very difficult because patient coming with perennial allergy to you, unless you give something to them, they won't do it. It's very much sure. Now they have been to so many doctors and so many medications they have been taking. So what you have to tell that you want to keep on taking medicine throughout your life because there is no cure. Then what? Then there is one cure. There is called immunotherapy. Do you want to know to which allergens you are having allergy? Then I do with 200 allergens, and my kid is 200. Yes. So from the beginning,
newer allergen in
newer allergen is what?
Something seeds, pollen, everything.
Pollen is very common. Different pollens. All the jungle pollens are here.
In which season? Autumn season, spring season, which season?
Spring is more.
Spring is more.
And say fungus is very predominant in all places.
Thank you to our moderator, our chairperson.
Next one thing is about you can tell the patient that which they can avoid, and when it feels absolutely they don't have separate together. Allergens which are ingested and taken from the nose. So all this combined you can
Thank you to our moderator, our chairpersons, and our panelists for this highly engaging discussion on allergy. Now moving on to our felicitation part. Special thanks to Dr. S.B. Fukan. I request Dr. Swagata Khanna to please come forward for our felicitation session. Now I request Dr. Swagata Khanna to felicitate Dr. mark of our appreciation. Now I request Dr. Khanna to felicitate Dr. P. Now I request Dr. Khanna to felicitate Dr. Gautam Gowda with her. Now I request Dr. Khanna to elect certificate as a mark of our appreciation. Now I request Dr. Khanna to felicitate Dr. S.B. Fukan sir with an electorate as certificate as a mark of
P. Guest faculty and Dr. R.C. Jaka from New Delhi, you already know about him, and Dr. Amita Roy from Kolkata, and Dr. Srinivas Kishore from Hyderabad. So, all the members and delegates are requested, please do the registration for smooth arrangement of our midterm CME and surgical video demonstration. And already registration is going on just outside the hall and it is open. So again, I request all, please do the registration for grand success of our event, and we need your full cooperation. Thank you, sir. And
Good morning, everyone. First of all, I congratulate Utpal, Dr. Utpal for a fantastic CME. It is like a conference only. And I expect in our Dibrugarh chapter CME also everybody will come like this with great enthusiasm. We are preparing our with utmost care, and all of our members are working hard. So expecting all of you, please register and come. Counter is outside. Dr. Apurva has already explained. Thank you.
Thank you, sir. Now we shall move to the video presentation session. We have the first video demonstration by Dr. Anjan Meena sir on tympanomasticectomy with tympanoplasty, inside-out technique. The chairpersons for this session is Dr. Vishwajit Gogoi sir, Dr. Bidhan Das sir, and Dr. Supriya Chitram ma'am. I request the chairperson to please come to the seat. And also a small announcement, the PGT, the post-petition e-poster presentation has already started in the VIP room, and the judges are Dr. S.N. Mukherjee sir, Dr. Gautam Khan sir, Dr. B.N. Sharma sir, and Dr. Shubhama Chakraborty sir. I would request Anjan sir to please come to the seat. Thank you.
So, 19 तारीख 30 तारीख सेप्टेम्बर 2023
interesting আসলে সাইজ আমার কি বিধান মানে সাইজ ভালো কি ও এটা আপনার
Good morning, everyone. So, in my presentation, video presentation, I will be very precise. I will try to stick within 15 minutes. So, in my presentation, I have already taken two cases. Both the cases are cholesteatoma. First case is little bit of extensive disease, and in the second case is a limited disease. This is in the mostly in the anterior part. So these are the two steps I do in every cases. This is the normal skin incision inside the canal. Then the post-auricular incision. This is the common post-auricular incision I use. I use a lot of diaphragm in this area because bloodless field gives me a lot of precision. So we say just lateral to the temporalis fossa, I delineate the temporalis fossa, then go inside the canal after giving the soft tissue incision until one day. So in this incision there may be some few kidneys, nerves and small vessels. We need to take care of this. This post-auricular incision is helpful for a good exposure, and that helps me to do whatever disease is there inside the mastoid bone. So you can appreciate this incision and how I eliminate the implanometer flap. So here in the suture line, sometimes I use diathermies. It helps in eliminating the flap without much bleeding. So till now we have already noticed the cholesteatoma sac in the middle ear. This is the superior incision, inferior incision, and elevating the flap up till the annulus, till I see that order impeding. So here in the upper part, in the attic region, you can already visual. Its cholesteatoma is visible. There is some erosion in the sputum, and you can see some cholesteatoma is coming out through the section. So in this case, I taken out for inside-out technique because I can already see the cholesteatoma sac, cholesteatoma bone erosions in the attic region. So this is the canaloplasty to make the canal little wider so that there will be more comfortable in using the other drills. Now this is the smallest drill. This is the, I want to stop it here for a few seconds. So this is the smallest drill, and this is the most crucial step when I do from inside out, because here is the, in this step I need to be very cautious whether I am injuring the ossicles or anything, because in this step it is ossicles are not visible before. But after this incision, if I remove the lateral attic wall, and then I go behind and with a very small drill, and we can switch over this drill to a bigger drill. So keep on drilling posteriorly, keep on drilling behind, and at the same time I can lower the facial ridge and following the cholesteatoma sac posteriorly up to the mastoid tip. So this disease is extending up to the mastoid tip. So you can appreciate the disease in the mastoid. Now I am trying to delineate the sigmoid sinus and superiorly the dural plate. You can see the cholesteatoma sac in the mastoid, and at the same time, while I am suturizing the cavity, I am lowering the facial ridge and removing the cholesteatoma simultaneously. So I have no fear of injuring the facial nerve here because I am already lateral to the annulus, I am already lateral to the chorda tympani nerve, and lateral to the lateral semicircular canal. Sometimes we need to use the bigger conical bar. This will make your job more faster. So with the bigger conical bar, with the help of other dimensional cutting bar, we need to socialize the cavity. And I am here. I am trying to remove the disease from the mastoid tip cells. Gradually, you need to delineate the dural plate, and sometimes there may be a little bit of bleeding, blood vessels, some bleeding points are there. If the bleeding points are there in the dural plate, we can control it by with the help of a bipolar control. So the diamond drill helps us to remove the disease and making the cavity smooth and removing all the small air cell pockets. So till now, I am lowering the facial bridge and you can see. So here there is a small part of facial bridge is here. I remove just now. Anteriorly, now I am going anteriorly. You can appreciate the disease. I am tracing it anteriorly. There is a small bleeding vessels. I am cauterizing it by a bipolar. And in this video, I tried to show you how I could achieve a good mastectomy cavity from inside our technique. In the next video, it's another disease, another case. This is a limited disease. In this case, already we have removed, elevated the tympanometal flap, and now I am doing the canaloplasty. These are same. Now I am entering the medullary cavity by giving incision to the edematous mucosa. The middle ear cavity is disease free. So in the AT region, I am using the small drill, and now after using the small drill, I can switch over to a bigger drill and drilling it posteriorly. In this case, what you can appreciate that the disease is not far extended posteriorly. So here the master cavity in this case is smaller than the previous one. So I am handling this case in a defined way. I am not doing a complete mastectomy. That means it's not like a radical mastectomy cavity. So you can appreciate there is no disease, only there is some edematous mucosa. So I remove those disease in this area, in the tip cell area, or there is no disease, only mucosa. So I did not remove the cortex in this case. So with the diamond drill, I am lowering the facial ridge. You can appreciate the chorda tympani nerve is intact and healthy in this case. So I try to preserve this chorda tympani nerve, because in most of the cases we are ignorant about we don't care about the chorda tympani nerve while doing cholestoma surgery. But in this case, what you can appreciate, the nerve is very healthy, and I try to preserve this nerve. So you can appreciate there is cholestoma sac matrix under the bony ossicles. So I try to delineate the extent of the disease, but a little bit of disturbance because of the chorda tympani nerve. This is how we can displace this chorda tympani nerve by giving the bony canal of the chorda tympani nerve. 1 or 2 millimeter of downward displacement chorda tympani will give you a very good exposure of the ossicular cells. So now you can appreciate there is all the bony ossicles. You see the malleus incus stapes is there. Is apparently the incus long process is intact, but as there is cholestoma sac under in the vestibule area and everywhere, so I decided to remove the vesicles. So now you can see, though it was seen that long process was little eroded, so intact, but it was eroded. So little bit of oozing from the mastoid bowel. So this the way we how we can control. There is different way of controlling bleeding during this time, because blood gives you a lot of trouble while dissecting this in the magnified view. So now I am removing the head of the incus. This is eroded. Long process of the incus is membranous like, and the Melius bone is intact. But I need to remove the Melius bone because I need to reconstruct this cavity. So this is the disease removal from the vestibule area over the foot plate. You can appreciate the stapes head. This is a small piece of cotton ball soaked with adrenaline that helps us to remove the disease very precisely in this area, because this area is very difficult to handle, and more or less the chorda is intact. There is every chance of injuring the chorda wherever you are handling the instrument. So this is how I try to remove the disease from the critical area, and this is the disease removal from the anterior mesotympanum. So I dissecting it cholestoma matrix from the anterior mesotympanum, and piece by piece I am trying to remove the disease from the this area. So I am taking help of the suction, I am taking help of the small cup forceps and a light knife. So we can achieve this removal very precisely under magnification, but the disease removal will have to be very complete. If there is any doubt of remaining remnant disease, then we cannot reconstruct this cavity. So now I am removing the disease is from the stipple. You can appreciate. Okay. So other part is the mostly the epimetas mucosa. This is the dissection of the sinus tympani area. So from the sinus tympani area, I try to remove the soft tissue, but the soft tissue here is only erythematous mucosa. There is no cholestoma matrix. You can see. If there is some doubt, we can use a small endoscope to see that area. So with a small cotton or soft adrenaline, we can rub it and see if there is any disease or any remnant critical cells in this area. So this is how, if I am very happy with the disease removal, we will go ahead for reconstruction. So you can appreciate there is no disease. This is only I try to remove the mucosa, but the soft tissue. But what you can see, this is mucosa only. So I am not doing any curettage or any work in this area. So I am happy with the disease removal. Now I move for reconstruction. So for reconstruction, we use the tracheal cartilage, the temporalis fossa. This is the most common ossicular reconstruction I use is the tracheal cartilage. Sometimes I use bone, but not very regular. Cartilage gives you long-standing result, though it is not very great in terms of the hearing, but it gives a very long-standing permanent result. So as you can appreciate, this the tympanometal flap, there is a small hole only for the disease, and I kept the healthy part of the tympanic membrane and everything intact. So you can see this is the temporalis fossa. The temporalis fossa I put over the under the tympanometal flap, but over the chorda tympani. This chorda tympani, as I kept it intact, it helped me to place the graft lateral to it. If I place the graft lateral to the chorda tympani, then it again helps me so that it does not get rejected. You can see I am placing the graft lateral to chorda tympani nerve. Right. So you can see the chorda tympani here. And moreover, I am going to place a small piece of cartilage over the foot plate over the head of the stapes, and this cartilage will be in between the chorda tympani and the head of the stapes. So if it's in between chorda and head of the stapes, then it is very stable. You can see this. This is little bit out of focus, but in the next slide it is fine. So you can appreciate this cartilage. This cartilage is, you can appreciate the cartilage, you can appreciate the chorda, and you can appreciate the stapes head. So this cartilage is very much stable. You can see it's very stable. It's not going to forget. So this is how I completed the ossiculoplasty, and here you can appreciate the cavity is very small. As the cavity is very small, we need not do the big myeloplasty incision. If I want to make it smaller, I can give some soft tissue here. So there is no, in these cases, there should not be any cavity issues and anything like that. So you will appreciate that while replacing the canal, I just use only a small incision on the canal. I did not do, you can appreciate a small incision in the canal. So I did not do a total myeloplasty. So this is how I achieved the tympanomuscular with tympanomuscular. Thank you.
Thank you, Dr. Ranjan, for those various tricks you have shown us while we come across doing surgeries over here. Thank you so much. I think we should go to the next speaker again if there is no question.
If allow one.
Because he has taken 15 minutes.
Exactly 15 minutes, not
because it's better to have.
You are a boss of this session.
It's better to have interaction other than if you have any interaction.
Yeah, please.
I'm
very precise.
Anyone? Let us quick comment.
Yes,
what is the advantage of inside out in an expensive disease rather than going outside?
There is no disadvantage of inside out in this case.
Advantage, I must say advantage.
In a very big extended disease, there is no advantage of inside out. But the inside out advantage is you are not, at the very beginning you can see the critical structures. But if you are going from the cortex, you are blind. You are just assuming a surface marking and doing the disease. But here, if you are incising the lateral apical, you know where is the ossicles, you know where is the facial nerve, you know where is the chorda tympani nerve. Okay, so this is how you are very precise from the very beginning.
So here today in the last designer workshop, in many questions are what is inside out? Designer there is no inside out.
Whatever it is only a whatever you do, but doing an incision in the cortex, it is something else, and doing an incision on the lateral apical is something else. Because this is the way it can be done, but it gives you a lot of clarity.
But anyway, classical kissing of the outside is a one-time man like one will have precise distance. It is not like that without saying and without but this you can't say the outside technique also not a landmark surgery. It's very specific. You have to go from one landmark to the next landmark. But the idea of I think the inside out is a very limited disease, which is mainly in the mesotic venom. And little extension that we release. So the concept of cavityless mastoidectomy comes. Anyway, thanks Adonda. I think the one just for the vestibule, you have uttered many times vestibule. This is in the vestibule. If you say you want
vestibule, vestibule area because
I think it's the basically the either mesotympanic and hypotympanic area or foot plate area. Foot plate area. And vestibule, because vestibule is the vestibule is going.
Foot plate area is one of the parts of the vestibule.
Okay, that's thank you, Adonda. Next. I request Abhinav. Oh, Jago. Please, Jago. I think he's he gave the slide of the faculty. Everybody knows Jago. Jago is from Oracle. I know him very much. He's an academic guy, medical associate professor. Jago.
You have not submitted biodata? Oh, it was clean up. Solid biodata. Dr. Jagore. Jagore, Dr. Jagore. Ajit Nam. So, he is a pioneering doctor in endoscopic ear surgery, and most probably he is trained endoscopic ear surgery under Mubarak Khan, and he has brought the Mubarak Justice medal holder also in his place. And she regularly organizes otology workshop. His workshop name is Loving Otology, and I have visited also his workshop. We have pass from names. And so I'm reading from my side his profile. And I have also very good memory of doing a workshop in his place, starting from, I must be recent, 6 p.m. and we ended at 2 a.m. or like 3 a.m. So here is his bio profile and biodata. So already he has good publications and attended the conferences. So now he's a faculty. Okay, Zego, please go with your survey.
Thank you, sir. Good morning to all. So thank you, Mangalda. We had a very nice time. So today I'm just going to show how we do endoscopic tympanoplasty using two-handed technique. So this is our starting of the video. You can see here, this is just normal routine cases. So we do infiltration. We clean the canal, then we infiltrate with 2% gel in all 4 quadrants. And then yeah, gifted me, in fact, he gifted me free of cost. With the microscope? Yes, with the microscope. Yeah, and then the like step 2 is freshening the margin of preparations. So we do the, and then this is the third step. We just try to denude the handle malleus in the initial part because here the malleus is very stable before elevation of the plate. We do this in the initial part of the surgery. So you can see here the suction in my left hand and the sickle knife in my right hand. It's like a microscope only, but you can see the image, difference in the image. Then the incision we give the 240 degree, and elevation we use this marrow cell. So it's like a microscopic surgery only. Then we reach up to the annulus, till annulus, and then basically what we do is internal elevation. I just wanted to show the step of internal elevation. So till annulus, we have to reach equally in all directions. So this, once you see the annulus, we engage this 90-degree hook in the annulus and just fill it off. It's a very simple technique. Just engage the right angle and then just fill it off. It comes easily. So this is the internal elevation. So we elevate all around except in the posterior. This kind of you can say a kind of a modified interlay, because we have to expose the ossicle. So here, let me just show the exposed part. So it's a very easy kind of elevation. Then here we just bridge the mucosa and try to see the ossicles. Because in every tympanoplasty we have to expose the interostitial joint. Now the next step is denuding the handle of malleus. So handle of malleus also we denude from upward downwards. Just give a nip here, just give a incision here, and then just denude. Because the tip part we have already done in the initial part, so this in the later part it became easy. And then the next step is clearing the ventilatory pathway. So unless if you don't clear the ventilatory pathway, it is going to recur again. So just pasting the tympanic membrane or just sealing it is not going to help. So basically, anterior ventilatory pathway is here. We're just trying to clear from the coke to the cochlear process. So here we introduce our instrument with this marrow cell and try to break the mucosal folds and all here. And then posterior isthmus, I mean the posterior tympanic isthmus here from the cochlear process to the equidistal joint area here. We try to push the marrow cell inside and then come out. Then coming to the posterior, here is the posterior from the equidistal joint to the pyramid. So this area we can visualize with the angle endoscope also. And this way we clear the ventilatory pathway. It is mandatory for all tympanoplasty. And then the next step is coda. We have to always see the coda actually. We have to see and try to guess from here the stability of the coda. We can guess how the mastoid is behaving. And then now this is the elevation, the 360 degree actually we elevate, but this portion we elevate like this. We introduce our round knife through the preparation and elevate from inside out. This is the from backward side. So inside out elevation. So this is 360 degree elevation, and this particular strip we kept here. And then we try to remove this edematous tissue here. Then the next step is, let me just show the annulus excision. We try to excise annulus in total, because once annulus is out, it is difficult to put into the sulcus. So sometimes it can float there and may cause the healing purpose. So we remove this annulus in total. So once we remove the annulus, so if we do this, there is no need of pressing the margin. In fact, then before harvesting the graft, we put back the tympanometal flap and try to keep it in its original position during the time of harvesting the graft. And we put the marrow cell there so that in the later stage when we try to maneuver this tympanometal flap, it's easy. And now this is the graft bed. So normally we do the bed-to-bed graft, and this is the most important step in this tympanoplasty. So first of all, we harvest the graft. We use the wet graft, and you can see here the bed is already ready here, but here there is a deficient because we have to look the key area, the ossicle area. Then in time to time we have to put the water actually. It is just to lower the temperature, that is the heat radiating from the tip of the scope, and also to clear the area. So now we spread the wet graft first in the canal. Just
you already use wet graft.
Yeah, wet graft, just wet graft. Direct, sir. So just keep there and then spread it. So once it is folded, it is difficult to put it. So now I am using my single hand. But once the graft, then slowly we push inside, then my left hand comes. Use this tip of this suction as a left hand and just put behind the meatus. So then after that, we just adjust the graft all around 360 degree, and we must show that the graft should lie over the bone. This graft is going to get a nutrition from two sources now. One from the direct from the bone, from the Haversian systems, which is already opened up by now, and also from the canal skin that we are already raised. So here we don't put anything inside the biliary. We don't put gel form because we believe that gel form is like also a kind of foreign body, so there can be any foreign body reaction can be possible. So the natural content of the middle ear is what? It's air. So we try to put the air in fact, just try to make it airtight actually. So we put the suction. I just wanted to show how we put the air. Just put the suction there and just close the this graft actually. So this is already airtight. So after that we press with the marrow shell, trying to make it and try to recheck it whether it is, because the graft should touch the bone all around. There should not be any fold or anything. Then we lower the plate. So after lowering the plate also, again we have to raise it again. We have to recheck it again and again, because many a time when we lower the plate, at that time the graft gets folded and there is a gap creating all around. So we have to relift like this. So I am lifting it again and recheck all around. So we have to check anteriorly, we have to check posteriorly, and we have to check all 360 degrees and make sure that the graft lies all over 360 degrees and there should not be any gap in between the graft and the plate. So we have to recheck it again at least 2 times, at least after putting it back, again we have to lift and check. Then we have to press it all around with the marrow cell, just press all around like this. Then we put the ab gel all around. So this is a very common technique that we are doing. And as you all know that we as a ENT surgeon, trypanoplasty is a bread and butter of ENT surgeon. So we must try to give a 100% result for the patient, although it is very difficult to achieve. But we are doing all routine cases like this using endoscopic holder, two-handed endoscopic technique in our center. Thank you very much.
Thank you, Dr. Jigo. Very nice and clearly demonstrated. The surgical field and all are very clear. I would rather like to know how you hold the endoscope. If that picture is there, then it would be more nice.
Oh, ma'am, yeah. Actually, it is not there. Picture is not there. Sorry for that. Next time I'll show it. What we do is we use a microscope actually. The microscope is designed in such a way the endoscope holder is fixed in the microscope. So with the knob of microscope we can do forward and inward outward movement also. Once we want to go in, we just have to rotate the knob of the microscope, and then if we want to come out, then we just lift it. So there is to and from movement also there, and we can move forward and backward also. So there is all movements available. You can do it easily. Sorry, I don't have that video right now.
Is it customized or is it available?
It's available in the market. Given, I think, marketing done by some companies, they're still there. And there are 2 qualities are there, which is bed mounted is also there. Bed mounted means you can mount it, that holder in the bed of the patient, in the bed of the OT table. So that is also available. But I'm using that microscope one because I've been using this.
Actually, you can change from endoscope to microscope also.
Yes, yes.
Yes, yes. When you go for the cortical method, you change
You
microscope is there.
Yes, sir.
You can change like
Yeah, if you want to look from microscope also, you can just look microscope. And if you want to use endoscope also, you can use endoscope. It's a kind of 2 way you can do it.
I think nowadays Kalkan also have endoholder, so you can go with that endoholder. So Stores is a very good intelligent endoholder. It's kind of a robotic hand. That's another option.
Suntrose, sir. Suntrose also.
So that means you have 3 investment. One is a microscope, one is an endoscope, and endoholder, and also the laparoscopic machine. So if you don't want to be microscope in your place, then you have the endoholder. Endoholders are available nowadays.
Yes, sir. Yes, the advantage is you can start anywhere in the periphery also. And plus, and nowadays, cosmetic and other things, the young ladies and other things also wanted to go for arm pores and all. They always prefer the endoscopic scarless. So this is one technique that one should adopt.
What microscope, what the endoscope size of the endoscope you have?
Normal endoscope, sir. Normal endoscope 4 mm 1.
What is the length?
Same like 1801.
1871.
Same, but the small one also you can use.
But don't use.
But that is not very good in the field. Yeah, into the field view is
Last question. How do you sterilize your scope?
the same way like
What's
in the Cydex we just keep like that.
Side is not, nowadays the scopes are available which we can autoclave. Sterilization.
Yeah, autoclave is also.
Sterilization is a disinfectant. If you put a Cydex, it is disinfectant, not the sterilization.
Yes, sir.
Okay.
You are right.
Any quick
Total
question?
annular excision you've done.
Yes, sir.
What is the advantage of total annular excision?
Sir, total annular, as I said, once. Oh yeah, it is a debate nowadays. TAE is very famous in some areas, but it is controversial. But I have been doing it and it's giving good result. The advantage is, the first advantage I already mentioned, once it is out, it is very difficult to put it so that function physiologically. Because it is out from the annulus, body annulus. So sometimes it clot.
If you take out the annular, then you have done internal technique.
Yeah.
What will be the mucus layer?
And then, when you, sir, sometimes the mucosa also retained.
Yeah,
mucosa also retained there. So mucosal lesion also is possible. There may be weeping in the later stage. Yeah.
I think thanks, Lego.
Thank you, sir.
Very clear. Now I invite our next speaker, Dr. Abhinav Ghosh. And we have this disability biodata. Abhinav, just one quick request to you. If you finish early, then you have more interaction. Because it's always better to have a more interaction than a showroom. So everyone knows Abhinav is a gifted hand in odontology. And he is presently his own clinic here in Sinus Clinic in Maligaon. And he visited one place also, and they do lots of odontology and also the sinus work there. And he is a key interest in the balloon sinoplasty and balloon stimulation. He has presented in many conferences. And I request Abhinav to go to your presentation. Yes, sir.
So it's a collection of small videos. So I just put it into a slide. So ossiculoplasty, what is ossiculoplasty? We have used this term to describe the surgical procedures that reconstruct the ossicular chain to restore the transmission of sound to the inner ear. The goals are to restore ossicular continuity, improve conductive hearing, ensure long-term stability, reconstruction, and maintain a dry, safe ear. So we need to, before every ear surgery, we need to assess the merit so that we can properly assess whether the chances of failure or complications are there or not. However, in tympanoplasty and ossiculoplasty, there are the spiked and cracks. These are the like in ossiculoplasty, the tension, the round window protection of the and the angle at which the process is placed, whether it's centered on the foot plate and the space it creates in the middle ear. Those are very important factors influencing the outcome of a ossiculoplasty procedure. So let us consider a few scenarios. We see here that there is a small gap at the highest joint. There is most probably necrosis. So what can we do here? We can place a piece of cartilage between the joints and wrap the thin piece of fascia, or we can use glass ionomer or bone cement. What sometimes happens is we don't see the gap, but there is the erosion has started. The erosion has started, and but we cannot dislocate. So what do we do there? So what we can do is we can wrap a thin piece of fascia around the weak IS joint. Just take up a small piece of fascia which we have taken for grafting of the tympanic membrane, and then we just wrap it around, hoping that some fibrosis will occur around the joint and prevent the early dislocation of the IS joint. And then after that we just go in for a normal grafting of the tympanic membrane, just like a type tympanoplasty. So what do we do in this case? Yes. Since it's a video session, it's difficult to just continue without the video. But yeah, regarding what we've shown till now, you can just, in some cases, yeah. Thank you. So here we see that the higher joint is completely gone, but part of the incus is present. Most of the incus is present, the body is present. So what we do in these kind of scenarios is we can go for incus interposition osteoplasty. So what we do here is that we just make a groove on the to house the under surface of the handle of the malleus over the body of the incus, and make a socket to house the upper end of the superstructure and the head of the stapes. So here you can see we are making a groove which will go under the handle of malleus. And first we will just put the refashion incus under the handle of malleus, and then we push the thing over the stapes plate. Stapes superstructure makes a very solid, what do we say? It makes into a very solid unit, which is very, which gives good results. In osteoplasty, we always should wait for at least 6 months, and which will give very good results, and there is very minimal chances of extrusion or falling off of the graft in these kind of cases. So here is the audiogram. This is a pre-op. Pre-op right here, and post-op is this one. So this is a pretty good result for incus interposition. This we should always. I usually take serial tympanograms from 2 months and 4 months and 6 months. So if you just look at the tympanograms in the 2nd month and 4th month, you will feel very sad that you might have not done a very good job. But by the end of the 6 months, you have a good result. This is another case. Again, on the left here, we can see the post-op audiogram at the 6 months. There is already some SNHL which cannot be corrected, but the AB gap has been closed off. So what do we do in this kind of case where the superstructure is present? Malleus may or may not be present. So first is that we can place a tracheal cartilage over the stapes head. We make a groove at the inferior end of the bony annulus and shape a cartilage. Probably, not probably, we usually try to harvest a tracheal cartilage because it is slightly stronger than the other cartilages, and place one end of it in the groove and another end over the superstructure. What we can do to make it more stable is we can drill a hole on the cartilage to house the head of the superstructure. This will give very good results because main thing is the presence of the superstructure. If the superstructure is present, then we can give very good results. This is basically a port fashioned from the cartilage. So here we can see the results in the right here. This is a 2-year post-op audiogram. You can see there is quite a good closure. And this one, it looks like I might have, it will look like as if I am lying, but this is actually true. This is post-op. This is a very good result, especially in children. Another thing which we can do is we can, if we don't have a proper incus, as we have seen, and then we can use the malleus. So if there is no cholesteatoma, what I am doing here is I just first remove the head of the handle of malleus and then made a hole to house the superstructure and the stapes head, on the undersurface of the head of the medius, and then we just nicely place it on top. Just keep a small groove for the stapedius tendon, and you can see the reflex, round window reflex. So what we'll do now is, I haven't shown it here, what we'll do now is we'll place a small piece of cartilage here and just finish off the grafting. What we can also do in such cases where we have only the superstructure is use the port. I have used a titanium port here. This looks easy to place, but let me tell you, this took me around 35 minutes. So this was the first time I was doing a port. This is a very good, see, we can see the round window reflex, and the main thing about this is when we place any kind of ossicular graft, ossiculoplastic graft like a port or a torque, what we need to do is we need to do the reconstruction of the TM first. Reconstruct everything first and leave this for the last. This positioning has to be done last. So what do we do in cases where there is only the foot plate? First and foremost, most commonly done, which I have done actually, is using an L-shaped cartilage with the smaller limb of the L over the foot plate. I'll just pause the video here just to show you one thing. Just okay. We can see that there is a cut here which makes it into the L. What we can also see is that there is another groove which I have made. There are two here. There is another groove here. So that is for because there is the overhanging of the facial nerve over the foot plate. You cannot see the foot plate properly. So I have made a groove to house the overhanging, but actually it's not required in every case. So in this, again same as that, we make a groove here and place the other end of the smaller limb of the L cartilage over the foot plate. We can also use the incus, or if any other remnant, we can just shape the ossicles. We want to use as much as the natural things as possible, whatever is present in the patient's ear. So what we have done is we have just shaped the incus in such a way so that it fits snugly over the over the foot plate, and here we can see a nice round window reflex. Again, just place a cartilage over the whatever prosthesis you are placing, because while healing, when the neotympanum retracts, it might pull off the torque from your foot plate. We can also use a Teflon here, Teflon torque, PTFE. So that again, all my reconstructive work is already done. Then only I am doing this. So this one has already been reconstructed. I am putting a big piece of cartilage here. It's not required so much, but this was a very bad case of retracted TM. So along with that torque, plus I am trying to help it to not adhere to the middle ear again. So the round window reflex, we can see, we try to check always check the round window reflex so that we can at least predict, we can have a little bit of predictability whether the hearing will be good or not. Here, this is the endoscopic view. When we have done the mastoidectomy, we just went in through the mastoid, and we saw, and we can see that the torque is placed properly. There is a good space in the middle ear as well, and the cartilage is covering the torque. There is no, the tympanic membrane is not in contact with the torque directly. So this is this is a Teflon torque. We can see that the result is not very good. It's not amazing, but still there is a good amount of epigap closure, but I'm not happy with the higher frequency because what might have happened is that we know that higher the weight on the foot plate, we lose some hearing in the higher frequencies. So maybe the large piece of cartilage which I have placed over the Teflon torque has maybe caused the higher frequency loss. So titanium torque will just look look at the preparation because I have just made a video as well. So we have a cutter. We cannot do this thing. There are many. We can cut as like whatever size we want. For demonstration purposes, I'm just cutting it in the largest area so that I can measure it again and then I'll put it into the ear. Just put it into one of the holes and you have a big handle which comes down, which cuts. This is the part which has to be cut. So when we pull the handle down, that yes. So this is cut now. This is cut at 5 mm. So what we also need to do here is what they mentioned in the directions to use and all. You see, there are two parts. There are two parts. This is the part which will be next to the TM, and the long part will be on the foot plate. So that has to be fixed onto that. One has to be fixed onto the other. So some blood is there. They suggest that some blood should be there while fixing it into the this round part. So we have to be very careful actually. I have this is quite a costly thing. It's about 8,000, and what happens is if you put too much pressure, it will bend. It will bend. It may even break. It's very flimsy. So once we have fixed it, and then again all the tympanic membrane work is done, and then we'll just put it in and over the foot plate. Here we can see the foot plate. This is very high magnification, more than 25 I think so. So you can see the torque being placed on the foot plate, and just we'll have a look at the reflex. It's the weight and everything on the foot torque shows beautifully on the reflex as well. Just a slight touch and we can see here. Yeah. So yeah, it's almost done. Just one small thing. Sometimes we can wonder whether this torque will stay or not. So these kind of cartilage shoes can be made, in which we take a small piece of cartilage and try to put it, if we don't have a cutter, I think so Counsar has a cutter, cartilage slicer which can cut it into small pieces like this, but I don't. So we had to struggle quite a lot with this, and then just make it into a shoe. We call it a cartilage shoe, which will give lots of balance to this torque. And then again, it cannot be a circular one because the oval window niche is not circular. So we need to cut that as well. I'm sorry for the part, it did not come in the video. It's very less. So just cutting it out. And then if you see, I've just left it there and it's just standing. It is very stable. It's standing on a just a steel board. So I think so that's it. I'm sorry I could not come yesterday because there are many competitors just outside my clinic. So that's why I thought maybe I'll come today.
Excellent, possibly I can say for the juniors, I know many seniors are doing this work, but when he asked me what talk I'll give, I asked him next 5 years you will only talk on osteoplasty. Next 5 years you only talk on osteoplasty, because every night he discussed with me after doing the survey. I don't know what he can indicate the magnification, what magnification his stability of his hand. And in his stability, how delicately he is using the equipment and all these things. Mostly many children can learn that. I have to learn from him to do osteoplasty because it's a really tough job. I think it's a really tough job. But as a senior, I can take the liberty of you. But when you come for a video, you don't make this osteoplasty talk for next 5 years. But when you come for a video presentation, make MP4, because all national guidelines you have to submit that this talk should be MP4 format, not in a presentation format. This is a talk for your presentation or any kind of things. Make MP4. You can plug the audiometry in somewhere. You can plug the other tube, you can plug somewhere, and center that should be run a video. That's the thing. Any questions from the audience? Yeah. Okay.
experience with the prosthesis, torque or pop, prosthesis result?
Results are variable. Because I cannot say that there are amazing results till now. What I can say is that in cases where we have only the foot plate, I'm basically using only torps, titanium and Teflon. The thing is that I cannot, I struggle to, when I use a cartilage, I struggle to guarantee results. Because sometimes I get very good results, sometimes there is quite a big gap. The thing is that cartilage tends to be pulled up quite a lot. So I have tried to shift from cartilage to torques, but the thing is that I don't have very long duration series. Like I have maximum 1 year or 1.5 years. So in that case, there is when there is a AB gap of maybe around 40, that has come up to around 25. But till now, it has not gotten better. So I think so with time, usually what they say is with time, the torque gets better settled, and if there is no other comorbidities, then the torque actually doesn't give extremely good results, but the thing is that we can at least standardize the results.
There is a more chance of probably extrusion.
Yes, but
so any special technique to prevent that type of extrusion?
Extrusion can be prevented with a cartilage shield over it. Because if you don't put a cartilage shield over it, then it will extrude. So nowadays all the guidelines say that we have to put a cartilage shield. Otherwise there will be extrusion, and with a cartilage shield the chances of extrusion are very less. But it's still, in a country like ours, cartilage is still the better option, because if hearing is not the main priority, then maybe cartilage is better.
And the measurement of the shoe,
yes.
We applied, no?
Yes.
What is the proper measurement?
No. The shoe.
So cartilage
go down.
Yes.
Yes. The shoe will depend, because this is it's different. The niche is different in size in different patients. So what we do is we just use that Dr. Madhuri Mehta's method, in which you use a 12 suction and just push it onto the cartilage and make a circular one. And after you make the circular one, place it in and see how much you have to cut, and then you cut. Because here I have not shown that I am placing it over the niche and then I am cutting it. I am just showing direct cutting, but we have to measure and try to. That's a very long process actually within the.
I want to put something here.
Yes.
In my experience, last some 25 years, since some 25 years I did the osteoplasty, osteopathy, all these different areas. But the most frustrating thing was that the patient was very much okay after the surgery, 2 years, still okay. After 5 years down, 10 years down, 15 years down, patients come with extrusion. That is very frustrating. So now I have completely stopped doing any rhetoric and and doing only cartilage in the body. So basically, the results may not be fantastic in case of cartilage. You are very much right. Sometimes the results are not cannot be guaranteed. But they usually, if you keep on treating, it gives good results. And I have already published few papers of it. And the results are moderate. I don't say that excellent, but it carries for a long time.
Sir, while doing those TRP and PRP, were you using the cartilage between the prosthesis and the graft?
Yes.
Still extrusion was there, even after using the cartilage between the graft and the prosthesis.
No, I am not using any prosthesis.
No, before when
you were cartilage only.
Yes, okay, you were using the cartilage.
Only cartilage.
No, you said that you were using torp and port before.
Earlier I used.
Yes. So when
yeah, I put the cartilage.
yes.
From the beginning I put the cartilage. Even these shoes also I tried. But the space is so narrow. In spite of endoscopic surgery, it's very difficult to put something extra. I don't know how you have done it, but it's very difficult to put in that.
It takes time.
Anyway.
Very nice demonstration.
Oh, yeah.
So, we use bones sometimes, intact bones. We have seen very nicely crafted fingers made. So, these are the cases with cholesterol or without cholesterol?
Without cholesterol.
So if there is cholesterol, we never use bone. That should be the case. Okay. Whenever the bone is invaded or not, in cholesterol, we don't use. Okay. So that is the dictum actually. We don't use bone when there is cholesterol. Okay. Thank you.
Very nice demonstration.
Just want to know one thing, like for have you ever tried this long columnar or the micro taxi with the various angle?
Yet. I wanted to try, but I didn't. I haven't gone to that. Yes, yes.
So whatever you do,
no, the type of osteoplasty is always intra. I have not, till now, I have not told the patient that I will do this osteoplasty. Always intra, I just give them a heads up that if when there is a large AV gap, osteoplasty will be required, then I just let them know that there is an option of a platinum torque, a titanium torque, which may be used, which might increase the availability. That's all. Otherwise,
I will tell one thing. See, all many surgeons say clear cholesterol, everything. But hearing, cut the hearing is the most meeting. And how much patience you have got to grading of patience? Patience. Without patience, these things.
no, these 2-minute videos are
How
actually 2.5 hours.
How many patients you get? You see the clock to do the.
Oh, no.
They don't see the clock. They don't see the time.
My anesthetist helped me.
This time delayed and all that. Now everyone cares more than me. But the hearing is the most important.
My anesthetist helped me.
So the most important thing is if the other ear is normal, the patient will always complain that I am hearing less. So before surgery, we need to counsel the patient. So you will improve the hearing, but the other normal hearing will be always.
Just I could comment on that. That's right. I request Amitav also. He is doing good out, but I request him to do the audiological part by third party, not by own. Sometimes because when you place the audiological part, what you are asking, that's a very good program asking. And they will have to complete the separation that this muscle loss is there. Because if you want to already hearing, you definitely my hearing is perfect. I am hearing this much. But you have to show the proper masking. Full masking. And there is a protocols there. And you have to complete this muscle loss and this muscle you are going to gain. And post of audiogram also. You need a protocol and lockdown to follow also. So ultimately, because I got a session, but 3 books is very important for this kind of work. One by Gopis, one by Mike Protos, and the most beautiful one is a book by Madhuri Brett. Please, the juniors can go back. Thank you so much. I can get something. No, thank you so much.
Did a very wonderful visual feed for all of us in this alternative video session. Can we have a felicitation of the speakers? May I request Dr. Vishwajit Gogoi sir to felicitate Dr. Anjan Bhuiya sir?
Thank you.
May I request Supriya Chintam ma'am to felicitate Dr. Jegorvi sir? I will request Dr. S.B. Fukan sir to felicitate Dr. Supriya Chintam ma'am.
Felicitors are always. I call her, she ended the Guwahati, and I gave 2 lectures. And she bought me very good organic tea from Manipur for me.
The chairpersons are Dr. Bhavesh Das and Dr. Rohan Murwa.
I request to start. Sir,
No PowerPoint is not So actually, this I was making the slide while I was coming on the train, so it's a slightly older version. We will see this one. So I have two disclaimers here for artificial intelligence. And artificial intelligence is the burning topic right now after IT revolution and after industrial revolution, IT revolution. Now it's the artificial intelligence revolution. So I have two disclaimers here. One is this. After this slide, all the slides are not generated by me. It is all generated by AI. And I have not done much of that. Maybe I have checked for spellings and all those things. So that is one disclaimer. Everybody is a little bit conversant with AI now because phones are forcing us to use AI, Meta AI, this AI, that AI, and everybody has some concept of AI definitely. So what we expect AI is something like mostly generative AI. So I generated this also on the way here. I was in railway station. So what I'm going to talk is advent of AI in healthcare and in ENT, a brief glimpse. In 15 minutes, I can hardly cover the tip of the iceberg, less than 1% of what is here. So just throw light into what we have. So before we dive into AI or anything into AI or anybody is interested in AI, we have to understand another disclaimer that AI, you have to treat AI as a personal assistant and not a competitor. And the moment we treat it as our assistant, then it is going to be of immense help to us. The moment we think it is going to take over our jobs or it's going to take over and become our competitor, then I think that will be the controversial part of it. So this is the second disclaimer. So artificial intelligence, what is artificial intelligence? Why is it making so much of a hype? There are so many programs, so many things are there, a lot of things have been happening in IT sector and in computers and all. But why AI is because AI follows a natural language processing. Means C++, basic, logo, we have to learn the programs, learn the commands, not so many things to make the computer do something. Here, it follows a natural programming language because it has got layers and layers of understanding to be able to process our natural language. So I may be talking in English to it and I may switch over to Nepali or I may switch over to any other language and it will have that understanding to be able to know what I want. So natural language processing makes it very, very easily usable by everybody. So that is why it's catching up so much. And a lot of apps are there. We all know that everybody's heard of Meta AI, this one, ChatGPT, the most common one, and then medically mostly Perplexity is better choice for medical things. And then, like that, lots and IBM Watson, another very good one. Lots and lots are there. So we'll not go into that one. We'll see what it can do for us in healthcare and what is AI in medicine. So AI versus TAI. So TAI is the ultimate aim of AI, but transformative AI, that is what we want. It should be like an industrial revolution in the sense that it should be able to do things that we are now hoping AI can do actually. So transformative AI, the use of machine learning, deep learning, so we'll come to this, what are these ones, some glossary terms. Actually, I didn't bring out, I had one more slide here about glossary, the terms that we'll be using in AI. So transformative AI is basically using AI to be able to do things like we wish somebody could do for me. Like somebody could interpret my APR report, or somebody could explain me my APR report in detail. I don't have to do anything, I just give the report to him and he will explain to me. Or somebody will plan this surgery for me. I have the CTs, I have the clinical findings, they at least plan, they do not do the surgery, they plan the surgery for me. So that is transformative AI. And like that we have what is called machine learning. Machine learning is basically the program will learn something not on the basis of programs that we give to it, but on the basis of data that we give to it. So we give it 1,000 APR reports, and then it will learn how to interpret an APR report. And then there will be, there's also something called trial and error kind of thing. So initially it may not be good, but over a period of time, when we start correcting it, or when it learns to correct itself, then it will be giving us more and more things. So, AI in treatment planning and AI in drug discovery, we'll talk about it a little bit. In surgery, what can it do for us? In surgery, robotic surgery is already there. So AI can help us go for the precision. It may help us reduce our error, and it can also help us increase our success rate. And so basically, predictive analysis. This is what we are mostly in for AI use in healthcare. So predictive analysis, because we have patient-specific data. Patient-specific data in the sense like the algorithms, the AI software or the AI algorithms, what it can do is, it can analyze the patient's medical history, genetic information, and then lifestyle factor, and so many things, and then think of things that we may not be able, we have read about it, but we will not be able to remember those things to apply in that specific place. But AI software can help us bring that tailor-made recommendation for the patient, which we as a clinician can verify it, and then we can apply it. We do not have to depend on it directly. The AI will instruct the patient to do that one. The AI will give us information, we will verify with them. Then we will realize that yes, I have missed this one, I could have thought of that one, I could have thought of that one. So that is one thing, because of patient-specific data. Then risk assessment, because it can help us predict the likeliness of a certain disease in a certain trait of patients, or with certain trait of maybe the complaints or the findings or whatever. So it can help us for the risk assessment, and it gives us improved outcome because we have personalized treatment plans for the patient. And it will definitely improve our efficiency, because certain redundant things that I don't want to do again and again, it will do for me. So then I can focus myself on better things in trying to understand what output it has given me and whether I can implement those things or not. So redundant tasks it can do for us. So personally I have started using for redundant tasks like replying a mail, and then those are very basic things that I think everybody, most of us are doing right now. So replying a mail, drafting or something. But in medical sciences, slowly it will help us even write prescriptions. My prescription, but it will help write for me. I do not have to tell it. Like it will know what to prescribe for, say azithromycin, whether it is given before food, after food. It will know for itself. So I will prescribe azithromycin for 3 days. It will prescribe azithromycin in a very nice way that the patient will be able to understand, and there will be some background behind it. So another is AI-powered virtual nursing assistants. So virtual nursing assistant for remote monitoring, and it helps us optimize our clinical workflow, operational efficiencies, because task automation can be there, data management can be there, and resource allocation can be there. So here everything boils down to data. So without data, we cannot go forward in AI. So the first step for anybody willing to adopt AI in future will be to digitalize the practice. So right now we have started that process, and we have now OPD is completely digitalized. IP, my hardware setup is already complete. Hardware, software is also complete, but I am doing a pilot right now. In another 3 months, IP will also be completely digitalized. So once we have IP and OP both digitalized, the future of AI will definitely, once more transformative AI will come, then we can start implementing it at local levels. So another is enhancing medication management and pharmacovigilance. Definitely here, because remembering drug interaction is very, very difficult. We know there is a drug interaction, but we miss it because we cannot remember it. It is not possible to humanly remember it. So definitely here, there will be a lot of red flags. So this app, we have already started having it in our software. So whenever we are prescribing 2 or 3 drugs, and if there is a chance of a very high interaction, it flags us for us. It is for me to take the decision, but it flags for me. So that can be there. And pharmacovigilance also. Improving access to healthcare in remote and underserved areas. This is another area where we are working on it right now. What we are doing is, there will be some devices which can gather data without the need of a doctor in a remote place, and we can bring that data, pull it to the hospital, and primarily use AI to analyze it, and then secondarily use a doctor to verify it and then take treatment. So this one, we have done the training, and then the devices we are getting very soon, and we are planning to start in some of our community medicine department pockets, and then slowly see how it works out. So the same thing actually. So this is for us, for EMT, what is there in AI. So hearing aid. Nowadays we are getting devices which have got AI inbuilt into it. So what it can do is, it can process according to the environment, it can process. So we get very noise isolation is very good, and depending on what we are doing, it can adjust. So what it gives us a better hearing, number one, it gives us better battery life. So that is one hearing aid. Vestibular rehabilitation using AI. There are wearable devices which gives us raw data, and then all the stabilimeters, and then all the platform where we are doing our balance test and all. So this data can be used to tailor-make the vestibular rehabilitation exercises, and some auditory brainstem response and AI again, deep learning interpretation, because ABR interpretation is to see the latencies and then to predict so many things. So this is already in practice. Imaging modalities. Morning we were discussing very nicely how we are using DICOM images to all do this one. So there are now a lot of softwares, even free softwares. I think like there's one called 3D Slicer, and then there is some other paid softwares where those things can be done with help of AI, and it is for us to take a call whether it is definitely correct, because the 3D renderization and everything will be correct. So it is our call to utilize it in our surgery or not. So it will save us time, and it will help us in those things. And diagnosis and differentiation of benign and malignant diseases, again, radiological, histopathological, all the correlation history, and if the genetic mapping is already there nowadays. So correlation of all of this, and for diagnosis, it is the next thing. Then categorization of chronic, and a lot of papers are there. They are helping us categorize chronic rhinitis and make tailor-made treatment. Surgical assessment, navigation, robotics, definitely AI will help us, because imaging, lot of data is here. So when there is lot of data, AI will definitely help us. AI helps us wherever there is lot of data which we cannot decipher ourselves. Then in laryngology, stroboscopy videos and voice analysis, and then post-surgical rehabilitation, speech therapy, recommendations, and all those things. And image-based diagnosis, again a very deep learning, machine learning thing, which is nowadays being, a lot of papers are there. So quickly, actually started in 1990. There was a paper by Mira et al. Exploration of expert system as a diagnostic in motor neurology. So that time it was not called artificial intelligence, but they were using machine learning to do diagnosis, and then it has come all the way. So many papers are there right now. So 2018, there is a NPC, special interest for us in the Northeast, NPC using endoscopic images, machine learning, deep learning of endoscopic images, because those who have not seen NPC cannot diagnose NPC early stages. And even radiologists, I have had radiologists who have missed NPCs, early NPCs, because they have never seen an NPC in their life. and it looks almost normal when only the F1 is operated. So in those cases, this will definitely help us. So a lot of more studies are there. I think main thing is ethical and regulatory challenges, and more than ethical and regulatory challenges, we willing to accept it. We thinking that it will take over us. So that is the first thing, and then ethical and regulatory challenges, privacy and data security. So whenever there is data in the cloud, there is always a chance of leakage. So that is there. So right now also, whatever data we are using and going to the cloud and all, there is a risk of leakage. So that always holds true. And then we need to have transparent and unbiased AI models, means that it should not be politicized or countries like trying to extract something, because there are some controversies here. So another thing, the future is we have to expand, and then medicine is going towards AI eventually. So whether we like it or we don't like it, one day in another 15 years, I think we'll be having more AI presentations, maybe more AI studies, and then something like that. So I just wanted to just give a brief glimpse of what we can have AI in ENT. So thank you.
Thank you, Dr. Shakti. Excellent presentation. Other than ChatGPT, you can name some AI tool.
So ChatGPT is the most common, no, sir? Other than ChatGPT, what tool you want for what? What you want? Generate Google GPT. Those are all different. So you have very task-specific tools are there, and then you can have generative tools like Canva AI, which is also quite. I'm currently using ChatGPT full version 1 and Canva AI as a full version. And
You are also having one.
yes, sir. What's up?
You are also having one. Twitter board. You are.
I'm mostly focusing on very much task-specific this one, sir. And then IBM Watson is very good. If anybody has a domain on educational domain, they give us 1 month free. IBM Watson, and it's very, very good machine learning, deep learning. Anybody wants to do a lot of research, and if you have 1 month time, in that 1 month we can at least generate 1 or 2 papers if we dedicate some time in IBM Watson. But after that it gets blocked. I just recently blocked. I'm trying to prepare out of it. And then this one, OpenAI, that's the gold standard, like ChatGPT, sir. Perplexity, if we are doing a very low-level AI help, automation help, then Perplexity is good, because Perplexity is quoting more from PubMed, and Perplexity is making less of mistakes in medical related this one. So Perplexity is more tailored for medical research. Also, it can do other general tasks also. Yes, it is able to do other general tasks also.
Some information are not correct.
ChatGPT is ChatGPT. ChatGPT, you have to take it with a pinch of salt. But ChatGPT can help us do a lot of simple things, like reply a mail, do this one, that, make this one, right? And not for yes. So these are all generative AIs, but more into machine learning, more into deeper this one, structured AIs and all. We have very specific. Like for the CT thing, there is a software called Slicer 3D. It's a free software, and it is quite nice. It helps us to reconstruct 3D images and all those things. I use it briefly, and then.
What are the special tasks you want in your OPD to be done by AI that you say you have done an OPD setup?
Ma'am, in OPD setup, like basically one is history taking, and then analyzing that history according to the chief complaints. And then I will examine, I will give my inputs, and then it will help me keep differences, definitely. And then we can pinpoint that if, after imaging comes, once everything comes, then we can run it. I've tried with multiple models, like this one, multiple patient models. Mostly I have masked the patient details, but I told the AI that this is the same patient. So this is the same patient that I'm giving, and it gives us things which are we don't think. Like, okay, the rarest of the rares also it gives, and how to work about it, autoimmune ear disease, how to go about working on this one, and then something like that.
So you plan to do it for genetics?
Ma'am, genetics, I don't think, I'm not planning right now, but genetics is the next big thing because once we have genetic mapping and then all of this, then...
You mentioned about the rare diseases,
yes,
so genetics has to come in.
We do not have the facility right now in our state to have any genetic study. In most of the places we don't have, no? So that's why. But our hospital, like we are now trying to at least first digitalize things, IPT, OPT, total digitalization. Then when AI becomes more transformative, more into mainstream, we can immediately adopt because we will have at least from this year data, and then we can something like that. Thank you.
Thank you.
Thank you, Chairman, delegates, especially the organizing team of particularly for that. I'm going to talk about sleep apnea. I'll just try to give an overview on the subject. Firstly, we should all understand that the person suffering from OSA is not necessarily coming to an ENT surgeon as a first consultant, and it is something which has to be dealt with in a multidisciplinary manner. One person missing out here is even a psychiatrist. Just for understanding that every person with any problem during sleep is not a person of OSA. The sleep disorder spectrum is very large. There are more than 80 different types. And one of the most common sleep disorders being insomnia. Whereas sleep apnea, which again is different classes, is just a part of it. And there's definitely always an overlap between very different varieties of sleep disorders. Obstructive sleep apnea is a part of the spectrum which starts as primary snorers, can be graduating up to upper airway resistance syndromes, or lead to obstructive sleep apnea over a period of time. And the prevalence of this disease in India is roughly around 10%, predominantly more in males and a bit less in women. I'll just go through the common signs and symptoms of sleep apnea. Most commonly is the excessive sleep, daytime sleepiness, which is one of the most common symptoms presenting. But loud snoring or observed apneas, abrupt awakenings, morning headaches, difficulty in concentrations and decreased libido are some of the symptoms which we miss sometimes. Though excessive daytime sleepiness is one of the commonest things in adults, we need to know that that may differ when we are talking about children. Hyperactivity is in fact more common seen in children. They might be having sleepwalking, nightmares, fatigue, grinding, bedwetting, and many other unthought of symptoms which may be pointing towards sleep apnea. Just a quick run through the causes of sleep apnea, although there are 1,000 causes. I've just noted down a few. We need to understand that it's like a physiological and structural disease. So there are a lot of static causes and a lot of dynamic causes. The static causes need to be identified, and the dynamic causes need to be looked for by different parameters. Just to list a lot of other causes, the main lead cause of obstructive sleep apnea is obesity, although not necessary. Age, as a person ages, his tonicity decreases. Definitely more is seen in male. It's around 30% more common in males. A family history of OSA definitely has to be looked for. A patient taking medications may also contribute to sleep apnea. Alcohol consumption and other communication anomalies and syndromes need to be looked for. once a patient is in an ENT sleep clinic, what we need to do. Most commonly, very detailed history from the patient and more importantly from the bed partner. It can be whoever, it can also be grandparents sleeping with the child. We definitely need to do a lot of leading questions to find out what we are looking for. We have nowadays a lot of people come up with a video recording made on a mobile. That also helps you to visualize a lot of things happening through the night. Thorough clinical examinations and looking into the other comorbidities of the patient like obesity, hypertension, diabetes, COPD, hypothyroidism and other neurological diseases is important. And definitely a syndromic child is a different ballgame. These are some of the questionnaires which we can put out in the OPD settings for the patient to answer. Gives us a rough guide on classification or severity of the sleep apnea the patient may be having. But they are not decisive. Body mass index we should be aware of because this is something which really helps us to decide during our other procedures if we plan further on as we go along. These are some of the list of tests which we need to perform on a voice patient, not necessarily all, but the first and the golden standard is a polysomnograph. We in our hospital, we follow that we do a polysomnograph as the first thing. Once we have other details, we definitely take the patient to do a awake, flexible upper airway assessment. The rest, like other CT scans or a drug-induced endoscopy or a dynamic MRI, depends on patient to patient, although we don't do all in everybody. Coming to the gold standard polysomnogram, it can be done at different levels. Institutionalized level 1 study is not permitted in all the cases, so most commonly we do a level 3 home study test. This is what a polysomnogram report looks like. We really need to understand this report, how to interpret it, because this, like an AHI is an apnea hyperapnea index, is an indicator of the severity of the obstruction. It is classified as 0 to 5 to be normal, 5 to 15 to be a mild, 15 to 25 to be a moderate, and anything above 25 as a severe OSA. What it signifies is when a person is sleeping for an hour, the result of 7 shows that at least 7 times he is having an hypoapnea or an apneic spell for that hour. Whereas this patient is having apneic spells of up to 44 times per hour. This was a digital interpretation of the sleep study, and this is a graphic presentation where we can see different parameters on level 3, which shows the different parameters. This is unclassified apneas, obstructive apneas, central apneas. You can see the desaturations, the snoring, and all the flow. Once we have the sleep study, we usually take up the patient for an upper airway assessment, awake assessment. This is a flexible fiber endoscope. We use a bronchoscope. The patient is on the table near the head. You can see this is the velum. The soft palate is upwards. These are the tubal cushions. The patient is on spontaneous breathing. Usually take some time to assess the different collapses to assess the dynamic obstructions of SA. You can see the rubula now. down, we can assess the lateral collapse of the tonsils, the epiglottis, the base of tongue, their collapsibility. We can do a Muller's maneuver here to see how the epiglottis collapses. By noting down this findings, it helps us to identify the structural cause of obstruction and make a decision whether or not and where to operate. Once we have done our investigation part for the patient, what can we offer to the patient as treatment? The PAP machine is definitely the gold standard worldwide, although not accepted well everywhere. Definite lifestyle dietary modifications, exercise and weight reduction is something which needs to be emphasized to the patient and to the family. For minor cases, we can also offer some oral and mandibular devices to be used at night, which can pull the mandible out. There are some myofunctional therapy or sort of exercises which we can do to the patient to reduce the snoring and collapsibility. But when we have some definite causes identified, we can offer the patient some surgical interventions which can be planned for a single or multiple stage combination. Some of the most commonly performed surgeries, especially in pediatric cases, are the adenodoxes, although some surgeries can be taken on particular cases. I'll just run some videos, although everyone must have seen this somewhere. We're just doing a quotation of myectomy. This is a surgery, it's tonsillectomy, where we do some partial removal of the tonsils. But this is not something offered by us to the patient. This is some patients' parents insisting on saying that we don't want the tonsillectomy done, we don't want the tonsils out of the patient because of some misconceptions they have, and we were not able to convince them. So we at least did some partial tonsillectomy to reduce his obstructive levels. The patient benefited, but this is not the standard procedure which we do. And now coming to the adult OSA, there is a number of surgeries which can be performed in standalone or in combination. Again, it can be planned as a single stage, multiple stage. There are definite nasal obstructive surgeries which can be identified and offered. We have seen adenoids present in adults very commonly. The last, I think the most highest age of a patient undergoing adenoidectomy was I think 38, the very last. Again, tonsils, palatal surgeries, basal tongue surgeries, epiglottis, and in many cases, because of craniofacial anomalies, we can offer some maxillofacial surgeries. Again, I'll just run some videos. They're all expedited videos, so we won't waste time. These are commonly performed surgeries for an AD surgeon with the focus on USA. Again, some sinus surgeries also sometimes are warranted, which can really help the patient. A lot of palatal procedures, although it started as UEEE, it has now fallen into disrepute because of its high failure rate. You can do a lot of other surgeries with different limbs mentioned here, but ones which have stood the test of time is the expansion sphincter plastic, and now the BAP plastic is underway. This is a form of expansion plastic where we are actually reducing the bulk of the soft palate and then getting anterior, posterior and lateral expansions done so that the vena is much more stringent doesn't collapse and reduces the further collapsibility down the lower airway. And forward it. This is the theoretical aspect of PARC plasticity, where from PARC wires are sutured, you see the same results what we expect from an extension spectroplasty. As mentioned, the maxillomandibular advancements can be done for people with retrorhynchia or some other craniofacial anomalies. You can take the help of a maxillofacial surgeon. You can make a team and plan on the surgery. This is something which is a US FDA approved, but not available in India right now. This is a hypoglossal nerve stimulation, where a pacemaker-like device is planted onto the chest. And the hypoglossal nerve is stimulated while sleeping, so that the tongue is put forward during inspiration. This is something which we will definitely avoid, but a grossly morbid obese patient, maybe 600 pounds or something, is not able to do anything else. The only way out may be a crime. Quickly, as we come to the summary, see that OSA is usually part of much more complex situation and often associated with comorbidities. The patient may not come and complain to you about OSA, but definitely need to have a very high degree of suspicion. Proper counseling of the patient and the family is paramount. Short-term and long-term goals of the treatment needs to be discussed and realistic targets depending on each individual has to be taken into consideration and a multidisciplinary approach to development. I just wanted to say that every person who has been diagnosed with OSA should always have a ENT evaluation just before dispensing of a CPAP to the patient. Thank you.
Thank you, Dr. Thanks for this nicely explained. And regarding OSA or this sleep apnea, many of us we are suffering, but very rarely we see about it. Somebody else have used it was suffering like that. So very nice presentation. The topic is open for discussion. If there is any query,
I would like to know one thing. What should be the BMI of the patient in case of
BMI.
What should be the BMI in an obese patient selected for oral surgery? The standard BMI.
Okay. If we usually it's taken for thing that anything above 30, if the BMI is above 30, the surgical outcomes
Will be good.
will be bad. Will be bad. Above 35 will be worse.
Yeah. So it should be below 30.
Better.
Below 30 you can get a satisfactory result. And secondly, the ASI.
AHI.
Yeah.
AHI actually that doesn't correlate with what we surgically think. AHI sometimes maybe 80, 90, and then also surgeries can be done. Maybe you won't come down to 20 or 10, you might come down to 40 or 50. That will also reduces quality of life and his OSA.
So in this basis, it is very difficult to go for this oral surgery. So we always advise for CPAP. So many patients actually dislike using CPAP. So what is the alternative treatment for this patient? So weight reduction first or
Lifestyle modification and weight reduction
but it
is
will take some
paramount.
time.
That is why we say that during this time at least we try and use the CPAP so that your symptoms reduce. Once you use the CPAP and your sleep structure architecture is better, your excessive daytime sleepiness goes. What happens is a patient who is already lethargic in the day, he cannot go for a morning walk or exercise, he's not motivated enough. Once you use the CPAP, your daytime energy comes back. That also motivates him to change his lifestyle, maybe go for exercises and some modifications.
Thank you.
What are the criteria that you choose for surgery? Most of the patients whenever there is OSA, we go for a CPAP trial also. And some patients accept and they go for CPAP therapy. But what are the basic criteria that on the first go, we can suggest them that you should go for surgery?
Let's categorize this in 2 ways. Yes. One is the children suffering from OSA, where you definitely see that there's a grade 4 adenoid, grade 3 tonsils. There, it's a totally different ballgame. But when we adults, until unless it's a very process of nasal polyp, palatal polyposis also, where there's a surgical option. Other than that, I never give a surgical treatment as a first option.
But with those with huge tonsils and all, you ask them for surgery?
It's multifactorial. You have to, because you cannot guarantee a patient with OSA that if your tonsils out and you will not be snoring anymore. That is not going to happen.
But you will take it by your diet.
Pardon?
While doing your diet, diagnosing the endoscopy and
I don't do diets for all patients. I do diets only if you see that your endoscopy is not giving you results which you actually thought would happen. Over a period of time, if you expect this kind of a collapsibility, which you are not seeing on awake endoscopy, that's when dice is going to make the difference. But I don't think dice is going to be the law for all the patients.
Do you think that the surgery and the CPAP is complementary to each other?
In some cases, yes, definitely. Some cases, they are so bad that they are not able to tolerate the CPAP.
Yeah.
We say that if you reduce some obstruction factors, maybe you tolerate the CPAP. Just like doing a tympanoplasty, so that you can put in a hearing aid. That kind of situation.
And after your surgery also, you can consult the patient that after surgery you can go for CPAP in a better way. So viability is better.
Counseling is most important, and not only for the patient. It has to be a bed partner.
Nice. Thank you.
Is there any role of modafinil in OSA?
Yeah, a lot of talk has been going on so that it reduces weight, but I don't have much experience in that.
Hello, no smaller devices available other than the CPAP. No smaller devices available other than the CPAP.
Smaller device, ma'am?
Sheet over the mouth to make it mouth open during sleep in the night.
There are a lot of oral and mandibular devices. If you just go to Amazon and you put devices for OSA, I think you get around 80 to 100 different kind of options to buy. And they are all selling. And the problem is obesity, OSA, or any other chronic disease. Every patient wants simple solutions. They don't understand this is an ongoing thing. It's a chronic thing. It's maybe a lifelong thing. So the participation of the patient is like taking your diabetic medicines regularly. The doctor is not going to go and remind you have to take it today. You has to be conscious in yourself, and you have to monitor it, you have to take the medicines, you have to control your BP. So those kind of factors, it has to be instilled to the patient.
OSA has now a living problem like sudden cardiac arrest. So that's why what you advise.
Now, it's a syndrome, it's like a metabolism. There are so many factors everywhere. So each patient will find out what are the factors he's having. Not only obesity, the genetic factors also come in. So those kind of counseling needs to be done.
Basically, for him he become hypothyroid also. Metabolic disease increased by weight. That's the most important. So one thing.
There are patients were taking 3 to 4 drugs just for hypertension, by just giving us whatever things you are doing, maybe lifestyle modification, a CPAP or a surgery, he maybe coming down to a single medication or two medications.
No, actually, people are neglecting this because he has taken the subject, very nice. But very less people in Northeast is taking this subject. Therefore, I ask him to put this paper here. Because all pulmonologists, they would put a CPAP. And without thinking how the airway is. But they do not send the case for dice to him.
There are also patients who are not the CPAP.
The filler.
Use it for a month or something and then put it in a cupboard.
That's what I want to say. People are ready to take medicine for diabetes. People are ready to take medicine for hypertension, which is not going to be cured, which will leave until his last day, but they are not ready for the treatment for OSA and not coming to the ENT surgeons for a checkup. So we have to impress him that everyone should come for a ENT checkup. What you have given in the last slide, and that is the most important thing. Everybody should impress. If any family member is there, we should try to impress upon them. Come to the ENT person once, let him get diagnosed. That will go.
Usually 100 patients that comes to us, we don't offer surgical actions to 10 or 15 also.
No, we are
And
not.
out of that, only maybe 1 or 2 undergo the night. But again, I think that is also a good person.
Actually, sleep is a science, not arts. Actually, therefore, people do not think that sleep may cause more high rate of sugar, hypertension, high hypothyroid. They never think. They,
I have this, my father.
my brother,
It's common because generations in our house.
Genetical factor.
Genetic, but they are happy about it. They are happy about it.
Like that. Everyone does. Nobody is having any problem. So we should take care of this.
I think we should end here because time is running short. Once again, thank you for Adola.
Thank you, sir. I would like to request the chairpersons to
Hello. Good afternoon, everyone. First, I'd like to introduce myself. I'm Professor Nagesh, Professor at Department in Genetics. I'm University for chances First of all, I'd like to thank the organizers for inviting for a topic. I'd like to take as little time as possible, but I passed my MBBS in 1987 and did my DLO in 1989. Since 1991, I have been working as an ENT surgeon, and during my DLO and MS, I didn't have any chance to do endoscopy. So I started learning from different teachers. Like I even went to abroad to Amsterdam Medical University under Professor Fokens to learn the sinus surgery. Then my microear surgery was a long time. I have been working for over 15 years. Then from 2003 onwards, I have been working in endoscopic ear surgery. So since 2009, I have stopped working with microscopes, especially in the ear surgeries. Completely, I have shifted to endoscope. That's what I want to say. And I'm using with only one hand, and I'm not doing any dual hand with a holder of the scope, because the advantage of the scope is completely removed when we use a holder. That is why I don't use it. Anyway, so the meeting was since 1801. Bosnia was first endoscope for visualization. Then in 1879 and 1901, Hirschman modified the cystoscope to examine sinonasal cavity. Then 1954, there was a technological breakthrough. Hopkins introduced the fiber optic endoscopes, flexible visualization of the larynx and sinus cavities. And 1960s, Hopkins brought endoscopes clarify with clarity with a wider field of view and improved illumination. Most of you must be knowing these two fellows. One is Marcel Klinger. Since 1970, he started doing endoscopic sinus surgery, and I've been lucky to meet Professor Sternberger, both here in India and abroad, and I've been working in his under his instructions, and also through Professor Fokens, and everyone must have seen him working. So nasal endoscopy has really brought out interesting accessory angelic ostium, which cannot be seen with the conventional methods, that is super sonization. Now I'm showing a small video of the AC polyp. This during the time of my house staff shift and my post-graduation. I could not even see the operation being done by my professor, so I had to improvise myself. So first, after removing it, only polypectomy is not sufficient. All this I am doing under local anesthesia, and 99.9% of my surgeries I do under local anesthesia. And this is the uncinectomy. And after uncinectomy, after removal, we have to increase the maxillary osteotomy, and we can go inside. Here, first of all, you have to widen it. Then, yes, suction is very much important because all these fluids like in air secretions. Then this is the final view, and you have to just make it smoother. And this is the final picture. And now, see the ENT subspecialties. And actually, I'm sorry, because of little time, I could not show any other big surgeries. And laryngology provide an event of the flexible fiber stops. I want to show a small video here. This is with nasopharyngeal flexible endoscope with working channel. And especially the fish bones in the valvula and just in front of the epiglottis is very difficult to remove. And this has been done under local anesthesia and in my OPD clinic. This I cannot speed up the video anyway. So it is almost done. This is this is the front body, and you can see my forceps coming now. This is the forceps, and you need a little hand-eye coordination, and the patient is very cooperative. You can see this under local anesthesia. Patient doesn't give you any problem. Patient is silently lying down in the table, and this is these are one of the most common sites of lodgement which the patient needs to remove in case of the fishbone throat. Otherwise, most of the fishbone throats, you either get it in the tonsil or elsewhere nearby, and it is very easy to remove. Anyway, now we have nasopharyngeal surgeries and clarity, minimally invasive precision laser surgeries. Then we come into the ear. These are two great fellows and some other ROs here. Professor Most Taradisi right now is in Dubai, and Daniel Marcioni, pioneers in the give us the nice 36-degree view of structures. Actually, most of my college diploma surgeries I do trans canal. Here is the results of my surgery. I just want to make a video showing you this is a video of the mastoid. And it doesn't need any problems. And here, most of my transcanal endoscopic surgeries, I do uniform epigotomy or epigoenterotomy. They are all done through the natural route. This is an example. I had already inserted a flag to make the intact tympanic membrane you're seeing. I have already elevated from there, from about 11 o'clock position. I am using radial here with the inspira terminalis, and then and most of the surgery I do inside out. I traced first I checked the machines and linear capability is completely okay. And the movement of the oscillants are also very much intact. So now my job is to lead the college diploma. And so This is the smallest timber and with the timber stuff like this. Usually, I changed the disease from the origin. It is from the area. Maybe the sponsorship area, marginal perforation also I usually pursue it from there and keep on going inside out. And this is a gel form or aerosol which I usually give to in the middle here just to safeguard the ossicles by like drilling. And you see the drilling is minimum. If you are coming from outside, it's from post-molecular approach, it's really between by around. And here I'm using the curate until the size when I can put bigger bursts so that the section will be bigger. At times I used to do curating just to make it easier and controllable. Because sometimes the bigger birds I cannot see properly. So I use small ones just to make it easier for me and to set all the procedures which are detected. So the process goes like this. Just trying to faster anyway. To the last. This is This is a transcontal endoscopic approach, which is an extensive polystopic demonstration. I've been improvising since 2017 because I showed it in 2019. And basically, here I'm combining the angioplasty with the hysterectomy. But still, the transcaral hysterectomy first completely liberating this skin. I know that it's an extensive hysterectomy, so I'll be going straight away from there to the concha, and after removing the concha and preserving the conchal cartilage and the pericardium, I take it for the graft. I do all the dissections from here. This is just to assess the depth, vertical incision, 10 mm from 2 upper position. Then I come it towards the incisional, that is from 2 upper position. Naturally, I use, most of the time I do only from the 11 upper position, then I come from 2 upper position. Right out. This is the ground that I have taken. This is the drilling than acting. Here, no obstacles are here. And this is the final drilling along with the diamond work. And we could completely remove now. I'll be treating the cavity. Before that, this was left with the osteoplastic. And this is the these are the complex pieces for making the cavity and put it. And this is putting back the anyway, I'll just finish here. Can you still hear now? Is it coming? I can finish. So, what I wanted to show is end result also. Sorry, end result will be much better. You will see completely intact here structure now, along with a little wider external canal. But result is very nice. And time is running out, I'm going to show you once more. The water resonations and the high definition here. We have a high resolution, a high definition video imaging, wide field endoscopy, enhanced surgical precision and outcome, integration with the lasers and 3D imaging. Is a 3D imaging can be enhanced tools like the 3D endoscopes and augmented reality are using long range tumor rejection and reconstructive surgery. This I'm not doing, I'm just waiting for the sake of completion. And there is future directions. We have assisted navigation, combined endoscopic views and real-time surgical guidance systems, robotic endoscopy, enhancing dexterity and narrow anatomical spaces. This was something. Thank you very much for your patient listening. Thank you.
Presentation in ENT actually, and you concentrated more on the US surgery. And I think US surgery is going a long way with the endoscope now. And actually we are running short of time, so if there is any questions from the audience, you can ask from the post-lunch or during the lunch session itself.
Thank you.
Thank you, sir. For this session are Dr. Apurva Kumar Sharma sir and Dr. NEBAOICON Sharma sir. No
Next speaker is Dr. Hemanta Mohan. He is a consultant and neck surgeon, Vispu Polyclinic and Hospital Private Limited. Dr. Mohan, you will start your presentation. You will be speaking on fibrous dysplasia. Topic of discussion is fibrous dysplasia of the ethmoid region in rare case presentation.
Good afternoon, everyone. I would like to first convey my sincere thanks to Dr. Folgrova for his untiring effort to make some conference a success. I would like to today present the rare case actually to address dysplasia of the ethmoidal region. Fibrous dysplasia is a congenital non-hereditary disorder. It's equal actually in both frequencies. The development anomaly of the bone formation, as you know, it is replaced, normal tissue is replaced by the fibrous tissue. Normally, the bones are more common, fibrous dysplasia common long bones. However, in rare sinuses, it is much less common. And whenever it presents, it always presents a diagnostic challenge. In my case, it was a 63-year-old male patient who came to our department actually. His complaint was a nasal obstruction with a left-sided headache. His diabetes was for almost 10 years, but he has not given any history of any other problem like rhinitis, hyposmia, or vision disturbances. Now, his preoperative investigation we have carried out, pathological investigation was normal. The patient had a little bit of hypothyroid. His cardiovascular status was normal. And even the chest X-ray also, we have done that all normal. Now, important part of particularly fibrous dysplasia is the radiological investigation. Particularly, you have few tools to diagnose it. The gold standard is we can say is a CT scan. And on CT scan on this patient, we have found that this patient is having well-defined heterogeneous ground classification in the left ethmoidal region. Yeah, you can see, because this is the sagittal part, you can see this is the region that has been, this is the region, ethmoidal region, well overseen with heterogeneous or situation here, both cystic and fibrosis. Now, along with this left ethmoidal, we can see both ossific and calcific areas. In between, we can see the soft tissue component also. Now, this extension of this lesion can be also seen after the frontal sinus region also, and downward to the part of the nasal cavity also. Now, here in this you can see a DNS map, DNS, then the turbinates are not well visualized. Turbinates are not well visualized here also. Now, they are the associated thinning to show it in Dutch. Particularly frontal sinus. Yes. There is associated thinning of the left frontal sinus, moid, as well as medial wall of the orbit also seen. And we can see there is obliteration of the osteometal unit with blockage of the maxillary. Then the second investigation, we have done is the MRI investigation. We have carried out the MRI investigation of this patient also perioperatively. The MRI, we can see a little bit better or some of the soft tissue lesion in the ethmoidal region, it is more delineated. So we have done this and we have found that left and frontal sinus extending an extension to the other part of the nasal cavity also. Particularly T1 lesions, there is a hypointense lesion we have seen, and in T2 we have got a heterogeneous hyperintense lesion we have seen. This is the MRI picture. Yeah, this is the MRI picture. So this MRI picture, see, this is how this model this lesion is nicely shown in MRI picture also. Now, there is a contrast study in the MRI also. Now, in contrast, there is a mild heterogeneous enhancement of the ethmoidal region is more properly seen. There is no significant enhancement in the frontal region, but there is no intracranial extension on this MRI. This is MRI report. Then we have directly gone to the surgical management. Now here comes the biopsy. Is the biopsy absolutely necessary in cases of this lesion? Particularly in cases of CT scan, we found that there is a ground glass appearance, then other parameters which is clearly seen in CT. That's why we have directly gone to the surgical management. So you can see this is the lesion. This is the bone fragment we have removed from during the procedure itself. You can see we are removing part of the cystic lesion also. We have used the microdeal. This is the lesion. We have removed it. This is the part which are removing through our process from the point lesions. And this is after removing all this, so correcting the sinus, osteometric unit, the other part, anterior. We both have done, me and Angan both have done this surgery. Even though very rare, we have removed at most removing everything as far as possible because it is extended up to the other parts also. So whatever possible without damaging the part, because we have gone to the base of the skull also. We use microdebrider most of the time. The biopsy report you can see. The final we have sent the biopsy. Biopsy says these are suggestive of fibrous dysplasia. This is the pure case of fibrous dysplasia. Now the micro photograph you can see. This is a micro photograph of that. We have seen intermittent heterogeneous tissue with a soft tissue component. This is the micro photograph of the patient. Now you can see the 4th week. We have followed, and on the 4th post-operative week, this is the there is smooth lining without any recurrences. Then on the 8th week, we have, this is the condition of the 8th week. There is no recurrence, the healing process is much better now. Now, a little bit of discussion regarding this case. As you know, it is a non-cancerous condition. Always the normal bone is replaced by the fibrous and the abnormal bone. This is a prevalence, it's a very rare condition actually. It's all benign tumors. Location, you can see that you can affect. Ethmoidal bone is much less affected. Even the other paranasal sinus are more rare. Yes, more rare. Now, patient comes sometime with asymptomatic condition, where it is usually discovered due to some other problem for which the imaging is advised, and in such cases, asymptomatic case can be detected. In symptomatic cases, you have all these problems. Then facial asymmetry, progressive headache, visual disturbance, nasal obstruction, eye pain. These are the symptoms normally in cases of fibrous dysplasia having a lot of problems. Patient having this ethmoid region and other paranasal sinuses. Imagine the gold standard, you can say, is a CT scan, because CT scan, it is the ground glass appearance, the typical of fibrous dysplasia. Here in this case also there are a lot of bone expansion and obliteration of sinuses in this case. MRI finding, just additionally we get a soft tissue involvement and rule out the other conditions. MRI is better. Biopsy, yeah, may be necessary to confirm the diagnosis, especially in atypical cases. Biopsy is necessary. Now, what will you do in cases of asymptomatic cases? Nothing, but you have to observe and you can do follow up with a CT scan to know the status of the progression. Symptomatic cases, we sometimes do surgical intervention. Why surgical intervention? Pressure release from the vital structures, correct deformity, radial, and what we are doing in these cases, also these are the things. There are now surgical approach, there are open approach and the endoscopic endonasal approach. Which is always preferred. Open approach says if there is some intracranial extension, then you can go for open approach and you will require help of a neurosurgeon. Now this medical management is there, but it's a very commonly not done. The base phospholipid it just reduces the bone turnover. In our case, it is not the case, so it is in medical management, it can be helpful. Yeah. This, particularly in prognosis and follow-up, you can see this condition is benign and recurrence is possible. In this patient also, it is not, because we have seen him for 2 months, so much longer to be followed up. He might come with a recurrence also, but that is why in such patient you have to have a regular follow-up, maybe 6 months, 3 years. And CT scan is very crucial to recurrence for any patient having fibrous dysplasia. Now, malignant Now, for female management, you have to have help of the otolaryngologist, ophthalmologist, anesthesiologist.
Thank you. Very nice presentation. You have said that there was pressure on the eyeball. So have you assessed the eye vision and eye condition?
Yeah, it was said by our ophthalmologist. He said that the pain is due to the only compression possibly from the factors dysplasia external more expensive.
Another thing, osteometrial complex was blocked. So
Yeah.
have you opened that area?
Yeah, we have opened. We have opened up and we have actually done it practically. ESS also.
Thank you.
Thank you. It's a very rare case. You have presented this case very nicely and operation was very unique. So when you did this operation,
It has been done almost 3 months ago. Yes, 3 months ago. We are still patient is still on the follow-up. And he is doing well. His pain has disappeared. He is not complaining too much. He is fine. But still we are following up.
is there any proptosis?
No, there is no proptosis. There is no visual disturbance was not there. He is only complaining of unilateral left-sided headache. The problem was on the left side.
I have seen a case of fibromyalgia, covering the whole upper part of the skirt, from the skirt on sides, with lots of deformity. Lots of deformity, looking of the eyelids, and deformity of the nose, then he has some swelling like this coming on, like that. I made only the bulk notes.
Yeah.
I could see nothing.
Yes. We have recently seen a patient of Herders dysplasia. He was having purely Herders dysplasia of the maxillary sinus and maxillary wall. So it was not involving the other parts. So this is yes, we explained him that it might go to the other area, but you have to keep in check. That is another form of Herders dysplasia.
So one last question, is there any classification?
Yeah, there are monostatic or polystatic. There are 2 classifications.
So thank you. The organizing committee instructed us to not put more questions. No. Thank you.
To make sure everyone feels appreciated, we have felicitation to single events.
Without much time, I would like to start the discussion on the record. It's just not a discussion between the moderator and the panelist. Actually, I also want input from the audience as well. So, hello, everyone is hearing me? Yes. I think in our classes, last benches did very well in our final exam. So I want input from the last benches as well, so that we can make it more interactive. So we have 6 panelists here. We all are from ENT background. We don't have a neurologist, we don't have a radiologist here. So we'll discuss on ENT point of view. We all are trained in neurology certified course under our master, Dr. Srinivas Dorasala. And because of that, maybe our views will be similar, but we are not. We are working in a different. We are working in a different situation. So tackling the cases will be different. So they will represent each one of you. I would like to introduce my panelists. Dr. Anjali Guru ma'am. She is also past president of NEBAOIC, and we have another past president from NEBAOIC, S.N. Mukherjee sir. They are like, just can't believe at this age, they have picked up this subject. It is so tough, but hats off to you too, because you have done a great job in joining the course, and you are doing a great job. And Anjali ma'am is that, you all know, she is the consultant ENT from Lincare Hospital, and she has been awarded an eminent doctor from INA headquarters. And S.N. Mukherjee sir has done a great job in Railway Hospital. And we have the one who has led all of us to the neurology, introduced us to our mentor, is none other than this Dr. Surajit Parla. And he has a wide experience of 19 years to be in the neurology. So I definitely would like to hear from him as well. We have another young neurologist, Anjali Guru. We'll hear from him as well. He is presently associated with BS Sangma International Medical College. We have we have Supriya Sintam. She is coming all the way from Imphal, and she's doing a great job not only in the neurology as well as in aesthetic surgery. And whenever any neurology conferences is happening in Northeast, she will be coming only. So thank you, Supriya, for joining us. And last but not the least, the one lady who always accompanied me in any neurology conferences, Dr. Fauziya. She has done the course long back, and these are my panelists. We'll like to hear from them. Before going to my first case, I have taken two scenarios. The first one, I just want to ask from the audience, how do you feel like a patient in the last 5 minutes before closing your OPD, if patient is coming with acute vertigo, nausea, vomiting? How many would like such type of patient to deal with at this hour? Kindly raise your hand. Anyone? Okay. So thank you. And anyone else? So probably you all will not like to handle this case, not feel like to handle this case until you have a proper way to go how to deal with these cases. So we are here to guide you how to deal such type of patients. So this is my first case, a 50 years old businessman, non-diabetic, non-hypertensive. He was complaining of intense pain of getting up from the bed in the morning, and it was lasted for 7 days. It was associated with nausea and vomiting. My first question to one of the panelists, maybe S.N. Mukherjee sir, so how do you approach this case? Be precise so that we can do justice to the speakers behind us.
Okay. 55 years, and patient is non-diabetic, non-hypertensive. He is having vertigo for last 7 days with history of nausea, vomiting. Naturally, we have to keep out any inflammatory pathology which has caused the whole thing. This inflammation may be at the level of the labyrinth itself or central lesion. So then we have to go further into it. Therefore, we have to take the history, what was the character of the vertigo, is this true vertigo, the external or internal vertigo. Number two, any precipitating factor which has caused this thing, any positional change of position causing vertigo, or the patient has intense cough, after that patient is having vertigo. So the proper history has to be taken. So we have to spend a lot of time in the history itself.
Okay. So your first preference, you have to have a good history from the patient. Anjali ma'am, do you have any other approach? Because we cannot have much time to deal with this patient. So how
this is with history of vertigo and
please history is
already there. I have vertigo for so many days and nausea, vomiting for so many hours. We have to think that it may be a case of from central origin or from peripheral. That we have to differentiate.
Okay. Dr. Suroji, how do you approach in this patient? You have a, what I mean, I've been giving my clue. Do you have a proper agenda in the history taking or any other way to go to the case?
You show the previous case report. Yes.
So, acute vertigo, even before taking the history, with most of the patients I try to do the HINS, just to make sure that this is not something central, because anything central requires immediate neurological evaluation. But if HINS tells me this is peripheral, then I think this is the proper protocol to go for the history.
Okay.
So, because you have told that this is a history of 7 days, continuous vertigo. So, whether it is a continuous or intermittent or episodic, that point we'll have to make it sure. Sometimes the patient says that this is continuous vertigo, but patient is letting on a BBAB. Because he says that yes, I have continuous, but we'll have to make it sure, particularly if there any point where, at what point you feel better. If there any point in between where you were better. So if the patient says, no, I was not at all better at any point, then it is not episodic.
Dr. Supriya.
Yeah, I agree with Dr. Anjan. In acute presentation, like this patient presenting with the symptom of nausea and vomiting and 7 days duration, I will go for a syndromic approach and will treat accordingly and try to extract from the just a short history, so we cannot consume time much. In such a case, if we are coming at the end of the OPD, and also I'll do a syndromic approach and try to do to rule out the central and peripheral lesion.
Okay. Dr. Bhodia, so if it is a syndromic approach, what is syndromic approach?
It is actually depending on the time duration of the problem. The syndromic approach is divided in 3 divisions, and accordingly we assess the patient.
So this is a case of acute vertigo, spontaneous onset, lasting for several days. So what, along with that, we have to include the history. The patient was having hearing loss, tinnitus. There was no fullness in the ears, no complaint of loss of strength or except that there was weakness in the one half of the face and patient was ignorant in the dark and felt disoriented, especially after dark day. And there was no significant past medical and family history. Now, how we can approach? Now, at this stage, how you defend the hearing loss, how you defend the weakness of the in this case. So I think for that you need to examine the case. So what the panel says, some of the panelists are agree with the syndromic approach, some are familiar with history taking. If I ask you like history taking, do we follow any particular format? So, Jay ma'am?
We follow the stone approach. And in the history taking, if we take the history taking, then we have to know the nature of dizziness and all whether spinning, any rotational sensation, imbalance, then whether any accompanying factors are there or not, any triggering factors, and even time duration is very important. The duration. Along with the thing like any hearing loss, that is very important.
Can you elaborate what is soapstone is about?
Yeah, in soapstone, according to the mnemonics, we'll see about the symptoms, then about the duration of the disease, then what procedure has started before the procedure, like history of fever, the patient had upper respiratory tract infection, and since means not the time, but actually it's also illness preceding that condition and the trigger, what are the triggers, then autological fact, any symptoms are there, neurological factors, and evolution and of course the evolution of the duration of the disease.
So anything to add in this rostrum, it is sufficient. So Rajit, can you add something?
Soulstone is by itself very comprehensive, but there are some lacunas, not exactly lacunas, there are certain cases where we miss. I think one better approach was what Supriya had mentioned, the syndromic approach. So if I can read out, the syndromic approach has been popularized by Dr. Srinivas, where he has basically divided it into 8 different syndromes, which are number 1, recurrent spontaneous vertigo lasting minutes to hours, sometimes days, recurrent spontaneous short-lasting vertigos, dizziness or pulsions, recurrent immediately triggered short-lasting vertigo, falls, predominant complaints of difficulty in walking, first episode of vertigo dizziness, chronic persistent and recent onset. And when we try from the history to put a patient in one of these, what happens is not only do we get to a diagnosis very fast, but that also leads to the management. So whereas Soulstone approach can tell us a lot about the dizziness, I think syndromic approach is much more clinically practical.
So it is the first ever acute adult isolated spontaneous vertigo. What differential diagnosis is coming to your mind? Dr. Forger, can you add, or you can add one by one? Repeat 20 minutes is over. 20 minutes is over. When 20 minutes over? Okay.
There is dizziness, hearing loss, and there is facial weakness in one side. So my one of my differential diagnosis will be labyrinthitis, or it may be a vestibular neuritis.
We'll come to that hearing loss part because we have not examined the patient yet. So even as a first ever acute isolated spontaneous vertigo, what differential diagnosis is coming to your mind?
Isolated spontaneous vertigo episode is the most common cause in the vestibular neuritis. If there is no other symptoms like the ear symptoms. And we will have to rule out some central cause of vertigo which is continuous. We will have to rule out labyrinthitis or other ear infections and all the viral infections in the ear. So we will have to rule out all these things.
So we have to rule out the first episode of vestibular migraine as well. And anything else?
Yeah, it may be the first attack of the menias because menias also primary attack. Unless you all know the character of the menias, but then first attack may be confused because you don't have the past history of the similar.
So from the history, how can you rule out many of this? We have 6 now, 6 differential diagnoses. From the history, how can you short it out? This is not the case.
Very clearly, first of all, menias. If we think of the menias, low frequency, deafness and oral fullness, history is not there. So we can straight away eliminate that. Then comes past episode of vestibular migraine, of course it is difficult. And again, history of migraine in the families, that has to be
there was
taken into
nothing.
account. Then comes demyelinating disorder, multiple sclerosis, etc. That will have other neurological findings also.
It depends on where the focus is. If it is at a root entry zone, you might get only the acute vertigo. So demyelinating disorders will get usually you will get a previous history of any neurological deficit. So it is also out.
Then comes cerebral infection. Of course, cerebral infection will have the desaturated rigidity, polyphagia, finger nose positive.
So we are talking about history.
Cerebral ataxia, all this.
So this is some best on history because we are here to examine the patient. So cerebral infection will rule out any post-traumatic stroke because patient didn't complain of any neurological deficit. So only this is facial weakness. Facial is there in the internal auditory canals and it is near to the vestibular system only in the internal auditory canal. So it is far away in the brainstem facial nuclei and the vestibular nuclei. So it cannot be anything in the brainstem. So it is maybe something here in the near the internal auditory areas. So we have to sort it out, it is near the internal auditory areas. So now, so already it is mentioned by Surojit that we do H plus. So we do the hair impulse test. If it is pathological to one side, that means that side vestibular function is that is not functioning, and nystagmus will come to that. We will show the nystagmus, and skew deviation is a feature of central phenomenon, and also hearing test is very important to differentiate in it is a peripheral or central illusion, because we don't want to miss, even if you fail to diagnose a case of vestibular neonitis immediately, but we don't want to miss a case of posterior stroke. It will be a crime on our part. So, so we, for others, I just want to say, we always follow a pro forma. Can you elaborate, Supriya, a little bit?
We see for the pulse and BP to check orthostatic hypotension and check the voice if any cranial nerve 10 is involved. Then speech also to check the cranial nerve. The facial nerve for the 7th nerve, we have to examine the cranial nerve for hypoglossal nerve by seeing the tongue protrusion. Then 10th nerve again by seeing the sopalate mobility. Then eyes, we have to check for any conjugacy. Size of the pupil is also very important. Sometimes we can find meiosis also in central region. That we have to see it, and also the skew deviation also can be seen from the eyes by seeing the conjugation. Then nystagmus, we check it whether it is most of the vertical nystagmus we see in central region, but this horizontal torsional nystagmus can also be seen in central region, but to rule out central region, we have to go and check for the gaze holding nystagmus. That is to check the nystagmus in both the left and right and up and down gaze. Then the skew deviation I've already mentioned. Then we have to also to check the oculomotor examination like the chakras, the smooth pursuit. Diplopia charting is again important. We have to check in which gaze the patient is having diplopia, and accordingly we can identify the site also whether internuclear ophthalmoplegia is there or not. Then 222 test is again important, that we have to check the sensation of touch and fine touch and temperature in two body sides, that is the upper portion, the face and the body, and also two sensation, and then two sides, right and left. Then finger nose case and this diadokinesis, everybody knows it is to check the cerebral coordination.
So basic aim is just we check whether patient general examination, whether BP is controlled or not. Then we have to rule out bradyarrhythmia, and all the cranial nerve examination, especially the lower cranial nerve environment examination, as well as the oculomotor test. Actually, by these tests, we are mapping the brainstem. Is there any lesion in the brainstem? Because we can locate where the lesion is. So the basic aim is to check all the lower cranial nerve and also the oculomotor test. So also we check the gait of the patient. Also, we cannot deny that it's not a case of TPPD. Also, positional test is very much important in these cases. So I would just like to show this video. This patient spontaneous nystagmus. This is not, it is a 7-day duration, so some amount of compensation has occurred. So you can see in the later part of the video, you can see little bit of right pitting nystagmus. So it is with fixation. Now we have removed fixation, we cover the eyes, then we'll see the nystagmus pattern. Can you appreciate the nystagmus? It is, this side is right side, this side is left side. So it is a right breathing nystagmus. So nystagmus, which is prominent on removal of fixation. So it is in favor of a peripheral lesion. So in favor of peripheral lesion. So it is a case of vestibular neuronitis on the which side? Left side. Left side. So what happened in peripheral vestibular lesion? You're right. This patient is left side is not working, and even in normal situation when our head is not moving, even then our vestibular nucleus will try to keep the equal input so that will not get any nystagmus. Suppose your left is gone, so right will push your head eyes towards the opposite side. So slow, that will be the slow component, and there will be rectification. That is the first component. So this is in favor of peripheral vestibular lesion. Now look at the picture of the patient. This patient is having lower motor facial nerve palsy, and also you can see the blisters in the pinna, and also vesicles, ruptured vesicle in the external auditory canal. Now, what is your diagnosis? It's a So now we can justify why hearing loss is there, why facial weakness is there. So now Mukherjee sir can think better that why the patient is having hearing loss, vertigo, facial palsy.
Sir, this is all because of anastomosis we have at the ISC. Because yes, this is the worst anastomosis and worst anastomosis. Because 7th nerve is connected with the inferior vestibular nerve. So also there is the anastomosis from the 8th nerve itself with the 7th nerve, superior vestibular nerve. And at the level of the ventricle, both superior and inferior is united. So this is the reason. If there is a geniculate ganglion virus, that will ultimately transmit to the vestibular nerve, and until you go to the labyrinthitis, so also the patient will have rash on the pinna.
So, how will you differentiate it from posterior fossa stroke? So, Surajit? Anything to add?
In Higgs plus, head impulse will in posterior fossa stroke, head impulse will not elicit any corrective setback. In nystagmus, it will not follow the Alexander's law. So, central posterior fossa strokes, the nystagmus will not be more towards the site of lesion. There will be change of nystagmus direction. So, right side will be right PD, left side will be left PD in posterior fossa strokes. Likely we will get a screw deviation, and hearing loss may not be there. Posterior fossa stroke unfortunately can also lead to some amount of hearing loss, but it's unlikely to be there. So I think this is one of the best ways.
Anything else to add?
Can I add one point?
Yes.
Just a minute. In a patient with posterior fossa stroke with acute vertigo, this patient cannot stand.
Not always. I refer you, not always, because I'll show you one picture. The posterior fossa stroke gait may not be affected in patient, imbalance may not be that there. So it is not a diagnostic feature of patient. But definitely, if patient cannot stand, we're sure that it's a case of central depression. Doesn't rule out.
Actually, the patient comes in a wheelchair. Usually, it cannot walk. Projectile vomiting. I've seen personally.
This patient rules out
and we have to add the neurological symptoms also.
That already mentioned in the history, we have already ruled out that. So, any other investigation? Already we have the diagnosis. Any other investigation you want to do?
I think video head impulse test. Video head impulse test. Functional head impulse test. This is very important because we know the integrity of the canals as well as we will do the C-bank and O-bank to know the integrity of the ventricular section.
I think one of the most important tests I'd like to do here is escalating sexuality guided. So we can do it either in a posturography machine or CCZ guided. escalating sensory image will give us a hint towards which side is affected. Obviously, FET is very important. You have already done a oculography to sonal nystagmus. So these are the investigations. Apart from the vestibular examinations, the other examinations like audiometry and all will also play.
What will be the line of management, Dr. Fortin?
As the patient is diagnosed as a malaria labyrinthitis, first line treatment will be steroid. If prednisolone is given 1 mg per kg body weight, 7 to 10 days duration, and if we go, it's okay. And we can add antiviral also. Antiviral and in steroid, we can go for
So here in the admin comes a great role because how your rehabilitation is working, we can get it from the admin.
For a short period of time, we can give antibiotics, but if there is severe
Our patient is coming after 7 days already.
Anyway, the patient coming after 7 days, he must have already taken enough antibiotics.
So we are here not to promote, we are here to give rational treatment, not to suggest anything which is actually not required. So if the patient is coming after 7 days, definitely some amount of central compensation has already occurred. If he is not, or he or she is not taking any vascular solution. So the patient is walking to my clinic alone. So we don't need any antibiotic in this patient. So yeah, definitely some sort of antibiotic.
Ma'am, giving some trace elements like magnesium, chromium, etc. and vitamin D may help to some extent, calcium may help.
You can give it, no problem. But most important is that giving steroids.
Yes. It's a long back, 8 years back, I came to a Olympic conference. One of the ward boys said he was admitted in a medicine ward. Then medicine people did not think that at the time heart attack is from DLT. But somehow they called me. Then actually I know that after 7-8 days, then he is from Guardian. He is a donkey. I still remember. He moving like this. I simply give methyl pegmycin, not pegmycin. Methyl pegmycin, 0.8 mg per kg body weight. Dramatic result. Within 2 days,
Yes, B12 deficiency can present with liquid vertigo as well. So nutritional
no, not nutrition. Then I give this by steroid. It is actually fatal vertigo.
Okay. So so we go to the second case already.
I prefer that was a god.
Okay, fine. It depends on the person to person. So second case is 57 years old patient attended ENT OPT with unsteadiness with fall while turning. For 9 years duration he was suffering. So so in the history, what he has said, he had, when I inquired, he had acute headache long years back, but he went to a local doctor, took some injection, took some medicines, and he was okay, but he keeps on going to the doctor and taking injection and tablets for his pain sensation, but I could not elicit what medicine he has taken. So, this is the, actually I don't want to go into the details because this paper I had found in one of the paper, this presentation. There is particular, we take history of chronic dizziness like this. The categories are onset and temporal profile, course and progression, age of onset. in each and every point we'll find a differential diagnosis for them. If age of onset is also important. If young adults, it will we think of, can it be a multiple sclerosis? So we'll come to that later on. So associated symptoms, trigger factor, past medical history, functional impact is also important. So this is the evaluation we follow. So we have 8 categories already. Surojit has told. Do you follow any performa to examine these cases in acute vertigo? Any vertigo patient.
So again, I think we have all done a vertigo course under Dr. Srinivas, and in that course we were actually given with 2 performas. One was the acute vertigo performa, which we have already described, where almost 2 tests and escalating sensitivity, and we also have a chronic vertigo performa. So in this patient, that chronic vertigo performa has a big role. Just to add something apart from the performa, one big important question in this patient is description of the first episode, because that tells a lot. Because that tells which way this diagnosis will be. So that's chronic vertigo performa. It's a big thing we can discuss about it.
We have acute vertigo performa, recurrent vertigo performa, chronic dizziness, also difficulty in walking. So we have different performas for each and every. So this is the patient, the severe condition of the patient, not being able to stand properly, and this is
we can see the head impulse test, the corrective saccades. So the eye moves with the head and then jumps back. Right now you can see that. Moves with the head and then jumps back. Moves it and then now jumping back. This is called corrective saccades in head impulse test. This signifies loss of vestibular ocular reflex, that is vestibule, particularly specifically the semicircular canals are not working. In this case the horizontal semicircular canals are not working. And more corrective saccade was seen on the left side, but there was also corrective saccade on the right side. So this has a bilateral disease thing. So this points towards a bilateral vestibular.
So this is the picture on functional head impulse test. You can see that all the canals are not working and vestibular score is very less. So management in one line.
Rehab, number one, rehab, but before rehab, this person should not even look at anti-vertigo.
So this is the what is called different type of presentation.
So this is the 8 syndrome that Dr. Srinivas has divided into.
And a differential diagnosis standard. So acute vertigo, coming to your clinic, if you can elicit that, you are safe.
So if we get this is a peripheral condition, we are safe.
Right-sided, left side characters support, you are safe, you can send the patient to home. So, but things are not that easy. So this is the case came to me. First episode I missed. Initially I did head impulse, I didn't get. I thought that my procedure was wrong. She came and told me that I had a similar attack, you have given some medicine and I became alright. Then this time actually struck my mind, I did an MRI, I see that it is a case of multiple sclerosis. By the time she did MRI, she developed hemiplegia. So now she is fine, doing well. So this is, don't take acute vertigo so lightly.
That is why, even if we get head impulse continuous peripheral, going for a neurological whole finger nose, true test, dysdynopinesias, all those things are very important.
That means brainstem mapping is very much important in acute vertigo. So this is a case of cerebellar tumor. He came to me after 7 days of acute vertigo. This is a cerebellar tumor. Patient didn't survive, but survived for 2 years. This is a cerebellar infarct, and you can see this old lady came to me with acute vertigo. So I have checked. Can you see what abnormalities you can see in the video? Other than the nystagmus? See the left eye. Left eye, is it moving? I don't know. One eye. The patient is having medial rectus pulse. So, and patient knee jerk is exaggerated knee jerk. So it came to mind something is there in the midbrain or bones. This area, something is there. Third nerve is affected. So I did an MRI. This is the case. It is an internal carotid artery aneurysm. This is the case. So this situation can occur.
Third nerve, the typical appearance of the eye should be not only medial rectus pulse, but the effect of SO4, superior oblique, that is done. So inferior oblique will take up. So the eye will be on one corner, on one side.
It is there.
It is saying inside
don't always bend the vestibule. So this patient came to me with so much of tremor in the hand. And interestingly, he cannot so much of tremor. So he was giving all the vestibular suppression, and he was giving Syndupa also. That what I could find that the patient was having this tremor for long duration. Then after giving some medication he developed, he just cannot be some sort of dizziness. So I checked that some medication is giving for prostate, and this was the case of orthostatic hypotension. So don't always bend the vestibule. So it is important of checking the blood pressure in lying down position and the sitting position also to rule out orthostatic hypotension. Now the most pathetic part I am coming, this is the last slide, I am finishing it here. So this is a case. He came to me after 20 years of sudden sensory neural hearing loss. He took all sort of medication. He took a short intratympanic steroid also. So for 20 years, he had some sort of dizziness. For last 5 days, he came with trigeminal neuralgia, pain. So when he was complaining of some sort of dizziness, trigeminal neuralgia, and hearing loss. So it's time to, so it is better, I didn't do any vestibular evaluation. I did immediately do an MRI check in that how, what is the condition of your internal auditory meatus, then find a large tumor, internal acoustic neuroma. So the patient is going to be operated on 31st. And before I conclude, one comment from each and every panelist, take home mention.
I think in all Bartlett cases, history is of paramount importance. We have to carefully listen to the patient, and ultimately, history patient itself will tell the diagnosis. Careful history taking is always of paramount importance, and thorough neurological examination.
One. Other you will finish everything.
Never treat. My point is never treat vertigo. Find the cause. And even if the patient comes in the last 5 minutes of your busy OPD, never treat vertigo. Find the cause.
Anjali.
In history taking, first 1 hour history is the most important. And secondly, if you find any two nerves involvement between vestibular and cochlear or facial or something else, then we'll have to rule out the other central processes.
Okay. Dr. Fauzi?
We should always give time to the busy patient. Always, then we never miss anything.
Thank you. Anjali ma'am.
I also say that we should give time to the patient and try to extract as much as possible from the patient or from the attendant.
Thank you. Supriya. Supriya.
To find out the cause, just like Dr. Suresh has said, and don't prescribe antibiotics without knowing the cause.
Thank you, panelists. Thank you. You are excellent and you are very precise. And thank you, everybody. Any
So, if the superiors note that you don't prescribe antibiotics in a draft, so you have to make it sure that family comes back, not only with the patient, comes back to you again and again for evaluation if you are satisfied.
Yes.
So otherwise, any family member may go to a neurologist or a medical person who is definitely going to give the antibiotics. So that counseling is more important. What I could learn from all that thing, that you have to counsel the patient like that. The family as a whole comes to you.
One thing I just want to add here, acute vertigo lasting for years, lasting for few hours with nausea, vomiting, we have never said don't treat. Don't treat, give him supportive treatment as a must, but not more than 3 days. Because late the central compensation comes. So after that, and during that period, you have to find out the cause. If you cannot find out immediately, you have other gadgets to prove it what is wrong. So that's why actually gadgets are important to convince the patient that what is happening.
As ma'am said, a little bit of vertigo is necessary for central compensation to start. So that is why giving antibiotics drugs in very high doses to completely hide the symptoms is also not right. But yes, symptomatic treatment is necessary initially, but that treatment should not be the end of it.
One last thing to add. What is the role of prochlorperazine? 3 milligram upper lip and is actually works, I think. I've been in 6 cases.
So, to be honest, they are claiming that they have given me paper that it will go but I have not used yet. So let me use that because I am very much comfortable with flunarizine. So I am a little shaky to use it. So let me, I am a migrainer. Let me start with myself, then I will tell you what is happening.
I want to add one thing. Start DRT as early as possible.
Yes.
So, thank you very much to all the panelists and moderator also. Actually, vertigo is a complex procedure, but nowadays we make this subject popular by discussing it in So I think already in national level, Dr. Srinivas is popular with this subject. In our Northeast, I think Dr. Surajit Verma and Anjana also, and now Dr. Anjali Borua and Anjan Jyoti and they also take that. Dr. Srinivas is the mentor also.
Every state now. Meghalaya has Admiral Julfi. Tripura has heard. So I think all the states. Assam might not be coming. So I think every state now we have somebody there.
So I think we make this
Just a final remark. So I believe the Indian perspective this vertigo definitely always is simply because the patient, as you have said, we need to give a lot of time to the patient, but the patient load in every doctor's chamber in the hospital is so much. It's very difficult to keep so much of time for the vertigo examination. So I believe this will more or less remain a specialized branch mostly. And another very important thing that Indian people mostly are very restless. Say a patient comes to you really wants, some kind of relief in within 24 hours. So if you do not give any symptomatic treatment, then what will happen? The patient will go to a different doctor. So that the patient will keep on moving. So I believe from our own branch maybe, if we can have some public awareness programs where we can teach not only the patient but the doctors also. Because before the advent of these organ-neurologists, so far vertigo, most of the load to the patient was vertigo patients were taken by the physicians. And they were treating only with the antibiotics drugs. By the time they report to the ENT doctors, either they have lost their ear or they have some other disability. So some kind of awareness program should be there. Otherwise, this vertigo management will always remain a problem. So with that, I believe if there is no other query, may we conclude this session. Thank you, Anna.
Before the felicitation and before everyone disappears for lunch, I have the honor to announce the names of the prize winners of the e-poster. The first prize goes to Dr. Anjay Kumar Paul from Tezpur Medical College. The second prize, joint team, Dr. Deepsika Bhattacharya from Agartala Medical College and Dr. Deepika Kamukar from Silchar Medical College. And the third prize, Dr. Miyakshi Gogoi from GMC. So the prizes will be very literate. So you cannot escape.
Call everyone for group photo. So everyone for lunch. Ready?
Ready? Start. Ready? Sir, ইয়াত চাব এইটো কামত চাব হয় স্যার
ডিরেক্টর যিফালে কৈছে
And now I would like to request Swagata Khanna ma'am to felicitate our. Post this, few more lectures are there and will be presided over by Ms. Dreamy, and we can also proceed for lunch in between. Thank you.
Are important. Family history has to be taken. The age and gender, males more than 45, have to be taken under consideration and should be counselled likewise. The next problem that we face is retrosternal extension. So in the last 3 years, we did almost 5 cases of retrosternal extension in the CTBS 14. So none of the patients required a sternal split. So I don't think it is really required. I don't know how many of us have actually seen a sternal split for a retrosternal goiter, thyroid swelling. So, but anyway, if we get that's the CT showing the retrosternal extension. So, if we get a patient with retrosternal extension, we always take the opinion of the CTBS surgeon. So, better to have a CTBS backup. Even if sternal split is not required, always should be done with a CTBS backup. Because sternal split, even the CTBS surgeons, they avoid doing a sternal split because there is an increased risk of injury to the rectal laryngeal nerve and there is an increased risk of infection in the cells. So even they avoid. They feel relieved if we can take out the thyroid from the retrosternal region. So the next thing is Hashimoto's thyroiditis. What to do when we get a patient with Hashimoto's thyroiditis? Or just because the patient has a Hashimoto's thyroiditis and a swelling in the neck doesn't mean that we need to pin the knife on the neck. But the risk of malignancies, especially papillary carcinoma, is more. And we also have to monitor the TSH levels. If it is raised TSH levels, then I think we should better put the patient for surgery. If the TSH levels are maintained, we may defer the surgery, but if it is raised, better counsel the patient for surgery. Now next is this papillary thyroid microcarcinoma. Usually this is an incidental finding and microcarcinomas are tumors which are less than 1 centimeter in size. 1 or equal to 1 centimeter in size. Now this also has a subtype. NIFTP, that is non-invasive follicular type papillary carcinoma, variant of papillary carcinoma. So these are tumors with very good prognosis actually. There are microcarcinomas but with a very good prognosis and only incidental finding maybe, but we have to follow up the patient. And usually the older patients are the best candidates for surveillance. So the first USG has to be done after 6 months, and thereafter every year the patient has to be followed up with the ultrasonography. Now sometimes microcarcinoma can present as lymph node metastasis with occult priming. In fact, we got a patient recently in Nagaon Medical College, came up with a node, level 4 node, and on FNAC it came out to be a papillary carcinoma. But there was nothing in the ultrasonography, not even a microcarcinoma. So that is a occult primary with metastasis. So these cases are very aggressive, and if we get such types of cases, I think we should go for we must go for a total thyroidectomy with clearance of the neck node. Okay, then if we get a microcarcinoma in the thyroid and which has metastasized to the lymph nodes, then also we must go for a total thyroidectomy because the disease is very aggressive. So just putting it as papillary thyroid microcarcinoma, a safe variety with good prognosis is not the idea. So the subtype, the way it is presenting is very important. So if it is not aggressive like the one I told, NIFTP, then we can wait and we can go for surveillance. And of course the other factors also will have to be taken into consideration, the age and gender of the patient. So that is regarding the papillary thyroid microcarcinoma. Now, if we fail to prepare the patient well, then we will be preparing for a failure in our procedure. So I would like to come to the complications now. The post-op complications, mainly hemorrhage, which can very easily be dealt with. In fact, we always store 1 unit of blood pre-operatively, but we hardly give blood. We have hardly given blood transfusion to patient with thyroidectomy. But of course, it is always that we always keep 1 unit of blood preparation. Then injury to the rectolaryngeal nerve and the superior laryngeal nerve, we can easily avoid by, it's not that the anatomical landmarks have been known. So always assist first in around, I would say, 20-30 cases, and only then go for case. So this is very rare if you delineate the anatomical landmarks. Hypocalcemia, for total thyroidectomy, we do encounter hypocalcemia, but that is only because of the shock to the parathyroid glands. Most of the hypocalcemia is transient. So, and the level of the calcium, that is when it reaches 7, we start the calcium gluconate 5 ampules. We start if the calcium level comes to 7, and we continue with that, and usually we've seen that the patients recover from their thyroid shock, the parathyroid shock, and the calcium levels come to normal. Within 6 months, usually the levels come to normal. And then the scabbard trachea, I would just like to show this photo. So if this is the state of the thyroid, when the patient turns up very late, especially in the medical colleges. So when we get this huge thyroid, we should always be careful about the scabbard trachea. So always book a ICU bed before the surgery, so that if required, if the extubation is difficult, we can shift the patient to the ICU. This patient did not require, there was no difficult extubation, it was not difficult, but then we kept the patient for 1 day in the ICU, and the patient recovered fine, no hypocalcemia. And lastly, wound dehiscence is one of the problems. If we go for mostly for hemithyroidectomy, and the sealing of the left leftover thyroid is not done properly, there is leakage of iodine, then it could be, it may result in wound dehiscence. So that is it. Thank you.
Actually, in a short time, we have given everything. I could elaborate. very confident about doing a thyroid surgery, that blood is not necessary. So, yeah, maybe in a situation like
No, but then the anesthetists, they always, I mean, they will just reject the patient if you don't have a blood stool.
Anesthesia people, they just look at the surgeon's time. If the surgeon is doing it very fast, they say, I don't know, but they give the just.
We hardly give them blood actually.
Yes.
It depends on the bipolar, availability of the bipolar.
Yes. And hardly any blood is supposed it will be difficult for it to get the blood.
And especially, I would say, in Nova Medical College, we don't have a blood bank, so it has to be brought from the civil hospital. So better keep it.
And you are very right that before doing a single, doing an independent, you should be at least 30 cases you should be as an assistant.
Because in your first few cases,
now all the medical colleges, PGs are very lucky that all doctors are doing, all BS are doing the thyroid surgery. So they are getting the opportunity. By the third year of time, they are at least doing 3 or 4 cases by themselves. So that is what I have to say.
Thank you, Dr. Bandita. I think very concisely put, summarized very nicely. Just a few comments. Thyroid function test. Now, most people agree that as the present thing is that the thyroid function test, the first thing you do is do a thyroid stimulating hormone level test. If that is normal, then you can do the T3, T4, unless there is some other things that you are suspecting. Unless you are suspecting dysfunction of the thyroid. Then about Hashimoto's thyroiditis, actually if you can keep the TSH level okay, then it's fine. The other thing what we should do is get the thyroid antibodies level 3. Because if the antibody level is high, then there is another risk factor for
Moreover, it is better than 2, and it is autoimmune thyroid.
Yes.
Then the one you described about the lateral lymph node metastasis. Now this was probably what earlier was known as the lateral aberrant thyroid. Because in the older textbooks you will find that mentioned as lateral aberrant thyroid. That is probably what refers to this particular kind of.
But the histopathology report said it's a metastasis to the liver.
Yeah, metastasis. The lateral aberrant thyroid, they used to harbor pulmonary cancer. Then blood transfusion, Dr. Kapilon Sharma has also mentioned. Actually, the thing about blood transfusion, the fear of probably requiring blood transfusion is because in olden days, during our time when we started off in ENT, blood transfusion used to be quite frequently required. Because those days the kind of thyroid surgeries which were carried out was quite different. They were generally big thyroids and hyperdynamic circulation, of course, they reduced it by treating the patient with potassium iodide and propranolol 2 weeks prior to surgery to reduce the vascularity. So that would reduce the vascularity to some extent. But then still, they used to operate without the help of any diathermy or any such thing, without diathermy. And they used to do a subtotal thyroidectomy where they used to slice the thyroid off, and then the residual thyroid had some bleeding. Even though they had a technique of quickly stitching up the residual thyroid.
Really sorry, I was going so fast.
Yeah.
Just let me interrupt. I just skipped this slide. So the Graves' disease is another thing. So if it's a multinodular vertebrate thyrotoxicosis, actually we got a patient that was long back when our teacher, respected Dilip Burwa sir, was there. So endocrinologists referred this patient to ENT because they could not control the thyrotoxic state of the patient. So they said that you do a surgery and only then they could do, they did, but then we had to do a subtotal thyroidectomy. Sir, I was a registrar then, sir did a subtotal thyroidectomy and the patient was fine. There are cases where the patient may have thyroid storm or
actually, even now, we have done a couple of cases also, but in our case now, nowadays we are more inclined to do a total thyroidectomy rather than that, put the patient on thyroid replacement. Then about the recurrent hernia, the thyroid surgery nowadays, you see, instead of being a purely thyroid surgery, it is now surgery of the recurrent hernia, the parathyroid gland, and the external branch of the secondary hernia. So these are the things which matter because these will help to preserve the quality of life of these patients if you preserve these structures.
So, any more questions from the audience?
After hemithyroidectomy in capillary carcinoma, is there any chance of recurrence from the thyroid vein on the same side? If there is recurrence from the thyroid vein itself after hemithyroidectomy, actually what are the causes we have to rule out?
If it has gone to the bed, I think we need to do a total thyroidectomy.
I guess that is
If
true.
it is not extracapsular, then
Why it has been occurred?
You are talking about thyroidectomy for carcinoma thyroid or for
Actually, he is asking a question. The low risk thyroid, young age, less than 40, that is the patient on hemithyroid. Yes or no?
Actually, from the thyroid vein itself, after hemithyroidectomy, in the case of capillary carcinoma.
Actually, the
very reason for doing a hemithyroidectomy is that the chance of recurrence of malignancy is very, very low, almost negligible. And it has definite indications for doing a it has to be unilocular and strictly confined to one side of the thyroid. Then only you do the and without any bad prognostic factors.
I think what I could understand by Aguila's question is that at some point of time, if your resection goes extracapsular, so you are supposed to take out the capsule and all that, and during your resection point, by doing some cautery or anything, in case it has gone extracapsular at any point and you were inadvertently left some tissue there may be some recurrence. That's very unusual, but you are taking it in total. And when the question of fibrosis came, with due respect to this one, so what I always remember him telling that if you are removing the hemithyroidectomy, the bleeding from the thyroid should not occur. The remaining part, you should secure it properly because no amount of pressure, no amount of cautery, or no amount of thing is going to stop that bleeding. It will continue to bleed. And sir was very, very careful. He taught us very nicely how to secure the tissue.
Another thing about your asking about the chance of recurrence. Actually, these cases we always postoperatively keep the patient's thyroid stimulating hormone at a low level. Low level is within the normal range or towards the lower end of the lower side of the bone. Because if the case is high, then that's another restriction for
Thank you, Dr. Rubandita Sarma, for your valuable insight. Now, moving on to our next recent part, I request Dr. Anjali Barua ma'am to please come forward. Anjali ma'am, please come forward. I request Dr. Anjali ma'am to now I
So it is a long journey of about say 40 years of journey, and he has passed out from Guwahati Medical College and a fellow American Academy of Otolaryngology, the proprietor of Rohua Nursing Home Nalbari, the most renowned private hospital, founder and director of the first private cancer hospital, Northeast Cancer Hospital, Durabad, and founder of managing director, Navadip Hospital with a new venture from his side, and experience and area of interest, oncology, rhinology, head and neck cancer, community ENT scenario, and service, and 45 years of clinical experience in different hospitals. And he has got lots of honors and achievements, like presented papers at SARC conference in Kathmandu, Colombo, and Bangkok. Presented paper at the European ENT Congress in Spain, editor of NEBAOICON Journal for 2 years, chairman of NEBAOICON Journal for 2 years, past president of NEBAOICON in 2019, published 2 Assamese poem books, he's a poet also, and published the only history book of NEBAOICON, Walking Down the Memory Lane. It's a really, it is a important document for NEBAOICON, and received the Best Rural Service Award from IMA. I think you have, you did not mention that your Nalbari branch was adjusted the best branch by AOI. We have got lots of achievement, and with these words, I would like to invite Dr. P.M. Murwa sir. Please give your interesting topic.
Respected chairpersons, thank you very much for your kind words about me. Since last evening, you have received 18 talks, all scientific. So, I want to divert the talk from scientific to non-scientific. My talk is basically financial talk. The previous talks are also very interesting. Our all learners, professors, our speakers, they give the talks. But I doubt that my talk will be interesting to you, because these financial talks are very boring. Still, I will try my best to make it very interesting. At the very beginning, I'd like to ask the August House 5 important questions. Please listen very carefully. Question number 1. Do you like to purchase joining NT Hospital of Jaipur from Dr. Satish? And third question. Second question. Do you like to purchase this Mercedes Benz, cost of which is more than 2 crores? Third question. Do you like to spend your honeymoon or holiday at Chennai? Yes. Fourth question. Do you like to send your child for higher study to Oxford University? And last question. When you become old, you would like to enjoy your retired life near Jalsa, as Amitabh Bachchan and Aishwarya Rai as your close neighbors. If the answer of these all 5 questions are yes, the next 10 minutes you have to listen to my talk very, very carefully. Without closing your eyes, without making any noise, please listen to the talk. Respected chairpersons, though I am a ENT specialist by profession, but I don't hesitate to tell you that I have enough knowledge of tax computations and accountancy. Well, I was PG student at Guwahati Medical College from 76 to 79. I have training of chartered accountancy under Mr. M.L. Sharma. He was that time #1 chartered accountant of Northeastern India. So, sir, whatever I will be telling here, it is not a theoretical talk. It is purely a practical talk. Practical in the sense that I have my practice of last 46 years. I have constructed about 5 hospitals. So I will give you whatever I will take here. I will give you all the talks from my personal experience. So I come to the topic proper. What is tax? Income tax is a tax charged by the central government on the annual income of individual or business house earned in a financial year. This is income tax. How it is calculated? We have two heads. One is the source of revenue. That means whatever we earn, this is the source of revenue. And other is the source of expenditure, whatever we spend, A to Z. So when you subtract expenditure from the revenue rate, that is your total income. Revenue minus expenditure is equal to total income. A specialist from where he gets the revenue. You know everything, but just I am telling you, we get revenue from our clinical practice, OPD, indoor consultations, fees from the private practice and hospital visits, surgical free from procedures, so that means different operations. Usually it to be maximum from this. Institutional revenue, hospital attachment fee. A doctor is attached to a hospital, the hospital gives him the honorarium, but give one attachment fee for his attachment to that hospital. Retainer payment from the medical institutions, income from the diagnostic procedures such as audiometry, endoscopy, laryngoscopy, etc. Additional revenue. Revenue from the medical property or equipment leasing. If a doctor, healthy doctor, he is another property, medical property, he may lease it. And from the leasing, he might get the additional revenue. Honorarium from the medical camps, webinars, guest lecture, and medical education programs. These are some common heads from where we get the receipt. The expenditure list is very, I won't go into details, such as salary, advertisement, electricity, generator running, computer expenses, all expenses, staff salary, everything is there. So how it is computed? This is the computation sheet of income tax sheet of Dr. Gautam Bola of Jola, not our function. For the year 2023-24, his revenue is 1 crore 40 lakhs. 1 crore 40 lakhs. His expenditure is 25 lakhs. So total net income is 1 crore 15 lakhs. There are some deductions. I come a bit little later. Deductions. Dr. Gautam, he receives 15 lakhs as deduction. So his taxable income becomes 1 crore. There are some slabs. Up to 3 lakhs, you don't have to pay single paisa tax. After 15 lakhs, you have to pay 30% tax. As his limit is 1 crore, so he falls under the category of 30%. That means he has to pay 30 lakhs as income tax. There are two regimes. I will go in short because it is useful for our ENT doctors. One is the new regime and another is the old regime. Most probably you know everything, but I just want to say little points about it. New regime is 4488, and old regime is old regime. What is new regime? When the turnover of a ENT doctor is below 75 lakhs independently, that means, suppose my son Rohan is earning, if his income is below 75 lakhs, then he has to pay under new regime 4488. Here, 50% of the receipt is presumed as tax. Suppose the doctor gets 60 lakhs. Then here in new regime, out of the 60 lakhs, 30 lakhs has been presumed as income. So income tax will come from the 30 lakhs. What are the benefits? No book of accounts required. It is very important because we don't have time to maintain book of accounts. ITR filing is very simple, just you have to fill a single page, form number 4. No audit required. Audit is very harassing. I do run hospitals, nursing homes. Audit people, they harass us like anything. So here no audit. You don't have to approach CA, Chartered Account. Only disadvantage is there. From this new scheme, there is no deduction. You can't avail any deduction. Old regime, if the turnover is over 75 lakhs, as in Dr. Gautam Barua of Jorhat, 1 lakhs 40, 140 lakhs, so he will come under the PV of the old regime. Here advantages are there are deductions. I will come in very quickly later. State level subsidies are there. Rural practice incentives are there. And most important, I say thrice, most important, Northeast Industrial Development schemes are available for our doctors, for our ENT specialists. Under HTC investment, if you invest in life insurance, public provident fund, equity linked scheme, personal pension scheme, all of you are investing. So you ask your CA to deduct 1.5 lakhs in one financial year by investing in these schemes. Next, all of us, we do personal health insurance policy. Maximum 90% of us do. If you invest in the medical insurance, then for self and family, we get discount up to 25,000 per annum. For our parents, additional discount of 25,000. For senior citizens like Buddhist, Amit, myself, Mukherjee, SB, we get additional discount of 25,000, that is 50,000. And for health checkup, if you go to Apollo, we go Apollo health checkup, and we can claim another deduction of 5,000 rupees. We can have additional deductions. If you invest, or if you not invest, if you give donations to the PM and CF relief fund, then you will get 100% deduction. And if you give donations to the private charities recognized by the government of India, then you will get 50%. In the first quarter, 3 years back, I donated to the CM fund 3 lakhs rupees. So on that year, both 3 lakhs was deducted from my tax. Second is, 2 months back, I started one new hospital at Nalbari Hospital. For their blood bank, I have donated 15 lakhs rupees. So this time from 15 lakhs, I won't get deduction of 15 lakhs. I will get deduction 50%, that is 7.5 lakhs in next balance. Additional deductions, interest on home loans. Most of you are having home loans, so you can claim up to 2 lakhs in 1 year. depreciation of your medical equipment, 15%. Medical conference expenses, most of us go. You are coming here to Mohammed also. So you bring the papers and submit to your CA. Then you can claim up to, you can claim deduction on this medical conference. Of course, it must have proper documentations. For critical illnesses also you get deductions. Region specific benefit. This is very important, mainly for our ENT doctors, health type doctors living in Mizoram, Nagaland, Meghalaya. They can claim up to 100% income tax benefit. So see, they don't have any income tax. Additional deduction up to 20% available for ENT doctors serving in the dedicated rural areas. This is very important. Northeast Industrial Development Scheme. Sir, I am taking 2 minutes because very important for our junior PG students. Tax benefit for ENT surgeons investing in medical infrastructure, hospital, clinics, nursing home. There are some deductions. What are the deductions? State government give deduction 30% and the central government give deduction from 30 to 50%. These are my 3 hospitals. One is Northeast Cancer Hospital, Jorawat. Other is the Navadip, started last year. And other is the Northeast Super Specialty, which will be started from 2nd October this year. So, I don't hesitate to tell you that for Northeast, our hospital got subsidy of 6 crores. For Navadip, our sanction, 5 crores sanction. And for Northeast Super Specialists, we have applied for 8 crores. That means 19 crores. So, my PG students, if we have good ENT surgeon, along with the ENT surgeon, you become an entrepreneur. You start your own hospital clinic. There are different schemes. You apply and you get course and course of this. I think you need not pray. What you will get? Maximum 1 crore. That if you start nursing home hospitals, start different hospitals, then you can have course and course of this. Now, as time is short, I am answering few of the queries that usually our medical professions have. Very important queries because most of us don't know. First question is from a gentleman. Yes, gentleman. He is working in the hospital. Nursing home. I don't make the name. His query is, can you take commission from the hospital clinic? It is open secret. Most of the doctors, they take commission by sending a case for MRI, CT scan from the clinics. Whether you can take or not. Answer is yes. You have to show it as your professional member. The hospital will pay the amount after deducting TDS at the rate of 10%. Next question is from a Gateman. Can you receive any professional income without deducting TDS? In my hospitals, when they first deducted the TDS, the doctors are very annoyed. Why you are taking 10% our hard-earned money? But you have to. Hospital and medical institutions deduct TDS at the rate of 10% of payment exceeding rupees 30,000 made to the consulting ENT doctors. If TDS is not paid, what will happen? There is fine. What is the fine? TDS amount you have to pay plus tax on the TDS plus penalty of TDS which may run up to 100 to 300%. Very huge fine. And it is applicable not only for the doctors but for the hospital also. There is third query from one gentleman. big boss. He has asked me, if any pharmaceutical company sponsor your foreign trip, can you accept it? No. Company has to transfer that amount into your bank account, deducting the TDS. They will show that as their business promotion account. Then only you can take this foreign trip. Otherwise, you will be put on jail. I can remember 5 years back, I said that Rohan had been to Spain to give a lecture at Spain. That at that time, 15 doctors were arrested at the time because they had been sponsored by our pharmaceutical company. Sorry. This is a good question from a man who is always associated with CME scientific talk. I salute him. His question is, if any pharmaceutical company sponsor your scientific talk, CME, can you accept it? Yes. You have to be a speaker. You could take your wife to a conference, and then you will get the amount. After deducting the TDS, you have to submit the full proof and documents. This is from another man who is always associated with our association, whether association can accept donations for CME conference, etc. Answer is yes. The association must have their own PAN card and they have to deduct TDS. From a beautiful lady with students' knowledge, I question whether the stipend is tax-free. For UG undergraduate, it is called scholarship, it is tax-free. But for our PG students, it is not tax-free. It is considered as professional. Whether ENT doctor have to pay GST? No. But if he or she runs a hospital, then he has to pay GST on his hospital goods. Last query from a topman. If you don't pay your income tax fairly and regularly, what will happen? Number one, demand notice. Income tax department will give you demand notice. If you don't respond, they will come to your police, do a survey, you will fix your tax plus interest plus penalty. Then also if you don't respond, next step is income tax rate. This is a picture of income tax rate. Government will seize your property, as it does in case of Vijayanagar. They may issue warrant, they may issue warrant, they may seize your passport. And then also if you don't pay your taxes, what the government can do? It was done in case of a ENT doctor from my area. Notice was served, raid was done, he didn't respond. Then income tax raid was done, 1 crore was seen from the toilet of his, from the Google of his toilet. Passport was seized. Everything was done, but he did not respond. Ultimately, he has been put on jail. Respected chairpersons, I started the talks with 5 important questions. Do you like to? I started the talk with 5 questions. Do you like to purchase join NT hospital? Like a citizen, spend your honeymoon or holiday at Switzerland, your side to Oxford and spend your leisure life to campus. If you have listened to my talk carefully, and I have seen that really you have listened to my talk carefully, then I am oversure that one day, if not today, you will be able to purchase join NT hospital from Dr. Satish. You will be kind. Then
we'll be able to purchase this Mercedes Benz cost of which is too cold. Send your holiday or honeymoon in Sri Lanka. Send your child to Oxford University, and when you become old like us, you will be able to spend your retired life along near at Mumbai in Jalsa as a video person as you play. So, thank you very much. Boy, thank you very much, because I have seen that you have listened to my talk. I am sorry that I have exceeded by 4-5 minutes. Please excuse for that. Thank you.
As always, I predicted that it will be interesting, and it is very interesting. And Surajit missed it. He has taken the photograph. And so
Did you like it? I will talk a little bit about these pictures. You can see these pictures from yesterday. No? These pictures we used to see, we used to enjoy the Suknani Uzapali. The Suknani Uzapali is a feministic dance form done mainly from the area of Islam. So this Suknani Uzapali is basically a male domain, but there is an EFG relation because the female domain comes from my place of Patsala, and there is a lady, this is a doctor and related to us. She is a daughter of our Guru, Bhubaneswar Das, this Rupa Mudra Das. She is one of the Guru of this Suknani Uzapali, and another is my friend Piku Muni Chaudhary. They spread these cultures not only in Assam, in outside Assam also. So you know that Dharam is having a lot of history, like Suknani Uzapali. There is a history of Dhol Badan, that is called Hepadhul. The uniqueness of this Hepadhul is, this dhul is play with putting water inside it, and this gives a beautiful music. You know, the history of Dharam. When the Mughal came to fight here, the Lasit Barpukal comes from home, and this fight can be prevented by the Lasit Barpukal only by the peoples from Dharam armies. So this Dharam is having a very great history, and we should know, and because this Suknani Uzapali really I enjoy. Now I'll start my sessions on surgical roadmap. Before starting, I want to introduce our panelists. Next.
Just one or two lines.
Professor Kumkum Bora. She is my juniors. Now she is working as a professor. He is working at our new medical college, Sankarama Medical College, and professor at ENT. His project is next is Dr. Arup Sharma. He is working as a associate professor and Department of ENT, Tesco Medical College. Very good ENT surgeon. Not only ENT, he is a very good gentleman also. Dr. Arup Kaboti is working in Dhubri Medical College. Recently transferred from Guwahati Medical College in the same status in assistant professor. Very good ENT surgeon, basic ENT as well as in otology surgery. Abhinisa Goswami is nothing but daughter of our professor S.C. Goswami sir. She is working with me in Nalbari Medical College and registers. She is leader MBBS and MS from Guwahati Medical College and training fellowship also in ENT otology. And Naman Dasgupta, practitioners at Borfedado, and he is always busy with lots of ENT cases.
So with this panelist and with your help, I am going to start basic things, the surgical roadmap in chronic suppurative otitis media. We will give stress on timing, technique and troubleshooting. So I'll put two pictures in the monitors. On the left, there's a central purpose with a little bit of tympanostatic facts. And you can see the fibrotic mucosa and the things, it's dry ears. And the opposite side, there is a central perforations, and you can see a little bit of envelope medius, and then there is a discharge. Now question is, what are your criteria for decide the optimal timing for surgery in inactive, in this case left side, and active chronic otitis media? So I like to put the questions to the junior most or the service.
Thank you, sir. Sir, in both the cases, you've given a picture of inactive as well as an active otitis media. So first I'll address the inactive part. So we'll first do an assessment by the tympanometric findings, where we'll be assessing both the audiometry as well as the impedance or impedance testing. And based on that, if we see that the hearing is quite stable and it is of a mild variety, in this particular case, we can just defer the surgery for now. But if the patient wants to do it, then we have to take the patient's opinions into the case and we have to go for a tympanoplasty or a myeloplasty since it's an inactive case. And sir, coming to the active case, sir, since there I can see there is discharge there, we'll go for a medical treatment at first, especially by giving topical antibiotic drops as well as steroid drops. Or we can also give a course of antibiotics, systemic. And we'll wait for the ear to be dry, because we always prefer to operate on a dry ear. Because in dry ear, we always have less chances of post-operative infections. So that is
do you have any timing regarding surgery in dry ears and the discharging ear?
Sir, for the discharging ear, sir, if it is a mild discharge, so in these cases we have a fixed protocol. Like what we do, we give for 3 days, we give a course of injectable antibiotics, steroids, and ear drop. Just 3 days prior to the surgery in all cases. If the discharge is mild, if it is not profuse. Here in this case, I think this is a mild discharge. If the ear is dry, then we can take up the surgery.
So I think for a dry and a stable ear, in a dry perforation, I will wait for 2 to 4 weeks and then do the surgery. First case, I don't think we can go for a tympanometry because there is an operation there. And the second case, with the use of antibiotics, as soon as the infection is controlled, we can go for surgery. But after antibiotics, if the infection, even if it is not controlled, and we get some warning signs of complications, then I think we have to think that. But again, saying these timings are 2 to 4 weeks immediate, these are very arbitrary. I think the main thing which nowadays decide whether going for the surgery or not is the condition of the middle ear mucosa. If the mucosa is dry, I think we can go for a surgery. If it is wet, means somewhere in the aeration pathway there is a block, and we may need to combine that with an injection along with tympanoplasty.
No, regarding timing.
Regarding timings, sir, for a dry and stable ear, I will wait for 2 to 4 weeks time and then do the surgery. And for a wet ear, after a course of antibiotics, if it becomes dry, we will go for the surgery. But if it doesn't become dry and there are some warning signs for any complications occurring, then I will adjust.
We think that is for a purpose. So we think that is discharging as a contraindication for surgery.
Yeah, most times we have correlated. If it is already little mild, minimal mucoid discharge may go with the surgery. But it's in this picture, it's reflecting mucocorrelated definitely it looks infected. So it needs to be treated as antibiotic for
but it looks like it is glucosal rigid only. Then you can expect it to get dry up in the course of the radical release study. Then you can timing after it dries up also. We wait better to give us 4 to 6 weeks time for a better result.
Is a mucosal variety. So
no, one is central corruption dry, another is weight.
or weight.
Is there any timing?
Or weight we have to treat the infection with proper antibiotic for this, and we have to treat for at least 4 to 6 weeks time to be dry, and we can dry.
According to the literature, in a dry year, central corruption, there is no timing. You can operate at any time. Even if it is discharging year, you can operate. Only the problem is, in case of discharging year, there is no discharge of infection, nothing else. And in view of the mucosa, it is a dry mucosa. The take care of the graft may be a little bit of compromise.
Yes, sir.
That is my opinion.
Yes.
So this is safety. So nowadays this diabetes and immune compromise is very common. So if the person is having diabetes and immune compromise, so how do you modify your timing of compromise?
During the immunosuppressed patient is always makes it difficult because there is both sides damage. One is delay also. The patient is more likely to go for complications of that. So it depends on the basically hearing status. If diabetes doesn't give the associated SN loss and severe hearing loss, and if ear is dry, then it can be.
That means you have to control the diabetic status of the patient. If it is uncontrolled diabetes, there is a risk of doing surgery because it may cause an infections.
Depending on this, there is other indications that are so slow in this patients.
You have to control the first, you have to control the blood sugar level. But you have to ensure the risk of the disease accordingly. So if it is a onset variety or if it is a proceeding to complications, then you have to do the surgery with proper control of the blood sugar level through endocrinologist.
Yes, if there is any chance of complications like intermittent complications, and if it is burden surgery, you have to do it, and you can control sugars with the help of endocrinologist by insulin or insulins.
So another thing I would like to add is most of the people who have comorbidity on medications. So there are certain medications which we need to stop before we proceed to surgery. For example, for the diabetes patient who is on metformin, we have to stop metformin 40 hours prior to the patient. So that also plays a part in delaying our surgery.
Why metformin is stop?
So metformin is stopped because some of the pathway that it works on. It works on the liver pathways, where most of the general anesthesia drugs that we give are liver, they are excreted by the liver and mechanism. So that is one of the reasons.
Then what are other
So instead of metformin, sir, we can go for trimethyl.
That means those medications affect the livers. The anesthetic medication also may affect the livers, and that may be compromised. So it is better to stop metformin before doing surgery.
Actually converted to insulin, already said as well. To monitor the patient is most important. To monitor the patient, not what else.
Yes, sir, same thing. The diabetic level should come down, and we prefer the post PP level to come down under 200, and fasting level around 140. and the HbA1c between 5 to 6 is good.
To control the sugar level,
Yes.
then you can go for surgery. But if there is any urgency,
Then we can go for surgery, but with insulin, sir, and with proper guidance of the endocrinologist.
so the same person already mentions that before doing surgery, you should convert glycemic index to insulin, so that you can nicely control before any surgery.
Sir, I agree with the other panelists. In normal cases, I will go for optimal control of the symptoms and all. In impending complications, we will modify the perioperative setup with antibiotics and proper monitoring.
In this slide, can I ask one question?
Yes, yes.
So when we were discussing about the controlling of the diabetes, means diabetes can be controlled in 2 hours with insulin. So should I take the patient or it should be controlled for 48 hours or 5 days or 7 days? Is there any criteria?
I don't know that things. I will take opinion from the endocrinologist. And if urgently required, we will make sugar down and we will definitely okay.
That you can get from HbA1c. 3 months glycemic control from the HbA1c. You have the idea.
3 months control,
That
HbA1c will come down after 1 month.
Convert to insulin nicely, then do the big
Urgency, emergency, you can because if there is a say intracranial complication, many not that is extra. Least intracranial other complications. You need surgery immediately. You control the sugars and you do surgery.
Yes.
So what I actually see with the endocrinology people doing is they give the insulin, regular insulin and lactose also, and they used to strictly monitor actually. So slowly they used to reduce the the units, and if the blood sugar shoots up, then again they used to increase. Then slowly they will convert the insulin into oral.
And regarding this diabetes and failure to do surgery,
Because we are all diabetic.
in situations, we had situations where there was a cerebral abscess, and the sugar was also not getting controlled. Then the diabetologist told us that you have to go for the risk, you have to go for the surgery, because unless you take out that pus, the sugar
Yes,
is
that
not
infection we have to control and sugar coming
Yes.
So these are some situations like that.
So
When
we have to take a
when there is active infections, the sugar will come down. So you have to take risk, you have to reward the infections, then you can go for it. The sugar will be controlled and patient will be healthy. So how do you time surgery? Whether it is right or left ear, but there is no there is no barriers.
If it is posterior, I have a comment, it is posterior, then it's a technical case.
So if you repeat
When the graft is called small
so repeat immunoplasty is probably sufficient. But if you get you go for expensive massive.
It is always
How do you handle intraoperative bleeding from sigmoid sinus breathing surgery? Because it is happening to us when I have a hammer. You can hammer, no? Yes. When you use a scissor and hammer, it is happening to us also. But how do you control? How do you manage the case of bleeding from the sigmoid sinus? What is the
Sir, in most of the cases, sir, we apply pressure, sir, and I pack the cavity and I leave the patient, I go back and then I come back after 10-15 minutes, then I remove the pack and in most of the cases, the bleeding stops, so by packing on. So in some cases, we use Surgicel and I have used this bone wax, sir. So this is the maximum thing I have to do, sir.
Trabecular or PCB? What is the risk?
I am talking about
That's
the
big
sigmoid.
tear. That's a big tear.
No, sir, I am talking about sigmoid.
The question is on both sides. One is sigmoid sinus and one is tubular.
Tubular valve are not fixed until now. Pressure is also
try to put us in air policy. So first we'll put our finger on the hole.
Yes, the risk is the air embolism. There is a negative pressure. If there is a big tear, there is chance of air embolism. And then you can do manipulations. You can put your fingers, you can stop bleedings, and you can prevent air embolisms. Then you manipulate the air, getting it down, repair it. So bleeding from the sigmoid sinus or bleeding from the jugular vein, it depends on the amount of injury, amount of bleeding. So bone bleeding usually we do, but we do a diamond bar without irrigation, so we can control. And in some cases, bleeding from the sinuses, we can give support with the help of the bone wax. In case of cochlear implantation, there is a bleeding now, so we put some bone wax and you can control bleedings. But this jugular valve is different because of chance of air embolisms. And sinus, of course, you can pack it. You put some surgical serum and you can cottonide also, and you complete the procedures. Then you remove the cottonide, you pack the cavity, and you can control. So this is last slide. The identify the anomaly and the site. What will be your surgical approaches?
Sir, this is a case showing a corner septum on the left side. Left side, sir. So in this my approach, sir, I will have to take extra precaution while doing the drilling because I might inadvertently think that the corner septum has reached the end.
There is only corner septum. Basically, this is a post-operative case. This case was operated by one of our juniors. And before doing mastoids, that patient was operated for face, sinuses, and the tonsils. And after the mastoid surgery, this is post-operative pictures, this corner septums. Mastoid surgery facility with surgery here. The patients come to me. I see the pictures, CT, and I got that corner septums. And if you go deep to the corner septum, there is a soft tissue obesity. The disease is beyond the soft tissue obesity. The surgeon failed to identify the corner septums, and he opened up the superficial things. He could go to the mastoid and try to clear the disease. So this corner septums is an incidental diagnosis for me, but probably to diagnose such type of abnormalities, we have to go for CT scan in case of any ear surgery. That is important.
The other side of the book,
no, one side.
Right side is there.
No,
left side also similar to some side.
No. On the left side there is a complete corner septum. You cannot identify the mastoid entrance. When I did the surgery, I just got two or one cells at the junction of the corner septum to the dura. I thought that I just punctured your lateral sensory veins when I did the surgery because I am also confused. And when I put the suction there, I saw that the contents in the canals is come out, and I am sure that this is the way which way I have to proceed. And I removed the corner septums, and there is a cholesterol granulation. I removed it, and I complete the surgery. I had surgery. So this is important. Identification of the corner septums during surgery, whether it is complete or partial. Sometimes it's partial also. And in this case, this is complete corner septum. So with this little bit of discussions with our panelists and with the help of the audience also, I conclude my panel discussion on autonomy.
Dr. Arjun May I request Dr.
Sir.
I request Dr. Utpal sir to felicitate Dr. Vilasha Goswami ma'am.
And second is the junior consultant, and lastly the seniors. They will raise the hand within 5 seconds. They have to answer, but they cannot. Eyes will be observed. They cannot look downwards. If they have said GPT or Google, then we answer after 8 seconds. The question will pass on. And this is the picture open quiz.
All the questions come from here.
Come to the front. Come to the front.
All the questions please come from.
Come first. Okay. Be smart. And you make answer also smart. There are many. So, see, quiz master decision is the final. And you can answer any 2 or 3, but there is sufficient maybe. Again, you have to raise the hand first. First the juniors, then your junior consultant, then the seniors. If you ask them first basis, you will raise the hand, but you have to be confident. Within 5 seconds, you will answer. And don't, your mobile is not there, you know. But don't put a search GPT or Google and anything. But you need a deep seek also. Google observe. First question comes here. Name the second grade girl. Who raised that? Raise the hand. Who should turn? Okay, come here. From the school. Woman or someone. Name the second grade girl also. Huh? There. Material. Higher to material.
Second grade.
The second grade girl also. No. You're wrong. Second. Let me do what last day. Higher the latest calculate, but in the higher. But the post-thematic and pre-thematic branch, can you answer? What is post-thematic and pre-thematic? Answer first, anything. What is the post-thematic branch? Make fast, do it.
Sir, it's the branch from the next branchial arch. It provides a.
No, it's okay. Only name them. What is the post-thematic branch of the higher arch? Second arch.
Second arch, sir, post-thematic branch will be.
Right. Then let's go to the next. Full answer. Yes. People. No. Wrong. What is the branch? What's your name? No, you're second year PGT or first year? Low between critical model. First. I'll come to second question. Oh, sorry. Hey, go for another consultant. Give me the answer. Therefore, not answer. Second question. What is Jacobson now?
Make it
fast. And what operation is done on it and which condition? What operation is done in which condition? The operation done on commonly is a tympanic neurectomy. And for which condition? That's one condition, and there are three conditions. Only one condition you take.
Yes.
Have you heard what? The junior consultant? Mukherjee will not answer.
You will answer.
No junior consultants.
Hey, don't answer. You said what? When answer? Depending direct from me. It's fresh syndrome. On fresh syndrome, or recently there is a webinar of, you have not seen the NEBAOICON webinar. Paradigm was presented by whom? They have not seen the webinar. There this question was asked. There someone asked the packing of the parotid fistula. In parotid fistula also, this operation can be done to reduce the secretion of the parasympathetic. I am not going to detail. Third question, perspective. How many ampoules, see, very interesting, vestibular people have gone. How many ampoules is there in semicircular canal? Raise your hand and tell. How many ampoules? Huh? 3 ampoules. Yes. How many openings in semicircular canal in the vestibule? 5 openings, yes. This question, if you answer, I will give you 5 books. How many total openings in the vestibule? Can you answer? Vestibule, how many total openings? 5 openings from the semicircular canal, another 2 or 5 or 3, 4. 7 openings, very good. Oh, 3 books. Because see, step is your overland is another and vestibular aqueduct. Vestibular aqueduct is another thing. But cochlea aqueduct and round window is not to the vestibule. It is in the cochlea. There are some people say it is 9 openings, but not 9, it is 7. You are very correct. Very good.
Book before half.
Book. Can you read what is the knots? I am giving you. What is the knots? Any bone conduction or air conduction? Why it occurs in 2000 frequency? How many bone conduction passes there? 1, 2, 3, 4. There is 4 actually. Even CSF also passes bone conduction. But how? Why Carhartt does occur? That if you get into a 2000 frequency, then who can answer? No. Actually, peculiar distance. The ossicular osteosis, it is a osteoplasty remodeling of this thing. But in particular 2000 frequency, there is resonance impedance. One says you are correct, brother. There is a deep. People think that this deep of bone conduction is a SL loss, but it is not SL loss. It is conduct. How can you prove that it is a conductive loss? Carhartt loss. After step operation, many Carhartt loss is corrected. They prove that it is a bone conduction, not a SL. Any prize winner?
So you will get a book.
Book, yes. What is tennis in thyroid cancer? I went to cancer in thyroid. In junior student of senior will tell. Not to do some.
Anyone?
Tennis. But tennis no. You know both busy. Thyroid globin elimination, TE, and negative iodine scanning or negative isotope scanning. Why it occurs? When you go for ablation or your isotope scanning, it will not occur. Why? Thyroid globin is elevated. There will be some residual, some cancer is there. But you get a negative scanning. There is dedifferentiation of the cells. There is what is importer? Mukherjee? Iodine importer is being reduced. They are very, it is common question. Answer.
Very common.
No questions.
What can?
What scan is there? Okay, we go to it. What is this thing? This is by Vishwajit Gogol's the microscopic thyroid. This is I am telling you, this is left recurrent laryngeal nerve. See, all the blood vessels are also same. They are, and which recurrent laryngeal nerve is more prone for injury? Right or left? Left. Why? And non-recurrent? Okay, non-recurrent angel now?
So there is hydrotherapy, non-hydrotherapy.
This is the parathyroid. This is parathyroid, this is recurrent. Another tubercle is there in the thyroid. What is the name of the tubercle? Yoga Kendall is a pathologist or anatomist? Anatomist, very good. Then what is the cause of the non-recurrent? 0.1 to 1% non-recurrent? If the answer, you will get 3 books. No. Why non-recurrent occurs? Because there is a right recurrent is the branch of the right subclavian artery. If there is no right subclavian artery, it originates from the aortic artery. Then you have mentioned dysphagia or arterial lusoria. That goes the posterior ischemia. Then there will be non-recurrent. Most common the right side, but left side may occur. Can you answer where left side is occurred? Is hiatus inversus. Very nice. How many branches of the external? This is very common. You have to answer. How many branches are in the external carotid artery? How many branches?
10 branches.
10. Are you mean this one? 8 branches. Very nice. What are the branches from below upwards? Below upwards, ekdam serious from the spool.
First is the superior thyroid artery.
Yes. Then
facial artery.
facial artery. Ascending facial artery. Third. Facial, face not facial. And then? The junior consultant. Then Mukherjee they will. They do not know.
I will tell. Okay. But his superior thyroid. But from the back side comes
the left side
then comes lingual. Then
lingual. Ascending pharyngeal.
Ascending pharyngeal is there. Superior thyroid, ascending pharyngeal, lingual, facial, superficial temporal, and internal maxillary.
No. Zero. Occipital artery, then posterior, then internal maxillary and superficial temporal. There is no book. One book to him, yes. He got first prize in the poster also. Now raise your hand for this question. Can you, it is by Dr. Kudusam has given me this scan. Can you see there is a yellow mark? You see, this is the axial view, this is the coronal, this is the sagittal view. All have got a some white spot in the irradiant. What is this? Yes, good, what?
Silolithiasis.
Yes, very good, stone. Stone in the? What is the name of the other name of the submandibular duct? Extension. What is that? And why most common stones are there in the submandibular duct? Why common? Yes, one is anti-gravity. Number 2? No. Torsion. Secretion. The carotid it is a more cell. Here the mimoid cells and mucous component one more, then stone is more common. Then what is the treatment? What is the treatment? What is recidivism? Yesterday we discussed in cholesterol. What is recidivism? Recidivism by literally it is the prisoner comes up from the jail. He will by crime. The same crime he will take after coming out of the jail also. But that happens in cholesterol also. Then what type of cholesterol is? Recidivism means what? Don't know. Is it junior consultant or senior? Godam will not take. Mukherjee tell him. Go. Yes, tendency to recur. This is the residual or recurrent cholesterol. best imaging to detect the residual question mark, the best imaging. What am I? No. Yes, see diffusion with an MRI. Yes, sir. Book. DWMI. Very interesting. Is the first surgeon from Austria. From which place? He has come to Mumbai also for workshop. And who is the man behind? You tell? Heinz Sternberger. And he is known as the father of the face. Do you know anything about him? He, with the Kennedy and Carl Stoll, has devised the angle telescope, Hopkins telescope. He is a great man. He has expired recently. But name some famous face surgeon, and Vishwajit will not answer it. We like some very good people from Australia. Same some famous face surgeon from other countries. You know name one or two? You don't know? Huh? Senior people? You also know. You know, people. Huh? Hey, you have not heard. Peter Vishwajit will take answer. Vishwajit. From other countries. Richard Harvey is there from Australia. And there is Peter Wormwood from Australia. Nick Jones from South America. And Kennedy from USA. Kennedy is a very distinct face surgeon. But Harvey and Nick Jones are very mild, Japanese face surgeons.
Interesting tidbit. Chakrakandu was also from Graz.
Yes, he is also from Graz. Very nice. Chakrakandu, the tubercle Chakrakandu is a Graz, and this fellow is also from Graz. It's next. Name the neurotransmitter in migraine. You all girls are there. Common for migraine. Not the vestibular migraine or any migraine. Name, there are 7 neurotransmitters. You tell only 2 or 3 neurotransmitters in migraine. You have to know. One is serotonin. Serotonin, what is for serotonin? Yes, very nice. Serotonin and give one motto. Serotonin and there is line. Serotonin is for pleasure and dopamine is for what? Like this. So you know, see, neurokinin A, P substances, CGRP, calcitonin gene-related peptide. There is a molecule, anti-CGRP for migraine. And serotonin rightly say, now what is the medicine available? Triptane, somatriptane, zolmitriptane, all triptanes are for migraine. Why VM, vestibular migraine, is important for neurology and ENT? You have to know this answer. Very common for vertigo, because there is no headache, but vertigo will be there. Really interesting. You will get in ENT practice. You can, if you can cure means minimize a vestibular migraine, you are a good doctor. I am also a good doctor. I get many vestibular migraines. But all vertigo people have gone. Therefore, I am taking chance. This is the first CI surgeon in India. Anyone? This is the good one here.
First CI surgeon?
No boy. Sandra D'Souza from Mumbai is the old. And first CI surgeon in South India. He was son of the soil from Assam. Bodul Hazarika is named. And first laryngectomy done by whom? In what? Theodore Billor. Theodore Billor in 1873. And first laryngectomy done in Northeast. To do some present paper also. First laryngectomy in Northeast.
He's a famous person. Anyone?
Oh.
Famous personality.
Famous person. You are principal of Guwahati Medical College, principal of Dibrugarh Medical College, everywhere. When he was the chief, I know him. Good. Yeah. No. Give 2 books. Do you know the history of Suren Samsar? He was from Ambali, Guwahati. When he was the principal of Assam Medical College, when I read in Assam Medical College, then I heard that he was the principal HOD of the Assam Medical College. He had served at 8 a.m. in the department, and exactly at 9:30 p.m. he goes to the office. Same thing, all people are calling, all departments. He gives ground to all departments, surgery, medicine, everything. It's so much sleep. Very nice, but first there is still patients are there. What is this phenomenon? Is a branch of which actually? Huh? Yes. Is a continuation or a continuation of maxillary state? Why it is important in nasal cavity? Little area, posterior oblique. Now, why it is important in nasal cavity? For bleeding, one of its things. Another, the feeding vessel of a flap. What flap? Feeding vessel of a flap. I give me leading with. Can you name the other flap? I think very nice. Give it.
You already got the books.
Yeah, then okay. Name the space between superficial and deep lobe of the parotid. Yesterday, Jyotirmoy Fukan has not mentioned that, but I asked him. We have discussed this thing yesterday also. What is name the space? Can you tell?
Between superficial and deep lobe?
Of parotid? Yes, tell. Petis, that she knows. There is the facial-venous plane of petis. Because see, God has given the nerve above and brain below. In 88%, but other 12% who may get acid down, retromandibular vein. That's a very important thing. Yes, see again.
One more book.
One more book. Then rapid fire. How much fire? Bethesda used in what? Thyroid what? Oh, FFSG I give him. And but if you tell Bethesda is from which place? From India or England or USA or Australia? Bethesda place? It is from USA. Do you know that this is a? Okay, you don't know. And thyroid full form. If you get the thyroid, what is the full form of thyroid?
Thyroid imaging, reporting and data system.
Very good, very good. Where it is used?
It is used in USG reporting of ultrasound of thyroid swellings.
Yes. It comes from bilates. From breast carcinoma, it comes to thyroid, the thyroid gets by your American radiography, that is your radiology association. Hinge Plus, today you discussed heart attack of an. What is Hinge Plus? Hinge Plus, today in heart attack of seminar, it is been mentioned by Amjana Sama and everyone.
To differentiate between central and peripheral disease.
To tell? Yes. Yes.
What sort of
Desktop, yes, correct. Desktop is good deviation. And plus is a, you can be full.
The mic up. The mic up. Plus.
Yeah, lovely. No,
Plus is a hearing test.
Hearing test. You don't attend the, I think you have a poster presentation, that I don't know. Who is Clement Van Parkwell? I have mentioned in my allergy panel. Who is Clement Van Parkwell? Is he a ENT surgeon or head surgeon or what? She is from Austria, Vienna. Vienna is a pediatrician. She has coined the allergy in 1906. Okay, you don't know. Full form of EAACI. In the allergy panel I have told. EAACI. What is it? This is a very good guideline of allergy. European Association of Allergy and Clinical Immunology. Agriba has attended this EACI now in Europe. Hey, it is a general question for adults. Who is the captain of the Indian Test cricket team in 2025 in England? Yes, you did.
Shubman Gill.
Shubman Gill, not Suhit.
Shubman Gill.
Can you, if you can tell, give him 3 books. If you can, what is it? There they want test match cricket in Australia. It is been border Gavaskar. But what is the test match in England?
Tendulkar Anderson Trophy.
Ah, that's very good. Anderson Tendulkar Trophy. First name is Anderson. Anderson. It's a very good place for us. I think, thanks for being a part with us. And now Kuku will take over.
See, I will make it very fast. Fine, choose.
কি হয়েছে
আর ফুইজ আরো আছে তো আর ফুইজ কেস পেপার না বস্তা আছে 5 minutes okay can you name the scientist anyone yeah he is the first wait conclusion
Results.
who first said Bezos he said Bezos
What
it is fabric Bezos
Bezos? His name is Bezos, but in your ENT, what why it is Bezos?
you will get a book part of it okay now identify him and name the structure which is named after the scientist okay the structure is eustachian tube you name him what is his full name full name anyone? Yeah. Yes. That is Bartholomeus Eustachius. This is already finished. I will skip this. Okay. You don't have to wait. You don't have to identify the person. You identify the pathology. As is the first one. Fox 40. Okay, once we have attended all the lectures today, can click this. This is one of the best view for superior semicircular renal diseases.
Now today mission is tomorrow morning. He have not attended.
All who have attended all the lectures can give almost all the answers to my this.
Yes.
What is the view?
Hey, why? I have also told it.
Yes. It starts with, I give it starts with P.
P. Stanford is another view. It starts with P.
Not standard.
Not standard.
Because you. Yes.
Yes. Spelling is tough.
What?
Spelling is tough. Not P. P-O-O.
P-O then.
What will be?
Can you name him? She is the first one, yeah. Nathaniel Maimon, and it's mentioned. Him, identify him. And the surgery he was first to perform in larynx. Identify him. Repeated question. But still they can't identify him. Full name. Full name, name first full.
Who is? Doctor?
The surgery is laryngectomy.
I told you
full
now.
name of the person. What Billot?
I told you the full name. Theodore Billot. In 1873.
Yes.
Take the model. In 27th August, I think.
31st. Now the question is,
December.
now you name the anatomical structure which is named after him.
You know? Hinge.
They have to identify him. It's very common.
What is which polygraph? His name is used where? In throat, ear, nose? Don't know. Have you seen polygraph bag? Polygraph bag?
Everyone knows the Welder's ring, no? So his is Welder born Welder hearts. The Welder's ring.
First of all, simple and
These are very common things. Okay. Identify this image. What is this? Yes. It's used in nasal surgery. Anyone? It is put inside something that delivers something. Inside your body. It will deliver your steroids, mometasone furoate.
Mometasone furoate?
It is put inside the ethmoid sinuses nowadays. Sinus.
After that, you put that instrument and it will be there, mometasone.
No, it will release the mometasone.
Oh, it will release?
Inside the
Drug-eluting stent. Drug-eluting stent.
Okay, what is this syndrome? Yes. Exactly.
Yes.
Golden syndrome. Can you identify it? That's why who have attended all the lectures can identify these things.
Can you identify this?
It has been shown. Yes. No, the blue shirt first. He is the first one. Take the mic. Yeah. Yes, what is that?
Vivekananda has told me in the presentation.
Sir has given a pinpoint answer.
To the point answer.
So what?
Hypoglossal nerve stimulation in USA.
USA.
Yes. Very inspired too. It's a hypoglossal nerve stimulation. What is this? Identify this. The device. That's the salivary cup. It's a salivary cup. I think I'm almost finished. What is it used for?
What is it used for?
So for this picking of the saliva, it's a salivary cup that sticks.
Why do you want the saliva?
So for excessive salivation sometimes, so you put it there, so that will accumulate it there, and not have a drooling part. So can you identify the syndrome and the condition? It's very common. Then red ring. No. Who said Gradenigo first? I think Puravi said. Is it Gradenigo?
What is the part? Gradenigo, correct. What is the part? Spectrous part of it.
There is catrocyte is there. No?
Catrocyte.
So it will be the syndrome will be Gradenigo syndrome.
What are three things in Gradenigo syndrome? What nerve paralysis? Six nerve
See, there will be autodia, there will be what? Retrograde and diplopia.
Diplopia.
The 3 Ds.
3 Ds.
Okay. Identify the sign. Where it is seen. It's not a ear disease. No. I told it's not a ear at all.
Do you know? No. Then I put the motor to the wheel master.
It's logia sign and you find it bacillus skull fracture. Skull fracture. Logia sign. Okay. Radiological sign.
It was discussed yesterday in a panel.
See, all questions have been,
discussed the panel.
discussed. That's why everyone can easily say. It's kept in mind and it's kept in mind.
If your mind
Who
does-
said something related to salivary gland? Someone said something. Who said? Ranula, exactly. This is state sign. You have seen it. Plunging ranula. I think this is the last one. What is this?
This is the musical instrument.
Yeah, this is Dionysius. Sir, he is answering. Dionysius. Book to him, sir. Book to him. Have it quality. So thank you. I have to thank the whole organizing committee, Utpal Professor, very serious. Thank you, sir, for such a lovely, organized CME. Thank you, Samfil. Afazul, very serious. Thank you, Afazul, and the whole organizing team. Thank you so much, sir. Okay. There is a request for
poster, no?
Next year, sir,
This is your certificate and this is a cash from the organization.
Third prize, third.
আজি আমি থাকিম ন কি হয় ৰুম এটা হ'লে গাড়ী পঠিয়াই দিওঁ লাগিব
Dr. Deepsika Bhattacharya.
You are from which medical college? Agartala. It is private medical college, no? Government. Oh, the Biplab and Devlina.
And Udipta Talukdar.
Devlina gone.
Yes.
She told me.
Sanjay Kumar Pal.
কিমান টকা দিছিল 5,000.
We are deeply grateful to all esteemed members of NEBAOICON whose presence, encouragement and active participation
লাইটকেইটা জ্বলাই দিব লগা আছে মনছি লাইটকেইটা জ্বলাই দিয়ক
Ready, sir?
Sindhu